very warm welcome to the annual Oncology Summit 2025. So we'll start our proceedings for today. So for that, I would like to invite Mr. Khan, who is the cluster head for the oncology business.
We are present in not only in India, we are present in 70 countries, having 25,000 employees across the geographies. And as we speak, we clocked $3 billion of sales. That's a big milestone for Dr. Reddy's. In oncology space, as you entered in the corridor, you must have seen that the oncology, we have started way back 35 years with the presence of Dacotin. And we got first product Dacotin, then we got first biosimilar Reditux, and after that we keep launching the products and getting the benefit to the patient. If you look at it, the brands which are very cornerstone for us is Reditux, Harvicta, Versavo. As well as speakers, a very enriching, enlightening scientific discussion over the next 2 days. So thank you very much, and wishing all the best to everyone. Thank you.
Thank you, Mr. Feroz. Now I would like to invite Dr. Rohit Desai, who is the oncology cluster head for our medical department for Dr. Reddy's.
Good morning everyone. My name is Desai, and I'm not from Gujarat or Maharashtra, so I'm from Karnataka. So my name is Miss Reddy. I'm proud to represent the entire oncology medical affairs team, and on behalf of entire organization, including my sales and commercial team, provides us an opportunity to pause, reflect back on the key clinical developments, and see how they will be, what will be the implication of these key clinical developments in a clinical practice. One of the most important milestones for us has been the launch of the country, and I'm sure that we will have a lot of discussion about the new entrant, not just but also the molecules and how they would impact a clinical journey. So without further ado, we would like to start.
Thanks, Rohit. That looks to be a Stone Age picture of me. Anyway, I'm not from Dr. Reddy's, so for people who don't know me, that's who I am. Thanks anyway, Dr. Reddy's, for asking me to share this particular session. This first session is on breast cancer. As Rohit was rightly pointing out, the intention of this whole meeting is to reflect upon what happened the whole of last year. So the pattern is such that we will present some abstracts, and then we will have a panel discussion on these abstracts. The high point of the breast cancer session is also that we have two very eminent international faculty who will be addressing us and have also kindly agreed to be part of the panel. So I'm sure all of us will have plenty of questions to ask all of them and learn to our learn as much as possible and make use of the time that we are here. I know Goa is plenty of fun, but let's see how best we can also do a lot of academics in the meantime. So I will not waste any more time. Let me call upon Dr. P.N. Mahapatra, who will chair the first part of this breast cancer session, which is on, let's put it as non-HER2 positive breast cancer. The second session is on HER2 positive breast cancer. So Dr. Mahapatra will conduct the proceedings for the first half of this session. Thank you.
Thank you, Dr. Redis. It's a pleasure and to be in a chairing a session like this. I think actually PIK2 inhibitors PIK3CA up to the target drugs are coming, which are FDA approved, and we'll actually learn from Dr. Parveen Jain, who will be Dr. Parveen Jain.
So first of all, I would like to thank Dr. Reddy's. So I'll be presenting this abstract, which is INAVO 120. So nowadays, we have two upcoming PI3K AKT-mTOR pathway inhibitors. So one is inavolisib and another is capivasertib. Capivasertib recently got approved by US FDA in the endocrine resistant setting. So this is another molecule which is not available in India, but recently in ASCO 2024 this abstract was presented. So this is inavolisib plus palbo plus fulvestrant vis-a-vis palbo fulvestrant in it's a selected population PIK3CA mutated locally advanced metastatic breast cancer who had progressed on endocrine therapy. So these are the secondary endocrine resistant population which was selected. So those patients who relapsed during adjuvant therapy or within 12 months of finishing adjuvant therapy. So the initial analysis of INAVO 120, it met its primary endpoint of progression-free survival, and there was a clinically meaningful significant improvement in progression-free survival from 7.3 months to 15 months with a hazard ratio of 0.43. And this abstract, it is looking at the further efficacy and safety analysis of this product. So just to set the background of the trial, so we know that there are three major pathways which are active in hormone receptor positive disease. One is the ER pathway, the second one is the CDK4/6 pathway which we are targeting with CDK4/6 inhibitor, and the third one is the PI3K AKT-mTOR pathway. So initially we tried to look at this pathway as a resistance mechanism, but now we know so there are a lot of patients who inherently they are having PI3K AKT-mTOR pathway aberrations. So initially we had everolimus and everolimus drug which was inhibiting the mTOR. So later on the AKT inhibitor capivasertib which recently got approved came into picture, then PI3K inhibitor, alpelisib. But the problem with PI3K inhibitors were the toxicity. So there were a lot of GI toxicity. Experience is that almost 50 to 60% of the patient, they stop alpelisib once it is started. So this inavolisib, it is a selective inhibitor of P110 alpha catalytic subunit, and it is specifically inhibiting this, and probably because of this it has less toxicity as compared to alpelisib. So this was the study design. Here the standard of care arm was palbociclib and fulvestrant, and the selection criteria we had already discussed, and the experimental arm was addition of inavolisib with palbociclib and fulvestrant. And the primary endpoint of this trial was progression-free survival. The other endpoints were overall survival, overall response rates, along with some other endpoints. So this was the primary analysis result, which showed that there is a significant PFS advantage with a 15-month PFS which was achieved with inavolisib arm, and the hazard ratio was 0.43. So these are another endpoint. The time from randomization to end or discontinuation of next line treatment, which is a proxy for PFS2, again significantly improved with addition of inavolisib, and this event, this was PFS2 was 24 month versus 15.1 month with a delta of 8.9 months. If we look at first subsequent chemotherapy time to randomization to first chemotherapy receival, so again this in inavolisib arm, so it is still not mature, the data is not mature, and if we look at the hazard ratio, it is 0.54. Post progression therapy, if we look at, so almost similar kind of people, they received chemotherapy, but more patients with the standard of care arm, they received any blocker of PI3K, AKT, mTOR pathway. We can see that 25% of the patient, they received PI3K inhibitor in the subsequent line. 7.3% patient, they received mTOR inhibitor, vis-a-vis in inavolisib arm, PI3K inhibitor patients received in 3.1%. So there was more receivable of PI3K, AKT, mTOR pathway inhibitors in the standard of care arm. Regarding the safety, again the class side effects of hyperglycemia, diarrhea, rash, stomatitis, it was also seen with inavolisib. But if we look at the resolution of selected AEs, so most of these adverse events which happened, so they were resoluted during the time of or the course of illness. So these are the concomitant medication which were used for these key selected AEs. So which were for hyperglycemia, diarrhea, rash, stomatitis, and the drug which were used were the metformin for hyperglycemia, loperamide for diarrhea, and hydrocortisone and steroids for other steroids for rash and stomatitis. So to conclude, INAVO 120 met its primary endpoint with a statistically significant and clinically meaningful improvement in PFS. Inavolisib with palbociclib and fulvestrant, it was associated with sustained benefit beyond disease progression. That means the PFS2 was significant. And inavolisib discontinuation for hyperglycemia, diarrhea, rash and stomatitis, they were low as compared to alpelisib. So with this, I would like to end the talk. Thank you.
Thank you. Thank you. Any questions will be on the panel discussion.
Okay.
Ribociclib has been well established as a treatment which increases survival in advanced breast cancer. Node negative risk, who are also more of a abemaciclib. So this is an trial, ribociclib in adjuvant breast cancer. I will ask Dr. Pankaj Goyal to describe more about the NATALEE trial.
Good morning, everyone. So the topic I'll be discussing in NATALEE trial, the addition of ribo to standard of care NSAID demonstrated a significant improvement in IDFS over NSAID alone in patients with stage 2 or 3 early breast cancer. So second interim efficacy analysis, that is the median IDFS follow-up 27.2 months. 20% of the patients had completed planned 3 years of ribociclib, and hazard ratio was 0.748. Protocol specified final IDFS for 33.3 months. 42.8% of patients had completed 3 years of ribociclib. Hazard ratio 0.749. So we report the results from an exploratory 4-year landmark analysis of NATALEE with an additional 10.9 months follow-up. So this was the study design. So they had taken almost all the patients. If we talk about all node positive, even N0, if they are either grade 2 with the key index more than 20%, oncotype DX more than 26, high risk via any genomic risk profiling, or grade 3. So they were randomized to either ribociclib in the dosage of 400 as compared to 600 with the use in a metastatic setting. And that was compared with letrozole. And if the patient was premenopausal, GnRH agonist was introduced. So primary endpoint was the IDFS, and secondary endpoints were OS and safety and tolerance, which are included in this presentation. Protocol specified final IDFS was 33.3 months and 4-year landmark 44.2 months. And 62% of the patients have completed 3 years of ribociclib at 4-year landmark. So these were the NSAID treatment ongoing, 70.4% in the combination arm, while AI alone arm was 63%, and 62% had completed 3 years of treatment. Primary reason of early discontinuation was adverse event in 20% of the patients in the combination arm, while in aromatase inhibitors was 4.9%. Significant IDFS benefit was seen at planned 3 year of treatment that we were well aware of, 4.9% delta, improved from 83.6% to 88. 9.6% to 6.9%. So they comprised of all type of recurrences, whether it was distal lymph node, CNS, lung, liver, bone. So all these recurrences were reduced as compared to the aromatase inhibitor alone arm. In the subset analysis, irrespective of the menopausal status, the stage of the patient, irrespective of key index also, whether it was less than 20%, more than 20%, N0, N1 to 3, prior endocrine therapy, all these patients actually derived benefit from this combination, and the hazard ratio was hovering around 0.726 somewhere. Then stage wise, if you see the delta stage 2,
Chandrakant will be speaking. TORCHLIGHT trial toripalimab with albumin-bound paclitaxel. Why has to be approved in India?
Right. So thanks, sir, for that introduction. So let us try and put some light on the TORCHLIGHT trial. So this is toripalimab nab-paclitaxel. So we know why nab-paclitaxel has been there, because we know with Atezo nab-paclitaxel showed some benefit. So this is triple negative metastatic toripalimab. So we all know triple negative is a difficult disease, and if at all, if any breast cancer is immunogenic, it is triple negative breast cancer. And IO works synergistically with chemo, and that's why tori is used with nab-paclitaxel. And phase 1 trial did show some promising results. So this is the TORCHLIGHT trial, which is a phase 3 randomized trial. This is how the trial design looks like. The inclusion is treatment-naive patients, but you can see even one line of previous chemotherapy was allowed, but majority were treatment-naive. Performance status 0 and 1. Random is 530 patients, 2:1 randomization. Tori 243 weekly with nab-paclitaxel 125 day 1 day 8 every 21 days. And it was a placebo-controlled trial. It was stratified based on the PD-L1, the previous taxane used or not, and the current line of therapy, first or second line. It was continued until disease progression or intolerable toxicity or up to 2 years. Right, the primary endpoint is progression-free survival, secondary endpoint being overall survival. These are the baseline characteristics. So PD-L1 positive was around 300 and the ITT was 530 odd patients, and you can see majority were less than 65 years of age, and PD-L1 it was like 1/3, 1/3, 1/3, had less than 1, 1 to 10 and more than 10, and previous paclitaxel was used in around 15% patients, and majority, above 90% patients were treatment naive of first line treatment. Only very small percent had second line. So it met its primary endpoint, and you can see the separation of curves happening a little late, but the median is different, 8.4 versus 5.6 months. This is in the PD-L1 positive subgroup. So there is a 35% reduction in the progression, not death. Hazard ratio is 0.65. And you can see the subgroup. So majority, all of them benefited. Just focus on age more than 65, very small number, probably they did not benefit. Again, we cannot draw conclusions based on subgroups. This is PD-L1 positive subgroup. This is the site of metastasis didn't matter. Whether previous surgery didn't matter, so all of them benefited with toripalimab based regimen. So this is the PFS in the ITT population. Again, here also you can see the reduction is there, but it is little less. So there is 23% reduction in progression or death. Hazard ratio is 0.77, and the delta is still there. The p-value is 0.044. This is the overall survival. Of course, there is late separation, but you can see, yes, there is a significant difference in overall survival, 32 versus 19.5. Separation, clear-cut separation is there. And this is in the PD-L1 positive subgroup. Again, the OS except the age and the previous taxane use, all of them have benefit with toripalimab. So even the site of mets all didn't matter, all of them had a benefit by addition of toripalimab to nab-paclitaxel chemotherapy. This is the overall survival assessed in the PD-L1 positive subgroup. CPS less than 1, CPS 1 to 10 and CPS more than 10. As you can see, the hazard ratio is better when the CPS is more and more positive. 0.85 crossing unity if it is less than 1, and hazard ratio is 0.67 and if it is more than 10, the hazard ratio is 0.55, something close to the keynote trial where CPS is showing an impact on difference in overall survival, especially CPS more than 10. So the response rates were of course better, and the safety profile is like any other immunotherapy as we expect. So well, to conclude, in the phase 3 TORCHLIGHT trial, addition of toripalimab to NATALEE provided significant improvement in progression-free survival. Median PFS was improved by 2.8 months, and the risk of disease progression or death was reduced by 35%. Overall survival showed trend towards improved OS, again focus on CPS more than 10. Trial met its primary endpoint in interim analysis, manageable safety profile. So the final PFS in the ITT and the final OS in the PD-L1 positive subgroup and ITT will be statistically tested in future. Thank you.
In early TNBC, actually TNBC is a very bad disease. In early TNBC, especially in locally advanced disease, we are tempted to start immunotherapy with chemotherapy irrespective of PD-L1. So actually, and we see the PCR and continue immunotherapy with either if somebody is PRAP positive, olaparib or capecitabine. Well, that is the keynote 522 trial. Dr. Sarath will be speaking on that.
Good morning, everybody. Thank you, Redis, for this opportunity. So I'm here to present keynote 522, the updated OS analysis which were presented last year. So the updated overall survival results from the phase 3 keynote 522 study. For a brief background, we know that keynote 522 already met its primary dual endpoints, which were PCR and also EFS, although the approval came after the EFS results were presented, which significantly improved to the tune of almost 9%. So then this particular survival data was presented last year, where they updated the overall survival at 5 years. So for a brief design, all the high-risk TNBCs were included, T1C N1 to 2 or T2 4 N0 to 2, with an ECOG PS of 0 to 1. Tissue sample with PD-L1 assessment was also done. The stratification factors of nodal status, tumor size, or the carboplatin schedule, which could be either weekly or 3 weekly. Weekly, they had an AUC of 1.5. Randomized in a 2:1 fashion to include pembro versus placebo along with the chemotherapy, followed by surgery, and then pembro in the trial arm to continue for 9 more cycles, along with the placebo in the other arm. So the statistical considerations, primary endpoints were PCR and EFS, key secondary endpoints were OS, and then there were the other secondary endpoints. To summarize, one important point is 75% only had started adjuvant treatment in the pembro arm, so almost 25% did not get on to the pembro, that is because of the toxicity. For baseline characteristics, as you could see, CPS more than 1, almost 84% patients in both the arms. Weekly was more used, almost 60%, 3 weekly was in 40% in terms of carboplatin schedule. T1, T2 almost 75% was the representation, T3, T4 around 25%, almost equal number of node positivity and negativity, close to 51 and 49%. So at the updated EFS, you could see now we are sitting at a delta of around 9% with the hazard ratio of 0.65, which is statistically significant, the confidence intervals well within 1. And then if you could compare the EFS in terms of residual cancer burden, if you achieve a PCR, it was not any different. If you had an RCB of 1, it was also not different. But if you have a residual cancer burden of 2, that is the data set where the improvement is the highest, almost to the tune of 20%. If you had an RCB 3, it was actually detrimental. So the key overall survival which were presented in this particular analysis, you could see now the hazard ratios are sitting at 0.66 with a p-value significant with a delta of around 5%, and there is no further OS which will be updated. So this is the final OS results from Keynote 522. We are now sitting at 5% delta. So if I could just say PCR of 14% improvement, EFS of 9% improvement, OS of 5% improvement in all comers. And then from the subgroups, as you could see, if you had a T1-2, the hazard ratios are much better when you compare to T3, T4. Weekly, 3-weekly, not much different in terms of overall survival, although weekly had better PCR and EFS when compared to 3-weekly. CPS more than 1 or less than 1, it didn't make a difference, although CPS less than 1, the hazard ratios better to the tune of 0.51, CPS more than 1, hazard ratios of 0.70, although from the preliminary session we know that CPS more than 20 had the highest PCRs and also the OS. Also one more point, age more than 65 didn't do well, although very minor representation was there. So in terms of whether you achieved a PCR or no, if you had achieved a PCR, OS is not any different, the hazard ratios are still sitting at 0.69, the delta is just 0.6, but in the non-PCR group, now the delta is around 6%, so with the hazard ratios of 0.76. So again, from the treatment-related adverse events, 27% drug discontinuation in the pembro arm and compared to 14%. Deaths not much different, 3 and 1 in both the arms, but the randomization was between 2:1. Immune-mediated events led to around 7.7% drug discontinuations, but no new safety signals they had reported. So what are the points we need to discuss after this trial? This trial already made sure that carboplatin was given for everybody in both the arms, although it was designed way back in 2017 where the debate just started whether to use carboplatin or not. But this trial had carboplatin in both the arms, so that killed the debate whether to include carboplatin or not. T1C N0, we don't know whether this particular high risk needs such a regimen, but because these were not included. Neoadjuvant by adjuvant pembro, which helped more? You could see the ones who did not achieve PCR, they were doing much better. So adjuvant pembro is also helping them. Neoadjuvant is driving more PCRs. Adjuvant is helping in the ones who haven't achieved PCR. So if you had achieved a PCR, can we omit pembro? We do not know the answer. This trial was not designed to answer that question. If you haven't achieved PCR, do we need more than pembro? Is one question we are all wondering whether we can add adjuvant capecitabine or olaparib after that. Safety data is there, efficacy data is not there, so that is our whole individual decision. So PCR, whether it is a surrogate endpoint or a marker with good negative predictive value, I think it is a marker with good negative predictive value rather than a positive predictive value. And how do we include PDL1 to take decisions? We know that it is a dynamic marker. We just saw irrespective of the PDL1 or the CPS scores, you were doing well. So the debate whether one particular PDL1 value will define everything, because we know that it is also a dynamic thing which changes over a period of time, is also one debate. Are we worried about safety signals after the data? No, not. So in a nutshell, carboplatin for everybody, at least in the chemo arm, after this trial and also from the brightness, although that was not the initial end point, but then they retrospectively debated Pacli versus Pacli carbo was doing better. So weekly Pacli carbo had higher PCR and EFS, although not much different in terms of OS, weekly and 3-weekly. Definitely significant improvement in PCR, EFS and OS, 14, 9 and 5% respectively. No adjuvant capecitabine or olaparib was allowed in this particular trial because this was designed prior to the results of Createx. And PCR group, there was not much OS difference. Non-PCR group was sitting at 6%. When compared to CPS positive or negative, CPS positive, the OS is at 5.6%, CPS negative, although it was only 13% of the representative population, were sitting at a delta of 15.3% OS in CPS negative group. So T3, T4, or if you are more than 65, there was minimal benefit. And we also know that no further OS will be reported after this particular trial because they already met the endpoint and this will not be continued for further OS events. Thank you.
Thank you, Doctor. So now we are moving further, and this time we are having our international speaker. He will address about the keynote address 1, optimal adjuvant endocrine therapy for early stage breast cancer, benefit of adding OFS, and Professor Dr. Olivo Pagani is a from the MD Institute of Oncology of Southern Switzerland, Ticono, coordinator of the breast cancer program, European School of Oncology. I would like to welcome our international speaker for his talk. Professor Olivo Pagani, sir, please.
Good morning, everyone. It's a pleasure to be here with you. So I will try to. Yeah. Can you see the slides? Can you see the slides?
Professor Pagani.
Yeah, can you see my slides?
Some technical glitch.
Now, can you see them?
Yes.
Okay, wonderful. So, I will try to put this in the, voila, here we are. So my task today will be to incorporate our trial evidence into your routine clinical practice. So I do not have significant conflict of interest. And so let's start to look at the soft and text data. We now have so far a median follow-up of 13 years for the text and 12 years for the soft trial, but they are going to be updated, and the 20 years follow-up will be presented at ASCO, hopefully. So you know the design of the text and soft trial, which are the two major differences. Of course, text trial, all the patients received ovarian function suppression, and 40% of them had no chemo, and this is very important when looking at the data, and 60% of them had adjuvant chemo. In the soft trial, there was an arm with tamoxifen alone, and in this trial, 53% of the patients received chemo, so a little bit less than in the text trial. If they received chemo, they had to remain premenopausal within 8 months after the end of chemo. So which are the patient's characteristics? Here again, there are some differences. If we look at patients in both trials who did not receive chemo, you can see that they were a little bit older. Very few were node positive. But in the text, and this is important, 21% of patients who did not receive chemo were node positive. Then, of course, in patients who did not receive chemo, they had tumors smaller, less were grade 3, and less were HER2 positive. We will come back on HER2 positive patients later on. And the difference in starting of the treatment, if they received chemo in the soft, they had it a little bit later. So in the women who received chemo, they were younger, they were of course much more not positive, bigger tumors, grade 3. So two different populations. So let's start and see trial results in the overall population, so in women who receive chemo and who do not receive chemo. And you can see here in the soft trial, so tamoxifen only arm, we have a significant absolute reduction in distant recurrence and death of 1.4 and 2.3% at 12 years by adding OFS to tamoxifen. And if you further escalate, so you give an exemestane plus OFS versus tamoxifen alone, the absolute reduction in distant recurrence and death are 3% and 2.6% at 12 years. This is the overall population. What is important to note is that the hazard ratio did improve over time. In the first 5 years, the hazard ratio was 1 for deaths, and in the more than 5 years, the hazard ratio was 0.7. This means that in ER-positive disease, also in premenopausal women, to see overall survival benefits, we would need to follow these patients longer in time. So this is really very important. The first results at 5 years cannot be significant, but they tend to become significant over time because we have, of course, late relapses. What is the soft and text overall population? Once again, women who received chemo and women who did not overall. And you can see that by giving exemestane over tamoxifen in the presence of ovarian function suppression, the absolute reduction, we are always looking at absolute reductions, not relative reductions. In distant recurrence, the absolute reduction is 1.8 at 12 years, keep this number in mind, and the absolute reduction in that is 1%, so not so much. Once again, the hazard ratio is improving over time. What about women who did not receive chemotherapy? So in soft, 9% of them were node positive, and you can see here that more than 95% of these women who were at lower risk, as I mentioned before, more than 95% are surviving at 12 years. But 50% of these deaths are after a breast cancer event. In these women, escalating endocrine therapy with the additional burden of side effects from tamoxifen to tamoxifen plus OFS to exemestane plus OFS is not worth. But what it is important, we will come back on that later on, is that as I mentioned, the breast cancer event was a major cause of that. But what is important is that, and this was a big debate, if you escalate endocrine therapy, you increase non-breast cancer death. And this is not the case. So you have only 2 deaths without cancer in exemestane plus OFS and 4 in tamoxifen alone. So at least from a safety profile, escalate endocrine therapy is not dangerous. What about soft and text no chemotherapy cohorts? Here we have, and this is very important in my opinion, 21% in the text population who were node positive. The 13 years median follow-up, once again, is that there is no clear benefit in escalating endocrine therapy in these women. So these women can live very well and longer just with endocrine therapy. And once again, very few no cancer-related deaths, no difference between the different treatment arms. In these women who were at least a little bit higher risk in the text population, you have 70% of the deaths are after a breast cancer event. The take-home message here is that you have to follow these women longer and not dismiss them from follow-up after 5 years, because they can have late recurrences. Let's go back to the chemotherapy cohort, so higher risk patients who deserved, according to their treatment physicians, adjuvant chemotherapy. Here, the picture is changing as compared to the overall population and as compared specifically to the no chemo cohort. And you can see here in soft that in these women at higher risk, 57% node positive, escalating endocrine therapy is associated with an absolute reduction in distal recurrence by 2.6% at 12 years if you give OFS plus tamoxifen versus tamoxifen alone, and as high as a 4.5 absolute reduction if you give exemestane plus OFS versus tamoxifen. So in this population of women, it's worth escalating endocrine therapy. What about the soft and text? A higher risk population, but a mixed population. Here you can see that, once again, it is worth escalating endocrine therapy in these higher risk patients. Just a quick mention to HER2 positive patients. As you see before, the soft and text trials starting in 2003. So before trastuzumab entered the adjuvant scenario. And so not all the patients, only 56% of the patients who were HER2 positive did receive trastuzumab. And the HER2 positive population was 14% of the overall population. Nevertheless, you can see here that there is a significant benefit in women who received chemotherapy and received OFS if they were HER2 negative, the picture on your right, and this benefit was associated specifically with tamoxifen plus OFS, which is the red bullet. In women who were HER2 positive, so a minority of the trial population, you can see that it is a benefit of tamoxifen over exemestane. The other way around, sorry, I made a mistake. The other way around, the benefit in HER2 negative is associated with exemestane. In HER2 negative population who received chemotherapy, 84% of the population, there is an overall survival benefit of 3.3% at 12 years if you give an aromatase inhibitor plus OFS versus tamoxifen plus OFS. And this is the benefit, more or less, of aromatase inhibitor in the postmenopausal population. So the message here is that HER2 negative population at significant risk who needed chemotherapy, there is a benefit of giving exemestane over tamoxifen. In the HER2 positive population, in our trial, tamoxifen plus OFS was better than exemestane plus OFS. So how to discriminate the higher risk population? So it is quite clear. You have different tools available, markers available, but from a clinical point of view, very simply, in the soft and text population, you can see that those who had the benefit by escalating, so the blue dots, exemestane plus OFS, if they received in soft the neoadjuvant chemo, so higher stages, if they were younger, less than 35, if they had more than 4 positive node, or if they had tumors bigger than 2 centimeters, or if they were grade 3. So the highest benefit was in patients who had chemotherapy and had the worst clinical characteristics. So what to conclude from this 12 and 13 years median follow-up? One very important clinical and routine clinical practice is that distant recurrence in deaths from breast cancer continue to occur among premenopausal HR-positive patients. And as I mentioned, the follow-up is continuing. Then, of course, the meaningful relative reduction in distant recurrence and death persists over time, and the absolute reduction can be as high as 10% in women at higher risk. In women with low clinical risk, there is no benefit of escalating endocrine therapy, and most of these women, even if not positive, do not benefit from chemotherapy. So being not positive is not necessarily an indication of chemotherapy. And then, as I mentioned, you need time to see a distant recurrence and overall survival benefit in these patients. So the 5 years, and we will see in a moment, the 5 years results are not always representative of the long-term results, which are the latest results in the SOFT and TRESS trial, which were presented at ESMO, recently ESMO. We looked at lobular cancers because in postmenopausal women, we had this information that aromatase inhibitors are better than tamoxifen in lobular cancer. In the population of SOFT and TEXT, as in the other postmenopausal trials, lobular cancer are a minority. So this is a post-hoc analysis in 345 patients. As you can see here, there is a superior efficacy of OFS plus exemestane versus tamoxifen in the SOFT trial for patients who had lobular cancer. So this is overall. If you look at the distant recurrence free survival, here again there is a benefit with exemestane versus tamoxifen in the presence of OFS in lobular cancer. And if you look also in the benefit as compared from in ductal cancer with lobular cancer, the magnitude of benefit is similar, but apparently the numbers are small. The exemestane benefit is more pronounced in the lobular cancer subgroup. They are very few in young women, but they are there. And if you look at luminal A and luminal B, once again, in the luminal B, so the higher risk population, there is a significant benefit, despite not so big, in the exemestane treated population versus the tamoxifen treatment population in the presence of OFS if they had lobular cancer. So of course, a word of caution, because these results of course add an additional body of evidence favoring aromatase inhibitors versus tamoxifen in lobular cancer, as it was already seen in postmenopausal women. Of course, it's not possible to run a phase 3 randomized trial in this population, very few. And so we just have this subgroup post-hoc analysis, and so we need, as usual, a clinical judgment in order to decide if these women really need to escalate to exemestane just because they have lobular cancer. So let's move to the recent results of adjuvant CDK4 and 6 inhibitors. We have two trials, as was mentioned before, the Monarchy with Abema and the NATALEE with ribociclib. different duration and different patients population, as it was mentioned before. So the Monarchy trial was dedicated to higher risk population, so no, not negative. In the NATALEE trial, there were not negative patients with higher risk, like bigger tumors, T2 or grade 3. So different population, different drug, and different duration. Which are the results in premenopausal women? Recently, in the NATALEE trial, were presented ESMO by Sibin Loiber. We had already the results in the Monarchy. And apparently, premenopausal Monarchy or age less than 40 NATALEE, so young women, they benefit significantly if they are premenopausal by adding a CDK4 and 6 inhibitor. What is my caution remark in this trial? Especially for the Monarchy, we do not have this data yet for the NATALEE trial. As you can see at the bottom of the slides, they were, as mentioned before, very high risk patients, but nevertheless 58% received tamoxifen alone, which is not the standard of care now, as I mentioned before, in high-risk patients. So these women were undertreated according to the current guidelines. Only 48%, despite being high risk, received ovarian function suppression. So this is my word of caution. In the NATALEE, we do not know yet how many received OFS. This is a more recent trial, if they were higher risk. And so we need for this data before making any definitive conclusion. But nevertheless, these data are encouraging. So if you have a high-risk patients and you want to escalate, giving them CDK4 and 6 inhibitors, who of course add toxicity, as we saw before, you have this opportunity, and so far it seems they work. Timing of ovarian function suppression. This is a very frequent question. Should we give ovarian function suppression in women who receive chemo after chemotherapy or together with chemotherapy? We looked at this data a few years ago now, and there is no difference. We looked at breast cancer-free interval and distant recurrence-free interval in soft and text, and the concurrent approach, OFS together with chemo in the text trial or sequential after the end of chemo in soft, you can see the curves are exactly the same. And this is true also according to age. So women less than 40, which are those who less frequently develop amenorrhea with chemotherapy, or women older than 40, the ones who develop a premature ovarian suppression with chemo, you have no difference. So the message here is that you can do whatever you want. So you can start together. If you want to use ovarian function suppression also for ovarian protection, or in older premenopausal women, this is what I do, you wait and to give chemo. If they develop permanent amenorrhea, you do not need to go for ovarian function suppression, otherwise you had it after chemo. But from an efficacy point of view, there is no difference whatever you do. Treatment duration, another very important question, especially because, of course, ovarian suppression, if you give LHRH agonist, and the trial with soft and text were done with LHRH agonists returning in particularly, are costly. So which is the best duration? We had the Austrian trial where they give 3 years of goserelin, and you can see at the top of the slide their 10 years follow-up. They did not continue long-term follow-up. So the latest data are at 10 years, and you can see that there is no difference at 10 years in escalating endocrine therapy with anastrozole or tamoxifen. We tried the difference. We saw there is a benefit, but we tried the difference in the soft and TREX trial, which gave 5 years of triptorelin as compared to the Austrian trial. The Austrian trial population was a lower risk population. Most of them, much more patients were node negative. The tumor size was smaller, and particularly only 5% of these patients received chemotherapy. So they were apparently at lower risk than the soft and TEX population. So in a lower risk population, you can see very good results at 10 years with 3 years follow-up. And then we have the Korean trial, the Astra trial, where they gave 2 years of OFS, and very interesting trial. They started quite long after the end of chemotherapy. So this is a trial which gives us information about the late start of ovarian function suppression, who remains, so premenopausal, at least within 2 years of end of chemotherapy. And you can see that you have here 3.6% absolute benefit in disease-free survival and 1.6% absolute benefit in the overall survival with just 2 years of OFS. The population is quite similar to the soft and test, node positive 56%, majority of stage 1 and 2. What is the difference? All these women receive chemotherapy by trial inclusion. So once again, the population of patients is not exactly the same as soft and text. So the cross-trial comparison is difficult, but once again, this is an opportunity if you have cost issues or patients do not tolerate long-term ovarian function suppression. Then, of course, which kind of LHRH you should use? We really do not know. There is no comparison between the 3 of them available. One of the possible practical consideration is that triptorelin has a very small needle, and so patients can also inject themselves at home and there is no pain. But there is no difference in apparently, not direct comparison, but the cross-trial comparison. There is apparently no difference in efficacy. So, according to an initiative, very, very important initiative from Dr. Femina, very recently was published the Indian expert consensus on OFS, and I had the privilege to participate in this effort. So there is the reference over there. And what is the expert consensus according to the soft and text data? That for high-risk patients, OFS coupled with an aromatase inhibitor is a recommended therapeutic strategy. Soft and text were done with exemestane, but once again, we do not have data, comparison data, randomized on the other aromatase inhibitors. We have no reason to believe there is a difference between the 3 of them. So this generic formulation is, I think, very correct. The potential duration of up to 5 years, I hope I convinced you, provided tolerability is maintained. You have other option if the side effects is quite intolerable for the patients or the risk is not so high. In patients below 40 years of age, simultaneous initiation with chemotherapy is advised because, as I said, they do not develop permanent amenorrhea, and OFS is also associated with ovarian preservation. while in those aged over 40 years, sequential initiation is acceptable and is, in my opinion, the best option. Among the available LHR agonists, triptorelin stands out as the preferred choice before tolerability, and it is manageable, although the efficacy is superimposable across all the options available. Which are my personal take-home messages, and then a few considerations for the future. So these results of 12 and 13 years confirm efficacy of escalating endocrine therapy in women at intermediate and high risk of relapse, and we have clinical tools to identify these women. Women at low risk of relapse, and there are these women also in premenopausal women, there are women with HR positive disease who are at low risk. Age is not equivalent to risk. And so they do very well long-term with tamoxifen alone and no chemotherapy. No need to give to all these women chemotherapy just because they are premenopausal. The benefits persist over time, and so this is another very reassuring message, is that premenopausal women can live longer if properly treated. OFS should be the preferred option for those at higher risk. Very young women, I did not show the data, but they are those who benefit most by the addition of OFS. Aromatase inhibitors do provide additional benefit when combined with OFS in these higher risk women. And which are the open question? Who are those who will benefit from chemotherapy? Which is the role of gene expression profile? And some very new data presented at San Antonio of the optimal combination in HER2 positive patients. So which are the data of genomic assays in premenopausal women? First of all, the TAILOR-X data with Oncotype. These were the first data to be presented, and you can see here that in women younger than 40, there is apparently no benefit in adding chemotherapy. The benefit in adding chemotherapy on top of endocrine therapy is in women premenopausal but approaching menopause. So those from 41 to 45 and from 46 to 50, which is my take-home message in this situation. And this was presented a few years ago, and now what was also presented by Ann Partridge at San Antonio. My interpretation, and not only mine, is that chemotherapy in these women have an endocrine effect. And this is what we think for many, many years indicate. So in women at intermediate risk, a recurrence score 21 to 25, low clinical risk or high risk, these women have a significant benefit, but especially if they are older premenopause. Let's move to ERIC-Sponder. TAILOR-X was in node negative, ERIC-Sponder was in patients with 1 to 3 positive nodes, and here postmenopausal women apparently not a big big benefit in adding chemotherapy, and there is a benefit of more or less 5% in women in premenopausal. Once again, the cautious message is that these women who do not know if they became postmenopausal after chemo or not. And the same results, so every trial seems to underline these results, that in mind that women with clinical high risk and low genomic risk, if they are less than 50, they do benefit 5% benefit in distant metastatic free survival if they are premenopausal. Once again, these tools can help you in identifying high-risk patients, but as I showed you before, and I hope I convinced you, clinical characteristics are also very important and do not need to be dismissed, even if you have expensive and sophisticated genomic assays. So a few words in the HERA trial, the data presented at San Antonio this year, and they looked in 965 patients, more or less the same number of the HER2-positive patients in soft and text. The median follow-up is 11 years, and you can see here that the survival outcome for OFS and endocrine therapy was higher than in patients receiving tamoxifen alone. This is like in the soft and text trial. So what seems really very important in HER2-positive patient, irrespective of everything else, is of ovarian function suppression. This is very clear in soft and text and in HERA as well, that these women need ovarian function suppression, both for improving disease-free survival and overall survival. Then if you look at patients according to trastuzumab versus no trastuzumab, you can see once again that in disease-free survival and overall survival, OFS is important over tamoxifen. So this is really important once again, even in patients who received trastuzumab. And then, if you look at the specific oral therapy, this is different from the soft and text. Apparently, in the ERA population, the aromatase inhibitor patients did better for disease-free survival and overall survival as compared with women who received OFS plus tamoxifen. So this is different from our data. We do not have detail. This was an oral presentation in a mini oral event, so we need to have the paper. I will wait until this data, because from that presentation was not clear which was exactly the population who received aromatase inhibitor, if they were the original population or they switched sometime over time. So I think we need to stay tuned, but these are data which seems to contradict our data. So to conclude, the risk of relapse can and should be calculated individually if you want by clinical characteristics or by genomic assays. We need now to take into account that CDK4 and 6 inhibitors have entered the adjuvant scenario. Of course, they were not available when soft and text were run, so we need some way to include them in the treatment planning. Of course, I did not mention the side effects. They are very significant in premenopausal women, and so they need to be taken into account, and especially for duration. You need to follow these patients for side effects, and you need to consider them in the treatment planning. And having said that, I thank you for your attention, and of course I will be available for the discussion.
Thank you, Professor Pagani. The house is open for question and answer to Dr. Pagani. Any question from the house side? If there is no question, I would like to call Dr. Bhuvan Chuk for a panel discussion implementing newer update for in the current treatment strategies for HER2-negative breast cancer.
So I would like to call my panel Dr. Sudeep Das, Dr. Yashwant, Dr. Shrikant, Dr. Vipul Doshi, Dr. Selvaraju. And thank you, Dr. Olivia, for a comprehensive talk, and the panel discussion is molded around what you have just spoken. So be there, we will definitely need your expertise there. To begin with, I'd like to thank Reddy's for this opportunity, and thank you to the Reddy's breast team. So we're going to divide the panel discussion, and we try to go through, I think we are running short of time, so we'll try to go through the case snippets. There are 5-6 cases, all of them are well concised. So the case 1 is a very young ovarian suppression, case 2 is a query low risk, case 3 and 4 are unanswered questions. One is about BRCA positive, another is a HER2 negative, case 5 is NATALEE, and case 6 is a triple negative. So before we begin, there was this excellent presentation by Dr. Francis in SABCS this year. I've taken the slides from her. So we're looking at ovarian suppression in early breast cancer, and there are 8 recommendations which she frankly gave. The first one is people who remain premenopausal and are at not a low risk of recurrence. As Dr. Olivia also said, the intermediate and high risk do require ovarian suppression. Very young women with ER positive cancer, premenopausal ER positive who are planned for adjuvant AI, women with ER positive cancer who have a chemotherapy-induced amenorrhea but are planned for adjuvant AI, especially under the age of 50. Patient for the NATALEE trial, all of them who were premenopausal were recommended to be on ovarian suppression. Premenopausal women who have not completed their childbearing, premenopausal women who we want to delay the onset of menopause, and the last one is a bit controversial, is the premenopausal luminal A who possibly may derive benefit, and as Dr. Olivia also said that, there's an entire TAILOR X subset in which patients are deriving benefit because of the ovarian suppression rather than because of the chemotherapy. We'll move forward, so I'll just begin with the case 1. So she's a 29-year-old female, she's a well-educated, fit, married, nulliparous, she's definitely desirous of a childbirth. There's no family history, germline is CDH1 VUS. She has a right breast lump which measures 3 into 3 centimeter at the NSE, and there's a palpable hard discrete node. She's ER/PR strongly positive, HER2 negative. Considering that she is a very young female with possibly an N1/N2, we have given her a dose-dense AC followed by Taxol along with monthly Zoladex as a part of fertility preservation. She has undergone a breast conservation surgery with axillary lymph node dissection on January 23. I've written January 23 because at that time only the monarchy was available, the NATALEE was not available at that time. So the post-op histopathology is IDC grade 2 T2N1A ER 8/8 PR 6/8 and HER2 neu 0. So I think we have all the relevant clinical information, and I would like to start with the questions there. So let's start with Dr. Sudeep Das. I think I have the list here with that. So Dr. Das, your take, anybody differs on does she require ovarian suppression or no?
Yeah, she requires because she has high risk of recurrence because she is not positive, she is young age. So
fine. Yes. Anybody who differs that she does not require ovarian suppression, I think we can move forward because it's a pretty straightforward answer there.
I think she required ovarian suppression because she is fulfilling all the criteria of high risk group.
Okay. So the next question I will ask Dr. Yashwant is AIOS versus TAM-OS. What would be your choice of? Anybody has a difference of opinion here about the AIOS versus TAM-OS? All of us are very. So I think the third one is where the things start to get a bit tricky. So timing, you'll probably put her as a start in a TAM-OS, and then once she's become postmenopausal, then you'll shift her to AIOS, or considering that she was on Zoladex to begin with, you would not repeat a LH-FSH estradiol, you'll simply start her on AIOS, or you'll start her on ovarian suppression, and once she converts to postmenopausal, then you will go to AIOS. So I'll take it one at a time. Dr. Shrikant, what will be your take on it?
Look, the age of the patient is quite young. She is 29-year young female. So the TAM-OS followed by once postmenopausal, that scenario will not happen because she is quite young age. So the AIOS to be start with the beginning.
Come again. Can you say the first point again, please? I think you said OS followed by AIOS will not happen. But go ahead, please. Sorry.
Because of the age.
So if you look at the softened text, and Dr. Olivia can correct me, most of these patients post-chemotherapy were put only on OS, and once they went into postmenopause, that's the time when their AI was introduced. So Dr. Olivia, can you come in here and define the patients?
I think that I did not show the data for the sake of time, but unfortunately, the women below 35, they were only 10% in softened text because they are not very many. But despite the numbers, which are not so big, they were the ones who did profit more by exemestane plus OFS. So I do fully agree these women who suffer more from, of course, this treatment are those who benefit most. And as it was said by the colleague, of course, she's 29. She will not become postmenopausal because of age. So I think she needs the best treatment from the beginning. I will not try to give her tamoxifen and so I will start with the aromatase inhibitors and OFS.
So what I hear, and this is what I wanted to clarify. So a patient who has been on Zoladex as a part of fertility preservation, once they finish chemotherapy and then they move on to the radiotherapy and they come back to you for hormone therapy, do you recheck their menopausal status, or you simply move on to AI plus
No, if I decide that she needs ovarian function suppression for age or for stage, I will keep going.
So I think that's what you've already shown these slides, I think we have discussed it, so, and that's where the confusion comes in. See, for a 29-year-old female, when you monitor them with the estradiol and LHN FSH, they are not concordant with their postmenopausal status. And I think if somebody differs with me, Dr. Vipul or Dr. Selvaraju, do you differ? Have you seen this in your clinical practice? Do you feel that
patients who are on Zoladex, we don't do such tests because those are not helping us.
So that
even NCCL is also not supporting that you do these tests to check their menopausal status. Those tests are for the patients who are not taking any GnRH analog.
So, and that was what was done in soft text. In soft text, there was no monitoring done for the estradiol, LHN, FSH. So Dr. Olivier, your take on it, so what you're saying is the moment you put a patient on an ovarian suppression, irrespective of the...
You need to check. If you give, we did the soft test trial, a subgroup of patients, so this was a sub analysis, but it was pre-planned. In women who are taking aromatase inhibitor, exemestane plus OFS, there is a subpopulation which is not menstruating but is not suppressed. So in women who are taking aromatase inhibitor and OFS, you have to check, because a subgroup of them are not suppressed despite not menstruating. If you are giving tamoxifen and OFS, you do not need to check, because even if they are not suppressed, there is no risk. But for the overloop, for the loop of the stimulation, if they are under an aromatase inhibitor, you need to check, because if they have the estradiol not suppressed, this can stimulate the ovarian again. So there is a loop, which is a biological one, and so you need to check.
And how do you check that?
With estradiol.
So
yes, you just need to check the estradiol, because of course, as it was mentioned, FSH and LH are not concordant, are not helpful. But you need to have a threshold of your estradiol. Ideally, you need to check the estradiol always in the same lab, because of course estradiol levels are challenging. But if you have a trustful lab, you need to be sure which is the threshold, and you need to check if they're taking an aromatase inhibitor or OFS, especially if they are very young.
Fair. So I think the learning which has come out is that any patient who is extremely young, there is a chance that you may be missing out on basically she may not be menstruating, but she still may be a premenopausal.
Yeah.
So routinely checking estradiol is something which is recommended. You may not check
every 6 months.
Come again, please.
Every 6 months.
Every 6 months. Fair. So I think that's a huge learning there, because what I have found in my clinical practice is usually the LH and FSH, we find it very difficult for them to come to the postmenopausal status. The estradiol, however, usually falls very rapidly to less than 15, which becomes very comfortable. Anyway, so moving forward, the NCCN recently recommended you can move on to the 3 monthly injections rather than a monthly injection. So I would like to ask, the Indian practitioners, their practice, do they do monthly or do they do 3 monthly? Anybody can take that, please.
Like 3 monthly only is more comfortable for patients and even more comfortable for follow-ups. So 3 monthly is preferred one.
And then the next question is, the NCCN recommends that as of now, the 3 monthly injection is Zoladex. So in your practice, you do triptofan more or the Zoladex more?
Like we have more experience with Zoladex only, so that is our.
So can somebody else also take this question? Do you guys do Zoladex or triptofan 3 monthly versus monthly? Anybody can take this question. Dr. Sudeep Das, Dr. Yashwant, anybody please.
Experience is more with Zoladex and 3 monthly.
Zoladex and 3 monthly. Anybody else?
Monthly primarily, but most of patients we start with monthly, but after a year or so they get switched.
So 5 of you raise of hand. We can, that will show how much Reddy's is working. So how do you do triptofan versus dominating Zoladex?
So we are using generally 3 because the patient used to come, patient was on AI, so used to come every 3 monthly for the follow-up. So it's very convenient.
So Zoladex or triptofan?
Zoladex.
Ladies?
Can I add?
Yeah, please.
I do not want to be intrusive, but there are very few data on the 3 monthly, also 6 monthly. There are some Japanese data, very small patients population. Once again, I think this is a clinical judgment. We saw it in my clinical practice, I see this not frequently, but see that very young women, the 3 monthly is not enough to suppress. So if you have a 45 women, you can go for the 3 monthly and you do not risk a lot. But if you have a less than 35, like in this case, I will go for monthly because the 3 monthly is not enough to suppress.
Okay, so I'll quickly ask you these 2 questions and then we'll move to the next case. How comfortable are you with the break? Considering that the Astra had shown, and this is a real case, she actually broke down this the last week when she had come, that she does not want any more ovarian suppression. And for me, why I'm asking this is because the adherence of ovarian suppression is always a challenge. As you grow in the years, 1/4 of the patient end up dropping ovarian suppression by the time the 3rd and 4th year happen. So how comfortable are you in following the Astra or the Austrian trial when it comes to a patient? So let me ask you this the other way around. What is the negativity as in, it is associated with an increased risk of recurrence. Can you help us with a deep dive in soft and text, help us understand what is the increased risk of recurrence we're looking at in a 29-year-old female who had node positivity? Dr. Olivia?
Sorry. I think once again, there is no randomized comparison on duration. As I mentioned, the Austrian trial was a very low-risk population. So once again, the clinical judgment here needs to be taken into account. In a very young woman like this one, with positive nodes, she had N1 after chemo, after neoadjuvant chemo, so she's really at high risk. I will go for 5 years. Of course, side effects are an issue, but it's not an excuse. You need to monitor side effects and treat side effects. They can be treated.
Right.
So you have to motivate.
Be with you today to discuss about treatment of HER2-positive breast cancer. I will try to provide an overview on the yearly breast cancer setting, considering both neoadjuvant and adjuvant, and then the treatment of metastatic, providing also some highlights on the future landscape. Those are my disclosures. Let's start discussing about yearly breast cancer. All the guidelines, ESMO, ASCO, St. Gallen, and NCCN, support clearly the indication to neoadjuvant chemotherapy plus pertuzumab and trastuzumab in HER2-positive breast cancer. That's why I believe a multidisciplinary tumor board should give a clear indication to neoadjuvant treatment in this patient population. Why? because we know perfectly since the first trial in the neoadjuvant setting, that was the NOAA trial, that combination of chemotherapy plus trastuzumab in this case may increase the rate of pathological complete response, and pathological complete response in HER2 positive disease clearly correlate with long-term outcome. The NeoSphere was a prospective randomized trial combining pertuzumab and trastuzumab plus taxane, followed by surgery, followed by adjuvant anthracycline and dual blockade, that demonstrated that the combination of chemotherapy plus dual blockade increased the rate of pathological complete response from 29% to 45%, with the specifically rate of PCR also in those patients without chemotherapy, mainly in the HR negative disease. We have many evidences, of course, that neoadjuvant chemotherapy with or without anthracycline may increase the rate of pathological complete response from 45% in the NeoSphere trial to 67-68% in the TRAIN-2 trial. So now it's quite clear that we need to give dual blockade plus chemotherapy in all the patient population with HER2 positive disease, assuming also that there is a subgroup of patients like the ER negative, PR negative, that can achieve a rate of PCR in 29% of the patient population. Can we de-escalate in this setting? Some trials have been performed with TDM1, but finally it seems that chemotherapy is better than ADC, but I believe the most important de-escalation we may consider in this setting is de-escalating the use of anthracycline. In the TRAIN-2 trial, finally, we have clearly that pertuzumab, trastuzumab, and paclitaxel and carboplatin, when compared to a regimen with anthracycline, may achieve a very similar event-free survival, that is more than 90%, and a better rate of pathological complete response, that is 68%, with less toxicity. So we can really consider to omit anthracycline in the majority of the patient population with HER2 positive disease. Another de-escalation trial was the de-escalated neoadjuvant pertuzumab and trastuzumab with or without weekly paclitaxel in HER2 positive HR negative disease, even if in this trial was quite clear that in HR negative population it was better to combine with chemotherapy. Finally, we have the FAIR-AGAIN, an adaptive trial evaluating a dual blockade with pertuzumab, trastuzumab plus endocrine therapy versus the same combination with paclitaxel. Then a PET scan was performed after 2 cycles, and in the PET sensitive, with the response, patient proceeded, of course, with the same combination. In the PET resistant, they received the chemotherapy. Just to remind to you that the rate of PCR at the final evaluation was 79.6% in the patient population PET responder versus 20% in the PET non-responder. Whether or not this is the standard of care, I don't believe we can use in clinical practice, even if a basic disease-free survival at 3 years was very good in this patient population. Finally, we have other trials, adaptive trial. One of these is the MRI TRAIN-3 study design, but up to now, what we can do in this patient population is to give and provide a clear indication to neoadjuvant chemotherapy plus pertuzumab and trastuzumab in all the patient population, waiting for the data of DESTINY-11, incorporating trastuzumab deruxtecan in the neoadjuvant setting, or alone, or in combination with chemotherapy. Don't forget that in the DESTINY-11, the RA was prematurely closed for futility. And so we know perfectly already that TDX followed by chemotherapy is better than TDX alone. Other trial, of course, are the FAIR-AGAIN 2, also in this case using PET scan in this setting. So what to do in the adjuvant setting? Oh, the first trial to escalate was the affinity, using pertuzumab and trastuzumab in the adjuvant setting and demonstrating that the benefit of the dual blockade is limited only in the node-positive disease. So in the context of an HER2-positive disease, dual blockade should be used in the adjuvant setting only in node-positive population. The other de-escalation trial was the APT trial. This was a trial designed for stage 1 disease, stage 1 including PT1A to PT1C and 0 population, in combining weekly paclitaxel for 12 administration with trastuzumab for 1 year, and with 10 years follow-up, the rate of invasive disease-free survival was very high, close to 91%, and was very similar in HR-positive and HR-negative population. A cluster of non-inferiority trials have been completed. The Persephone, the FAIR, the ORG, the SOLD, the SHORT-TER. What is very clear is that a shorter duration of trastuzumab can be proposed to some patients, but we need to escalate in those patients with residual disease after neoadjuvant chemotherapy, and we had the data of the Catherine trial where TDM1 for 14 cycles was compared to trastuzumab in the final analysis presented and published during the San Antonio Breast Cancer Symposium. There is a clear demonstration that with a longer follow-up, TDM1 is better than trastuzumab alone in terms of invasive disease-free survival, with a difference of 37.6%, but there is also a trend for overall survival benefit. The next step, and we are waiting for this, will be the DESTINY-5. In the DESTINY-5, patients with HER2-positive disease and the residual disease after the neoadjuvant setting will receive exactly TDM1 versus trastuzumab deruxtecan, and we need really to remember about this, that this trial can be potentially positive and can be practice changing. So in the treatment algorithm, in order to summarize what we said from all this data, in HER2-positive disease, if you have a stage 1 disease, recommendation is surgery, followed by systemic therapy that should be the APT regimen, weekly paclitaxel plus trastuzumab for 1 year. For any other patient with stage 2 or stage 3, indication is neoadjuvant treatment with dual blockade with or without anthracycline, followed by surgery, and then completion of 1 year of entire HER2 therapy if pathological complete response, or TDM1 if residual disease. What's about metastatic breast cancer? Here, of course, we have a first-line therapy that is still very well established, that is taxane plus pertuzumab and trastuzumab, with a maintenance with trastuzumab, pertuzumab, plus or minus endocrine therapy. I will mention the PATINA trial, of course, with, if to consider with palbociclib or not. We have the data of the Cleopatra. This is a consolidated first-line treatment in the HER2-positive disease. The trial compared pertuzumab and trastuzumab plus dual blockade, docetaxel plus pertuzumab and trastuzumab versus chemotherapy plus trastuzumab alone, and with a very long follow-up, the median progression-free survival was longer in the dual blockade arm versus the mono blockade arm, with an hazard ratio of 0.69 and the median progression-free survival of 18 months. We have many patients still at 8 years follow-up that do not have a progressive disease. Of course, this is really an important observation, because it means that maybe some patients can be cured with a dual blockade plus chemotherapy. But we know perfectly that Another trial is ongoing actually, that is the Destiny 9, in which TDX plus pertuzumab or plus pertuzumab placebo will be compared to the standard of care, and let me see if we can improve this median progression-free survival, of course, to more than 19 months. These are all important observations that can really impact on the long term in the patient population. Of course, we know that the advent of the ADC, the new wave, completely changed the treatment landscape. The first study was the Destiny 3, prospective randomized trial comparing TDM1 to trastuzumab deruxtecan in the second-line setting, and trastuzumab deruxtecan improved the median progression-free survival to 28 months versus 6 months of the TDM1, with an impressive response rate close to 80%, and with an important benefit in terms of overall survival. The hazard ratio was 0.64. Of course, after trastuzumab deruxtecan, you can consider their two-climb study with tucatinib, trastuzumab, and capecitabine. Don't forget their two-climb compared tucatinib, trastuzumab, and capecitabine to placebo, trastuzumab, and capecitabine in patients who received the dual blockade and who received TDM1. So it means this is a clear third-line therapy, achieving an overall response rate of 41% when compared to 23% of the placebo trastuzumab arm, and an improvement in both median progression-free survival and overall survival. And don't forget that patient population in their two-climb was enriched for patients with brain mets. So we have a huge cluster of patients with brain metastasis. So the second-line setting is trastuzumab deruxtecan with an alternative for tucatinib, trastuzumab, and capecitabine. Brain mets is really an issue, and we know that active brain mets in their two-climb have been included with an improvement in both PFS and overall survival, but we know that the Destiny 12 was presented during ESMO 2023-4 and was published also in the Nature Medicine. This is a real-world study evaluating activity of trastuzumab deruxtecan in patients with their HER2-positive metastatic breast cancer and active or non-active brain mets. In the Kaplan-Meier analysis, in patients with baseline brain mets, the PFS at 12 months, 61% of patients were live without progressive disease. And another important information was that when considering the CNS PFS, 58.9% were alive without brain progression. Overall response rate, in my opinion, was impressive, 82.6% in untreated. They were 23 patients, I know perfectly, but it's really an important benefit in this patient population. And I believe these data, also overall survival, are assuring us that trastuzumab deruxtecan, according to the data of the Destiny 12, can be really considered something that can be proposed. So now, according to this data, if you have a progressive disease, of course, you can really consider trastuzumab deruxtecan, and maybe you can delay eventually the use of radiation therapy in this patient population. So what's about to do after in the third line? Of course, trastuzumab deruxtecan, if not done before, or TDM1, or tucatinib, trastuzumab, and capecitabine. We have some data on tucatinib efficacy beyond trastuzumab deruxtecan. Still, we have some activity, so we should consider. And when you have to select between TDM1 and tucatinib, personally, I believe I would go for a tyrosine kinase inhibitor, because we know that an ADC after another ADC can be less effective. Of course, we have many other agents that can be explored. trastuzumab and lapatinib plus endocrine therapy, trastuzumab plus any other chemotherapy, lapatinib and capecitabine. And finally, I would like to remind to you the maintenance setting during San Antonio this year have been presented the data of the PATINA trial. Patients who received pertuzumab and trastuzumab after response have been randomized to maintenance with dual blockade plus endocrine therapy, or the dual blockade plus endocrine therapy plus palbociclib. I believe the data of median PFS were really impressive. The median PFS was 44 months. That was unprecedented. There was also an outperformance of the anti-HER2 therapy plus endocrine therapy that was 29%, 29 months. So, with a very long follow-up, these are data, in my opinion, important that may incorporate the use of this triplet combination in the triple positive disease. We are waiting, of course, in the future for the DESTINY-9, and then knowing that the first-line therapy is dual blockade, but potentially will be TDX, I would like to mention rapidly also the HER2-low disease. We know that we have a spectrum of expression of HER2, and that now with trastuzumab deruxtecan we can target also HER2-low and HER2-ultra-low disease. I presented the DESTINY-6 during ASCO this year, and then the data have been published on the New England Journal of Medicine. In a patient population who progressed to CDK4/6 inhibitor and never received chemotherapy, trastuzumab deruxtecan, when compared to standard chemotherapy, can improve median progression-free survival, both in HER2-low from 8 months to 13 months, and also in HER2-ultra-low population. That is exactly the same benefit with an hazard ratio of 0.7. Response rate, as I said before, is notable, because you can see over here 57% was the response in HER2-low and 61% in HER2-ultra-low. So in conclusion, HER2-positive disease is a spectrum of disease, and as I said before, what we need to consider in the future is to better individualize therapy. Thank you very much for your invitation.
Thank you very much. I think we really enjoyed your talk. And can I ask you one question? Hello? Is available for the question or not?
I don't think so. I don't think so. He's not recorded.
Not available. Okay. Not available. Okay. So we'll continue further, and now we will have a Destiny Breast 06, and that will be presented by Dr. Arnab Bhattacharya.
Hello, yeah, sorry. So good afternoon, and thank you very much to the Dr. Reddy's team for giving us this opportunity of this academic feast, and good afternoon to all the respected faculty members and fellow colleagues. And it is actually very warm for me to discuss the same trial presented by Professor Kurigelano. So without further time wasting, so this is the Destiny 06. So TDXD versus chemotherapy in patients with hormone positive, HER2-low or ultra-low metastatic breast cancer with prior endocrine therapy. So we know that among hormone positive HER2 negative breast cancer, so there is a large chunk was HER2 low, 60 to 65%, and then there becomes the concept of HER2 ultra low, that is another 20 to 25%. So TDXT have shown its benefit as per the DESTINY-04 in previous lines where the chemotherapy was given, and there it has shown the PFS as well as OS benefit. So in this particular trial, they have not allowed the chemotherapy, so previous 2 lines of hormone therapy or 1 line of hormone therapy with some conditions that I will come. So only those type of patients were challenged with TDXT versus chemotherapy. So we know that this is the current strategy for hormone positive HER2 negative metastatic breast cancer. So with endocrine therapy plus CDK4/6 inhibitors with first line, we know the PFS is around 2 to 2.5 years. And in the second line, PFS with endocrine therapy plus targeted treatment is 5.5 months. Endocrine monotherapy is around 2 months. And in the third line, if we use the chemotherapy, single agent, it is around 6 to 7 months, and with TDXT, it is around 10 months. So we know that HER2 low, now HER2 ultra low is among IHC 0, where there is faint or incomplete membrane staining up to 10% of the tumor cells. So this was the study design presented by Professor Kurigulano in this ASCO. So hormone positive metastatic breast cancer with HER2 low and HER2 ultra low variety were taken, and chemotherapy naive patients were in the metastatic breast cancer. Although in the adjuvant, the chemotherapy as per the treatment, it was allowed. And either 1 line of prior hormone therapy or 2 lines of prior hormone therapy was allowed. So where 1 line of prior hormone therapy was allowed, so there 2 additional criteria was there, that is recurrence within 2 years of starting adjuvant endocrine therapy or progression within 6 months of starting first line endocrine therapy plus CDK4/6 inhibitors in the metastatic setting. So these patients were randomized 1:1 TDXT versus physician's choice of chemotherapy. So options were capecitabine, nab-paclitaxel or paclitaxel, and the primary endpoint was PFS in HER2 low variety. Secondary endpoints were PFS in ITT population, that is HER2 low plus HER2 ultra low, then OS in HER2 low and OS in this ITT population. So this was the statistical analysis was taken. So at data cutoff point, there was nearly 457 BICR associated PFS in HER2 low, and during first interim OS analysis, there was 282 events in HER2 low and 335 events in ITT, overall ITT populations. So after screening, 866 patients were randomized between these 2 arms. Regarding treatment discontinuation, nearly 80% in the trastuzumab deruxtecan arm and nearly 90% in the TPC arm. And so this was the patient's demographic and baseline characteristics. So if we can see that primary endocrine resistance was around 30% in all 3 varieties, that is HER2 low plus HER2 ultra low and HER2 ultra low separately. Visceral disease was around 80 to 85% cases, and liver mets were nearly 2/3 of the cases. And regarding prior lines of therapy, so majority of the patients had prior 2 lines of therapy, that is nearly 2/3 of the cases, and rest patients are either having 1 line of therapy or 3 or more line of therapy. And prior chemotherapy was around 50 to 55% patients across the groups. So we know, because in different conferences the results are coming. So TDXT arm has shown the PFS 13 months versus TPC 5.1 months. So remember, if we see the DESTINY-04, it was results were 13 versus 8 months, but here it is more separation of the curves. And this is for the ITT population. These PFS results also corroborating with the primary PFS, primary result, low, ultra low, and together the PFS benefit was there, but OS has not been reached. So this was the subset analysis for the primary endpoints. We can see the majority of the subset have shown benefit in favor of the TDXD arm, including where the liver mets were there, primary endocrine resistance, so all the varieties. And this is the response rate. So we can see the objective response rate was 56% versus 32% for HER2 low. And for HER2 ultra low, it was 62% versus 26%. The clinical benefit rate was also 76 versus 53%, and actually all the subsets it was better. I will just take 1 minute more. Regarding treatment-related adverse events, so grade 3 or more adverse events were 40% versus 31%, and discontinuation rate was 14 versus 9%. And death rate was 1.2 versus 0%. And if we see the major toxicity for treatment discontinuation for trastuzumab deruxtecan, it was pneumonitis 5.3%, and TPCM it was peripheral sensory neuropathy 1.4%. And this was the common toxicity that happened more than 20% of the patients. So hematological toxicity were common in both the arms. And adverse event of special interest, so pneumonitis grade 3 or more, it was 0.7 versus 0% in TDXD, and left ventricular dysfunction 0.7 versus 0.2, and cardiac failure 0 versus 0.2%. So we have come to the conclusion slide. So TDXD demonstrated statistically significant and clinically meaningful PFS benefit versus physician's choice of chemotherapy in hormone-positive HER2 low in metastatic breast cancer in an earlier line of treatment than DESTINY-4. Results in HER2 ultra low were consistent with HER2 low. Confirmed objective response rate of 57.3% versus 31.2% in ITT population, and no new safety signals except interstitial lung disease. So, so as per this DESTINY-06, it established again TDXD as effective new treatment options for patients with this population, that is HER2 low and ultra low variety of metastatic breast cancer following one or more than one line of endocrine based treatment. So thank you, and any question? Thank you, sir.
I think before we proceed further, can I ask you one question, Dr. Jasper? Yeah, can you take one question, Doctor? Hello? Are you able to listen?
Yes, of course.
I wanted to ask you one question. Whether during all your presentation, you did not mention much about the addition of carboplatin. Even the TCH is a very famous combination which is used for the HER2 positive breast cancer. So what is the value of carboplatin?
No, I mentioned it because in the TRAIN trial, this is the combination used. Of course, as I said, we can omit for sure anthracycline in patients with HER2 positive disease, and the results of the TRAIN trial clearly demonstrate that there is a huge benefit also from this combination with the equal pathological complete response, and of course also with less toxicity, because we have less cardiac toxicity and less impact on the long term. So I completely agree with you. This is an excellent option, and for sure in many patients we can omit the use of anthracycline and use the combination of carboplatin and paclitaxel.
Thank you very much. I think now we will proceed to the next presentation.
This session, we are skipping this.
Destiny. We'll proceed with the next presentation. Dr. Harshvardhan, medical oncologist from American Oncology Institute, Hyderabad, is going to talk to us about.
Good afternoon, everyone. Today I am going to discuss about Destiny Breast 12 primary results discussed in ESMO 24. that is trastuzumab deruxtecan in patients with HER2 positive advanced breast cancer with or without brain metastasis. Approximately around 50% of the HER2 positive MBC develop brain metastasis. So, and as we know, promising preliminary evidence is there for TDXD intracranial activity in HER2 positive MBC, but all are small prospective patient cohorts, retrospective studies and exploratory analysis with an intracranial response rate of 44% to 73%. This is the trial design of Destiny Breast 12. So this is the largest prospective study of TDXD in patients with stable or active brain metastasis. Inclusion criteria were HER2 positive MBC received less than 2 prior lines of therapy in the metastatic setting. That is, tucatinib patients were excluded. No known suspected leptomeningeal metastasis with ECOG performance status 0 or 1. It is a single arm 2 cohort study. One cohort has baseline brain metastasis which include stable brain mets which were treated previously, or active brain metastasis, that is untreated or previously treated, which are progressing now. And the primary endpoint for this cohort was progression-free survival, and additional endpoints were CNS PFS, overall response rate, and CNS overall response rate. Other cohort was no baseline brain metastasis group. The primary endpoint was overall response rate, and there was no formal statistical comparison done between the two cohort of the patient. And in the baseline brain metastasis patient, 263 patients were included. Stable brain metastasis patients were 157, and active brain metastasis patients were 106. And median follow-up duration was 15.4 months. And patient discontinued TDXD therapy due to the most common cause was progressive disease. And coming to no baseline brain metastasis group, there were 241 patients included, and median follow-up duration was 16 months. And in this group also, main cause for the discontinuation of TDXD was progressive disease. Coming to the baseline characteristics, if you observe in both the cohorts, HER2 positive status was in 62% in both the groups, and around 7% of the patients received TDXD as a first line, and 50% of the patients received it as second line, and 40% of the patients had at least received 2 prior lines of therapy. Most common anti-HER2 therapy was used was trastuzumab and pertuzumab, and DDM1 was received in 40% of the patients. Coming to the results, primary endpoint in baseline brain metastasis patient were progression-free survival. 12-month PFS was in overall population was 61.6%, and median PFS was 17.3 months. And it is more consistent in stable and active brain metastasis patient, that is 62.9 to 5.96% respectively. And the similar benefits was seen in the CNS progression-free survival also, which was 12-month CNS PFS was 58.9%, and which is also consistent in stable and active brain metastasis patients. Coming to the overall response rate, which includes intracranial and also extracranial disease, it was 51.7%, and which is also seen substantial responses seen in both stable and active brain metastasis patients. And if we restrict it to measurable disease at baseline, it was around 64%. And CNS overall response rate was also remarkable. Sorry for the slide. It was 71%, which is more so in the, which was consistent in both stable and active brain metastasis patient, more so in the active brain metastasis patient, which was around 76%. And no baseline brain metastasis cohort, primary endpoint was overall response rate, which was 62%, which is inconsistent with the previous phase 3 TDXD trials. Coming to the overall survival in patients with or without baseline brain metastasis, 12-month OS was 90.3% in baseline brain mets cohort compared to 90.6% in the no baseline brain mets cohort. And there was no medial survival was calculated, overall survival was calculated as 2/3 of the patients were alive at the data cutoff. There were approximately 50% of the patients had more than grade 3 adverse events, and AEs leading to discontinuation 15% in the baseline brain metastasis patient and 9.5% in the no baseline brain metastasis patients. And if you observe in both the patient cohorts, the side effect profile was similar, but there was no statistical comparison was made. And most common side effect was in nausea, followed by fatigue, followed by constipation and neutropenia. Areas of special interest, there are around 0.4% of the grade 3 ILD pneumonitis was observed, and of all grades it was 16%. There were 6 patients died in the patients with the brain metastasis cohort due to the ILD, and out of which 4 patients had a coexisting opportunistic infection. When patient was treated with prolonged steroids, there was no PCP prophylaxis was given. So out of 4, 3 patients had PCP pneumonia and 1 patient has aspergillus pneumonia. And in patients without brain metastasis patient, 3 patients died of pneumonitis. And coming to the LVEF decrease from the baseline, there were no grade 4 or grade 5 occurred in LVEF decrease from the baseline. Okay. In conclusion, TDXD exhibited substantial, durable, overall intracranial clinical activity in large patient cohort of HER2 positive MBC with stable and active brain metastasis. 12-month PFS was 61.6% overall, and the CNS overall response rate was remarkable. It was 71.7% overall. In stable brain metastasis, it was 79%, and in active brain metastasis patient, it was 62%. TDXD activity in patients without baseline brain metastasis was consistent with the previous report. It was 62.7% overall response rate, and 12-month OS was maintained in patients with or without brain metastasis patient. The safety profile of TDXD was consistent with the previous reports. No new safety signals were identified. ILD pneumonitis remains an important identified safety risk of TDXD. And results from the DESTINY breast will support the use of TDXD for patients with HER2 positive MBC, irrespective of the presence of stable or active brain metastasis. Thank you.
Thank you very much. I think we'll move on to the next presentation. Dr. Harshvardhan Atreya is going to present. No? Okay. Fine. Then now I request our chairperson, Dr. Senthil Rajappa, to take over and conduct the panel discussion.
Thank you, sir. Good afternoon. We are aware that we are running behind time, so we will try to quickly wrap this up. Can I call my panelists, Dr. Prabhat, Rajiv Rajendranath, George Jacob, Dr. Rakesh Mishra, and Ullas. And we also have Dr. Crigliano online. So we will discuss 3 abstracts. We'll quickly wrap them up. I've removed the emerald which was supposed to be discussed. I've put in patina instead of that, which again Professor Crigliano was mentioning during the course of his talk. Okay, let's start with the HER2 low story, because that's one that's, should I say, trending, as they say these days. So Professor Crigliano, you are around?
Yes, I am here.
Oh, yes, sure. Thank you. Right, so let's start with our panel here. Prabhat, your pathologists are now clearly reporting 1+, 2+, of course 2+ with FISH, ultra low.
What I discussed with my pathologist is the ultra low is by a pharma company, not by the Association of Pathologists till now, because ultra low, it means you are saying something as ultra low, but essentially it is normally present in the cells. So okay. The word ultra low will mean that something is normal and you are saying ultra low. Just a friendly discussion with the pathologist.
Friendly discussion with the pathologist.
So essentially it is not ultra low, it is normal.
it is normal. Yes, Vilas, you wanted to say something.
Same here. They are very, they are not taken it like a fish to water. They don't want to report ultra low.
They don't want to.
Again, some intra-observer reliability and intra-observer variability is there. They don't want to do that.
So, Dr. Crugliano, your pathologists have started reporting ultra low, and what's the reliability of reporting ultra low in a center of excellence like yours?
No, my pathologist is not reporting ultra low.
Okay.
The pathologists there are completely right. So we report the ASCO cap definition, so 1+, 2+, and if we want to identify the so-called ultra low, the pathologist will report more than 0%, less than 10%. But this is not a pathology definition. Completely agree with the panelists.
Okay, so they'll say it's less than 10, but not completely negative. So that's how they will report an ultra low.
They write more than 0%.
More than 0%, less than 10%.
Yeah,
less than 10%. Yes. Okay, so that's how they will report. They will not label it as ultra low.
What is the low?
So anything that's 2+ fish negative and anything that's 1+ is low. So and then you go to ultra low and then you go to negative at some point. And George, tell me. You have the mic in hand.
Anything other than 0? I mean, ultra low.
We'll come to that in a moment. We'll come to that.
0 but less than 1.
Yes. So George, how many times will you rebiopsy patients with HER2 positive breast cancer or HER2 negative breast cancer, hoping that you will get some 1+ at some point in time, because there's some studies to show that if you keep repeatedly biopsying them, you'll get a small percentage that will become positive. Do you do that in practice?
I've done it to find if it's HER2 positive, but low, ultra low, no.
You have not. No, not ultra low. I think we leave the ultra low. We said that we are not reporting it routinely, but how frequently, or have you done this repeatedly? No. Yes, Ullas, you seem to be grabbing the mic from him.
Sure. So there are two things. When the patient irritates you a lot, and the patient's performance status is okay, a lot of financial money, we have actually got ahead and said, okay, let's just try to do a biopsy once again and see if it comes with HER2 1+. We can then probably give him her TDXG.
Okay, so yes. Do you do that?
I think, as Ullas was telling, mainly as signs of desperation. And if the biopsy was done quite long back, then we'll ask them to recheck the same HER2 again to see that if that they're reporting as different this time. But very few patients I would rebiopsy.
Professor, have you? Is that become part of your regular practice to get some patient who has probably exhausted many of the treatment options, and then you want to see if she will be eligible for TDXD? Do you do that frequently in your practice now?
Oh yes, of course. I used to do a rebiopsy only for patients that were defined at their 2-0 at the baseline. And so first I verified if their 2-0 is according to the most updated ASCO cap, because of course the ASCO cap of 2013 was completely different of 2018. And if a 2-0 at the baseline, I reperform a biopsy asking the pathologist, is any staining will be present 1+ or 2+. So I do specifically for many patients at 2-0 in baseline.
Okay. So if it's a HR positive or TNBC.
One more point.
Yes.
A friendly discussion with the pathologist.
All of you seem to be very friends with your pathologists, it looks like.
Certain pathologists.
Okay.
Not all pathologists.
We'll discuss over lunch. Go ahead.
Yes, we will. Previously, they only used to concentrate on 3+ and 2+ in fish. Anything which was 1+ or 0+, they would tell us that, we will just report as negative or we will report 0. So they were not reporting 1+ and 0 separately actually in the bygone eras when it was not necessary. So again, as Dr. Rajiv said, if the biopsy has been a long time back when the pathologist was not very nice, we would actually want to do a biopsy again and do.
Very good. So I think all of us should go back to a pathologist and tell them to report 3+, 2+, 1+ and negative. If you still want somebody to say ultra low, they will not say, but they are probably ready to say it's between negative and less than 10%, and that may or may not mean anything to you. So that's one problem or one part of the story. The second thing is, if you've had somebody who's negative for HER2 at the time of diagnosis or even in a first biopsy, and then you want to see if she is likely to be a candidate for Destiny, then you probably will want to go and rebiopsy them to see if there's a 1+ that might come up sometime later, because there's data to say that if you repeatedly biopsy, the probability of picking up somebody with a low HER2 seems to increase. So that's about rebiopsy. Rakesh, what would you do? Would you like to do? So I put this table here. This is a comparison of DB04 and DB06, as Professor rightly pointed out during his talk. It's a slightly different setting in which these trials were done. The difference predominantly is that in DB06, you have an overall survival benefit. The numbers in terms of the hazard ratio compared to chemo for PFS, the response rates, everything seems to be as good as if you did it earlier, right? And there is an overall survival benefit. So just for discussion / argument's sake, if I say use chemo first and then use TDXD in the second line, would you be okay with that, or would you say, no, I want to push a good drug first and not keep it for a later date? What would be your thoughts on that?
So I would push good drug first.
Okay.
Because the PFS is better if the patient is affordable.
The PFS is not, the delta for PFS is not different whether you use it in the second line, or when I mean second line, I'm talking about first line versus chemo or second line versus chemo. The absolute numbers will obviously be different because it's a later line therapy. But if you look at it in comparison to the chemo in the study, it doesn't seem to be very different. So that's the reason why I'm asking you this question. You want to use it earlier? It's fine to use it earlier. I'm just asking you for your thoughts.
Yes, I'll use
it earlier.
Yes.
Fine. George, would you also use it earlier, or hungry? Breathless?
I probably would.
You probably would. It's okay to do. Rajiv?
Again, I think multiple factors.
What are the multiple factors?
The volume of the disease, and whether I can get away with oral capecitabine for a few months and then go on. And of course, the finances we need to.
So you are saying it's okay to delay it to a later line?
I would, yeah.
You would not be against delaying it to a later line. Professor, I want to ask you this question. Considering the fact that in most places TDXD is approved for use, patients in the control arm of the DB06 are likely to get it at some point in time, and do you think DB06 will end up in an overall survival benefit because patients will have access to TDXD? When DB04 was done, patients probably didn't have access, so it was easier to show a survival benefit. But with DB06, what are your thoughts? And also, I want you to also answer the question that I was putting to our panelists. Would you keep it for a later date or use it earlier? So these two questions.
No, personally, I don't believe we will see overall survival data that would be positive, because of course all patients on the chemotherapy arm cross over, the radio will cross over to trastuzumab deruxtecan. But I believe that in some patients you need to anticipate the use of trastuzumab deruxtecan, because you can imagine there will be for sure an overall survival benefit. And the data presented by Dr. Aditya Bardia in San Antonio, in subgroup of patients rapidly progressing also to CDK4/6 inhibitors, the benefit of trastuzumab deruxtecan is really huge. So maybe not all patients should receive it before, but many of them, personally, I believe yes.
Okay, right. So even if there's no overall survival benefit, it's okay. That's point number one. Point number two, some patients might actually benefit with earlier TDXD than delaying it to a second line in comparison to chemo. Anybody in the panel, would you, if your pathologist says between 0 and 10, would you try TDXD at some point in time based on this 20% of the DB06 patients, or you would say, no, this is too little, I'm not happy with this data, I want more data? Rakesh, let's start with you. Are you happy to use it? You're not happy to use it?
So if it is ultra low, then definitely after the chemotherapy in the second line setting.
Second, after chemotherapy. Okay.
Yes.
So, and which line that after chemotherapy immediately?
After post hormonal progression, chemotherapy, if it's not working, then we can go.
Okay, fine. Ullas?
Use it sometime down the line. I mean, somewhere down the line I would want to use that.
Because the activity seems to be preserved irrespective of the lines, you will probably use it somewhere down the line. Professor, what would you do if somebody said 0 to 10% and you didn't have too many other good options for this patient? Would you throw in TDXD at some point in time for that patient?
Oh yes, of course, it's still not approved, but if there is the opportunity to give out of pocket and there is no financial problem, I would do for sure.
Okay, excellent, very good. So think about it if you have somebody with an ultra low, not necessarily upfront, but at some point in time, because all of us run out of options for our patients. So that's about DB06. Let's get on to the PATINA. PATINA is an excellent study. I thought it's, at least in my mind, a practice-changing study. These were patients who had the induction phase of trastuzumab, pertuzumab, plus chemotherapy for HER2-positive metastatic breast cancer in the first line. And the randomization happened after the induction phase for patients who had a CR/PR or stable disease. The randomization was to palbociclib AI plus trastuzumab, pertuzumab versus trastuzumab, pertuzumab, and endocrine therapy only. So the CDK4/6, which is palbociclib in this setting, is the drug that we are testing. And some phenomenally impressive numbers, I thought. For the palbo anti-HER2, dual anti-HER2 and endocrine therapy, the PFS was 44 months, a whopping 44 months. Even in the hormone therapy arm, it was 29 months, which I think is still much better than what you got in the PFS of the Cleopatra study. So does anybody in the panel think this is not practice changing? George, mic closer.
Monday morning I'll do this.
Monday morning, excellent. Monday morning you will do this. I think that makes sense to do this Monday morning. Professor, this overall response rate of 69%, do you think it's a little lower compared to what you saw in Cleopatra? And is the reason because these were patients who are ER/PR positive? Was that the reason? Because on the Cleopatra you had a response rate of around 85%?
You know, personally, I believe this is a triple positive population. Maybe there can be also a bias of selection in these patients because the median progression-free survival of the PATINA is very huge, much more than the Cleopatra trial.
Yes.
It's 44 months. So we need to better understand who are these patients, why there is a so long-term benefit from this quadruplet combination in some cases. And don't forget potential problem of financial toxicity, because if you have to add palbociclib to pertuzumab, trastuzumab, and endocrine therapy for a median of 44 months, it's a huge cost. So I agree with you, this is practice changing, and this will open again what to do after first line TDX, because in a few months we will have the DESTINY-9. And so maybe we will stop TDX and we will give this quadruplet or triplet combination in the maintenance setting. But I am not surprised about the response. I believe it's close to what we observe in the real world for HR positive, HER2 positive disease.
So we are happy seeing this result, Professor, because palbociclib is now generic available in this country, and it is easy for us to put patients on palbociclib. In fact, I'm very delighted to see this, because tomorrow if DB09 comes, I actually wanted to ask you that question. Tomorrow if DB09 comes and you find that the PFS for DB09 in the first line obviously is around 35 months, and you've got this option which gives you 44 months, how would you really put this data to practice? Would you do Cleopatra followed by PATINA, or rather would you do PATINA, or would you do DB06 and then follow it up with something, or stop DB06 at, I'm sorry, it's not DB06, DB09. So would you stop DB09 at some point in time and put them on hormone therapy? How would you really incorporate results of DB09 if it is positive in comparison to what you're getting in PATINA?
DB09 will be for sure positive. We expect almost 3 years of median PFS. I don't believe all patients can continue on TDX for a long time. If you just check the available data, 20% of patients stop due to toxicity. So personally, I believe we can stop trastuzumab deruxtecan. We can go on a PATINA regimen. We have also other trials, one with inavolisib for PI3 kinase mutant, and the other one with the METER trial, in which after response to trastuzumab deruxtecan, you stop and you maintain with pertuzumab, trastuzumab subcutaneous, plus or minus endocrine therapy. So personally, I believe the PATINA trial will impact also on the DESTINY-9 results, because many of the patients that will respond to first-line TDX will go on a PATINA regimen.
Excellent. So you're saying that we'll do a non-chemo regimen to begin with and then transition them to PATINA rather than the Cleopatra and transitioning them to PATINA. But for us, I think it will be easy.
Maintenance, yes, I would go for triple positive.
So for us, it will actually be much easier to do Cleopatra followed by PATINA because we've got generic pertuzumab now, we've got generic palbociclib now. So if the PFS is not very different for DB09, I'll be quite happy doing what was done in the PATINA rather than jump to DB09, but I think it depends upon where all of us work in and what kind of patients we see and what is reimbursed and not. We've got 2.5 minutes to go. I've just got some specific questions. Professor, this question is for you because the green one or that set of lines are from the ABC recommendations, and the other cut that I put there in the center, the screenshot that I put there in the center, I think you're a member of this committee also, the brain metastasis protection primary prevention consensus group, which is published its recommendations early 2025. So there's a dichotomy in the recommendation that I see here. In the ABC consensus, it says brain imaging should not be routinely performed in asymptomatic patients, and 85% of them voted in favor of that. But in the primary prevention of brain metastasis consensus statement, following the diagnosis of HER2-positive breast cancer, asymptomatic patients should be screened with brain metastasis with a contrast-enhanced brain MRI. 70.6% of respondents or people in the panel said yes for this. Within 6 months, there's a big jump between not doing versus doing. So what is the thought process behind the recommendation that have been made in the primary prevention consensus group versus the ABC consensus group? Any thoughts on that?
This is of course a consensus, and some questions can be raised in a specific context, some others in another context. Personally, I believe what we do in clinical practice for any patient with metastatic HER2-positive disease, usually perform a total body CT scan, including brain, and if in the brain there is something that is not clear, I will perform MRI. So I do not screen routinely with MRI patients with HER2-positive metastatic breast cancer, but for sure, when I reevaluate the disease, I perform a total body CT scan.
Right.
I believe this is an important point today because we have active agents, and so we saw the data of DESTINY-2F, but also the subgroup analysis of the DESTINY-3 was very similar. If you have small lesion, HER2 positive, now we have so many good options, TDX, tucatinib, that you can also delay radiation therapy. So discovering earlier small brain lesion gives to you the opportunity to treat with potentially active agents and to delay radiation therapy.
Excellent. So I think we are reaching the lung cancer oncologist very quickly with TDXD and tucatinib, I suppose. 1, 2, 3, 4, 5. So 5 of you. If I make a statement saying TDXD has, based on DB12, TDXD is as good or better than tucatinib in the brain, how many of you would agree that? Raise your hands. 5 of you. If I make a statement saying based on the DB12 data, TDXD is as good or better than tucatinib in the brain, you agree, you disagree? 5 of you. All of you are like this, either, yes. Okay, 2, 3 of you agree. Rakesh, you don't agree? You agree? So all the 5 of you. Professor, do you think it's time for us to say, rewrite the ABC guideline to also say that if it's a brain met and fits into the criteria of both the HER2 climb and the DB12, these are both equally good drugs, or would you still say a TKI is better? That's something that you mentioned during the course of your talk. So what would your thought be based on all the data?
I don't believe a TKI is better. Personally, in the second line, I would go first with trastuzumab deruxtecan, and I would reserve the TKI in the third line.
Excellent.
This is what we are currently doing in my hospital.
Very nice. So I think everybody agrees to the fact that TDXT is as good in the brain or maybe a tad better based on the DB12 beta compared to tucatinib. I think our time is up. We won't have any more. Yes,
One question.
One question.
So are we doing MRI brain in asymptomatic people also?
No, we are not doing, but Professor is clearly saying that over time, I think that consensus that I showed is more from a clinical trial standpoint. I would have loved to. Professor, one last question. Is there any data, DB12 or HER2 climb, on the brain protection effect of these two drugs? Because lorlatinib in ALK positive lung cancer, 16 months, 16-month data, and then if you fail only in 2% or 2 patients out of 118 patients, and if you don't end up there, you don't get brain met at all in those patients for 5 years. So do you think TDXT or tucatinib will get there? Is there any data on the brain protection effect of these two drugs?
Now, we will have, of course, the DESTINY-5, that is the trial in the post-neoadjuvant high-risk HER2 positive, that compares TDM1 and TDX, and we have also the HER2 climb 05 in the post-neoadjuvant setting, TDM1 and tucatinib. So we don't have now this data in terms of protection of brain mets.
Okay.
We have in the metastatic setting, of course, a delay of brain progression. This is very clearly demonstrated in their HER2 climb, and we are going to generate now the data in the DESTINY-12.
Excellent, very good. That will be very interesting to see, because then the question of doing MRIs in patients with asymptomatic brain mets and so on and so forth will become much more relevant. Sorry, we don't have any more time, though we would love to ask Professor many more questions. So thank you so much, Professor, for being with us this afternoon. And thank you so much, all of you. Thanks so much, panelists. I hand it over back to Professor Advani for the concluding remarks. So. Mike.
Yeah, I think today the whole symposium has really taught us how to use, when to use the newer and newer HER2 targeted drugs. And I think there are very finer points which have been explained, and I think it is a time also for us to learn more about it, and so that ultimately we can identify where to use for the maximum benefit. Thank you very much.
Can we go? Can take a cookie? We can take a cookie.
We will break for lunch now, and we'll resume in half an hour, so at around 2:15. Thank you.
hospital regarding that which patient we call it curative and which call it palliative, and I'll show you the examples that is it the right word to use in today's time. Sure, there was a time when this word was started and we have been using it. So starting with the first example, and this is the first example showing on this side is, which is obvious, this is CA pancreas patients where the randomized trial, and what we see that you have done surgery, then you have given chemotherapy. Surgery we can call it curative. I am sure none of the surgeon will say that they are doing palliative surgery for these patients. I am certain about it. And what is the progression-free survival? 6 months. That is the median progression-free survival. And what is the overall survival? Around 20 months odd. What we call it? We call it curative. And I'm just putting an example. When we call it palliative, I'm sure everyone knows this curve because this is a recent curve, lorlatinib given in lung cancer, metastatic setting, and this is not overall survival data. This is the OS data. This is not overall survival curve. This is a PFS curve. So what you have at 5 years, 65% patient being progression free. Make it OS, it will be some 80%. Now, a tumor where you give a treatment, the 5-year survival is around some 80%, and you have a tumor, you give so-called curative treatment, median survival of 20 months, you say, hey, this is curative, this is palliative. Again example, 5-year survival of 5-year PFS of 65% in this example, and PFS of 6 months. Again I repeat, please check, it's called CONC 001 study. It's a 6 months, it has not changed much. With some adjuvant chemotherapy, things are a bit better, but we call it curative treatment. So this needs to change in our era. Now, when I'm saying this, is this a lone example or there are multiple situations in our time as compared to what when I was growing up and when I was student? I'll give you another example. And this is one is what, and we had some dialogue about it, that standard arm teaches you a lot. And what is the standard arm? This is chemoradiation followed by osimertinib. This is the arm. This is chemoradiation. This is what you get. Add 3-4 months more to it because this was after chemoradiation that you added tablet. And again, give you another example. Same curve. We call it, this curve is curative and this curve is palliative. This is what we use in our clinic. This is what the connotation is. It is a fair connotation as far as the patients are concerned, because remember, the moment we use the word curative and palliative, I repeat again, I can't say about what happens in your centers, but there is an implication in a center like ours. The resources, the manpower, the ICU, the beds, those becomes an issue about when we call curative and palliative. I can show many examples. These are some of them. These are immunotherapy neoadjuvant setting. This is again showing you esophageal cancer patient. Oh, this is not clear. Esophageal cancer patient, famous trial, and the only trial for radiotherapy versus chemoradiation in esophageal cancer patient definitive setting. The 3-year survival in radiotherapy. Anyone can put their hands up. What was that? It is famous RTOG 085. 0%. And it was 30% in chemoradiation arm. So radiotherapy arm. So can you imagine a radiation oncologist giving radiotherapy in esophageal cancer patient as a definitive therapy alone and saying that he is giving a palliative radiotherapy? It will be tough to get someone to say that. But that was the data. Don't get me wrong. A bit older data because PET was not there. But PET can salvage a bit more. It looks better. But 3-year survival in this randomized trial, famous trial, this established chemoradiation as a standard treatment. Again repeating that curative and palliative in our era is not the same connotation what we had in the past. I can give many examples, prostate, kidney, but leave it here, highlighting the connotation for palliative and curative is different, and this is true for head and neck cancer also. There are some other examples, but I'll come to head and neck cancer now. We'll come to head and neck cancer, how this is, this will change the way we are perceiving same palliative and curative. But before that, how does the head and neck cancer feels? that is important to know that how do you give systemic therapy in patients who fail after treatment in head and neck cancer. This is our own data. This is the 10-year survival data for our patients who received in borderline setting neoadjuvant chemotherapy, and then they went for definitive treatment based on what the response was. But this curve is similar what you get in almost any head and neck cancer as far as the pattern is concerned. So what happens? A steep drop in curve initial year or two. That happens to almost whichever kind of treatment you give in head and neck cancer, either surgery or radiotherapy based treatment. And after usually 2 years, majority of the patients, they survive. They will survive. Usually they don't die because of disease being recurrence being there. They usually will die of something else. So majority of the patients, they relapse within 2 years, and out of those patients, almost 80% of them, they relapse within 1 year. So this is the overall pattern of the recurrence of the head and neck cancer. And second part is that which is very obvious, that they usually recur locoregionally rather than distance. Now, what are the treatment options in this setting? And we'll talk about starting with what patient wants and what do we do. Is there a role of palliative care? How do you manage the distress? And what are the palliative systemic therapy available for our patients? Starting with what our patient wants, and this is what our work. I think the slide has gone a bit haywire. But anyway, so what did we do? We asked our patients, what do you want? Many times we are very fascinated with OS curve, and which should be. Why not? We all want ideal endpoint for our patients. But then idea is that what patient wants, this is what we decided. And what we realized that almost we can put it in 3 groups. One group of patients, they say symptomatic relief is good enough for them. 1/3 where they're almost, who said, hey, we want overall survival benefit as an outcome which interests them. But 1/3 where who will say we want combined. What it suggests that you have a different patient wanting different kind of outcome from the treatment you give, and that becomes important. As much we may be fascinated with overall survival, and which you should remain, but having said that, we should not lose the focus of other endpoints. Why I am highlighting this? Remember, in all guidelines, head and neck cancer, till cetuximab came, chemotherapy was a treatment option. Before that, there was none, I repeat, none. Randomized trial which had ever shown that they improved survival. Meaning that clinicians were taking decision based on what patient wants as a treatment option of chemotherapy, which does relieve the symptom, and it may be useful for our patients. Second, one of the important issues is early palliative care. So we do know, and we also do it. Again, looks like slide has gone bit haywire. Not sure when I transferred, but anyway, the message is that today what we do, we have any patient with metastatic setting, and we do send the patient to early palliative care. Now, do we do this based on the very good evidence? And what did we do? That we do it, we also send it. We do realize that not necessarily that is true. This was a randomized trial we did, early palliative care versus not early palliative care, and there was no improvement in quality of life for the patients who went for early palliative care. Now, do I mean to convey that don't send the patient to early palliative care? No, I'm not saying that. And highlighting that was the primary endpoint, but that's not the message I'm giving. For overall quality of life, this was negative, but for symptom control, early palliative care patients were better. What we forget that quality of life, you have those 40 odd parameter. When you combine, not necessarily you will always get a positive result. But for symptom care, if you put pain, head and neck pain becomes important issue in the symptom, and that you see the improvement. So yes, early palliative care is important, but remember, not the same way what we read in the literature. You can stratify those parts in your clinic the way you want to implement it. So early palliative care remains as an option for sending the patient, but in a stratified way, the way you want to use it in the clinic. And also highlights the primary endpoint doesn't become the part of your decision making always. So again, I see that many times we get fascinated and rigid about that primary endpoint was negative for the study. And I'm giving you an example. And so you can go back and check. There are half a dozen randomized trials, except one we all remember, Tamil. All early palliative care trial was negative for quality of life for primary endpoint. You can verify that. And that doesn't mean, have you stopped it? No. If you see the secondary endpoint, it looks like it is meaningful. So we do send patients of head and neck cancer for early palliative care where symptom controls become better. And I give you an example where other symptom becomes confounding. You will have speech and swallowing issues. The problem is that the speech and swallowing issue is primarily because of the surgery being done and radiotherapy being given. That doesn't, you may have a tumor, but that doesn't recover, that doesn't improve because that is there in spite of a disease size decreasing. So you do have confounding factors to see that early palliative care works or not. Now, distress evaluation, and because we had an issue of not sure it happens at everywhere, we don't have many psychologists and we don't have any psychiatrists in Tata Hospital. So we have this limitation. So we did the work. Can doctor's intervention means that the treating doctor intervention can lead to decrease in distress. So first, these are all the factors the people put. These were the reasons for distress. So almost everyone is distressed when they come to our hospital. What we did is let the counseling happens with the treating doctor. And what we realized, the treating doctor saying some good words has an impact, and almost half the patient distress comes down. If it not, then you send to a psychologist, and then 75 or 80% patient benefits. Highlighting some kind words from the treating doctor is useful. Again, repeat, someone can put their hands up and say, hey, we have got a good psychology center, good psychiatry center, perfectly fine, please send it. But in case you don't have it, you do have other option which may help your patient. Now, coming to palliative systemic therapy, we have known this. So again, this has gone bad. So this is showing that single agent and double agent, what happens if you use chemotherapy in the clinic. What it suggests that you have responses which is higher with double agent chemotherapy, but doesn't look like giving more chemotherapy benefits patient more as far as overall survival is concerned. That was the gist of this slide. You have a whole lot of targeted therapy. Looks like all the slides have gone a bit haywire, but anyway. So looks like you have a whole lot of targeted therapy, but apart from cetuximab, doesn't look like anyone works meaningfully so well that we use in the clinic. You do have targeted therapy, which is useful, and this was in fact the first randomized trial which showed that if you add something to a patient in chemotherapy or whichever way you use it, it adds life to the patient. And this was the first randomized trial in head and neck cancer to show survival benefit. A small number, but it does. You do have some data regarding HRAS inhibitor. Looks exciting, and we are still waiting. It's now almost 3 years. Not sure why it has not moved forward, but response rate of around 40%. You don't get in head and neck cancer in second line and beyond setting with any treatment. So it is a bit surprising that it has not moved forward as far as the recognition for this drug is concerned, but this data looks exciting. You have some data for, again, we call extreme regimen, 5-FU platinum cetuximab, and compared to docetaxel platinum and cetuximab. This whole slide has gone totally color change ho gaya. What happened when I... Achha, okay, thank you. so the moment the cetuximab came, color changed. So having said that, it looks like you can interchangeably use it. Again, highlighting here in case people who have an interest in doing randomized trial, the docetaxel platinum and cetuximab trial compared to 5-FU platinum cetuximab was a phase 2 randomized trial. Anyone can guess what was the sample size? 500. And this was called phase 2. So again, do we use it interchangeably? We do use it. Can we say, hey, based on phase 2, you change treatment? We'll criticize you. You don't. Not necessarily. Always all phase 2s are not practice changing. You do have practice changing. And I give you an example. I can give many of them. But having said that, these designs and those, the way we do trials are different. And again, I give you a number, 500 patients, and calling a phase 2 randomized trial. You do have subsequently immunotherapy being developed in second line setting on the platinum refractory patient. We had 2 drugs used in this setting, both of them strikingly good. One of them was statistically negative. That was, but FDA didn't remove the label. It continued to continued to have the label for pembrolizumab. But yes, both of them are good. What was striking is to see at 1 year survival. The difference was around 19%. Now, we have not seen this kind of difference in the past, and suggesting that immunotherapy has got some promising activity in this setting. Subsequently, we did have this famous trial, Keynote 048. My apology for the slide. This was not the slide I had given for uploading, and I had seen. This is all yes. Okay, but anyway, I'll summarize this one. So what is important is for Keynote 048 is the 4-year survival data. And what it showed, if you take extreme study, don't take extreme regimen in this study. In this extreme arm, the patient of significant proportion of patients received immunotherapy later. Go to the extreme which Dr. Varmarkan did. The 5-year survival was 5%. Now remember that number, and that gives you a clue when you have 5-year survival in the whole group of 20%, why it is important. 4-year survival of 20%, why it is important. Now take PDL1 more than 1%, it becomes around 28%, and around 29-30% if you take a TPS score of around 20%. What does it mean? 1 out of 5 patients, depending upon PDL1 score, or 1 out of 3 or 4 patients starts living beyond 4 years. I'll put some number to it. It will be important to see hypopharyngeal cancer patient treating with CTRT, 5-year survival of 30%, you will not get many series having. UV operate, T4 tumor and 2 disease. Please check this tongue, we have done total glossectomy. The 5-year survival of 20-30%, you will not get in those patients. Highlighting, again, coming back to what I started with, curative and palliative, you started getting a situation where you have a small, it is not a phenomenal big group, but when you had a 5%, then 20% looks good. So you have a small group of patients who will start living longer, and sure, this will have an impact, which we see in our clinic also. Vijay is there, we used to work together. When the responses becomes good, how our surgical colleagues are interested in operating patients whom they were not earlier, that you have patients who are responding well, now disease control for 6 months, 8 months, can we remove those residual, and which is important for our treatment also what we are giving, because it means those are not getting eliminated, can we add some other treatment to it? Showing the same thing that yes, it works, but I won't get into it because it is not seen, highlighting that you have 2 broad options, pembrolizumab alone, pembrolizumab plus chemotherapy, and cetuximab plus chemotherapy. And depending upon PD-L1 expression you choose these group of patients, sure, pembrolizumab alone not a good idea if PD-L1 score is less. Combining them with chemotherapy is a good idea, but be careful. If the PD-L1 score is really low or 0, maybe cetuximab plus chemotherapy remains as a good option in this setting. Now, as I said, I will be talking about what you can do in the clinic tomorrow. So I said, what I have talked about, unlikely more than 10% of your patients will be taking it. It has increased in last 6 months a year because of many schemes, but having said that. So what we did at Tata Hospital was, we were developing a treatment called metronomic chemotherapy, where we combine oral tablets used in 1/5 to 1/10 of the dose. Here it was methotrexate and celecoxib, and compared with cisplatin. This was the thesis of one of my first students, and he's here, Vijay, and it showed in phase 2 randomized trial, it is better as compared to cisplatin. We did a phase 3 randomized trial. Again, methotrexate, celecoxib, compared to cisplatin. 400 patients plus randomized trial, suggesting that it is non-inferior to statistically, because that was the design, it was a non-inferiority trial, but clinically better than giving only cisplatin based chemotherapy in this setting, with improvement in quality of life. Now, but the response rate was just 12% in these patients, so we were looking for, can we improve the outcome of these patients? What was done subsequently? A phase 1, phase 2 phase 1/phase 2 trial, and idea was de-escalating. Usually we escalate in phase 1. Here the idea was de-escalating the dose and combining with erlotinib, because we had some hint erlotinib works in in head and neck cancer patients, and what we saw is that in platinum refractory patient, 40% odd patient responded. As I suggested earlier, in head and neck cancer in second line setting, 40% patients respond. This doesn't happen so frequently. So we realized that this is an important drug combination which we need to take it further. So what we did, so we don't see again detail. We did a randomized trial as a part of CRSF group presented by Dr. Rishabh as an oral presentation in ASCO 2 years back, and what it compared in second line setting giving triple metformin chemotherapy versus physician choice chemotherapy, and it showed that if you give triple metformin chemotherapy, overall survival is better for these patients as compared to giving physician choice IV chemotherapy like paclitaxel or docetaxel or irinotecan, which we want to give. We were also looking for subsequently that can we explore this in first line setting. This was done by Dr. Akhil in Varanasi, TMH Varanasi, and what we did was combining in first line setting paclitaxel platinum and comparing them paclitaxel platinum plus triple metformin chemotherapy. So in first line setting, if you combine it, it looks progression-free survival is better and overall survival is better. If you take it around 1 year, there is absolute improvement in survival is around 19%, and which is very good by any standard, suggesting that in first line setting you have an option of combining triple metformin chemotherapy plus IV chemotherapy of paclitaxel platinum, which is better than as compared to giving paclitaxel platinum in this setting. Again highlighting, you can use it tomorrow in the clinic in case you want, in case your patient can't afford pembrolizumab in first line setting. We were also looking for, as the time went by, that yes, you do get good responses, but you don't have a sustained response. As you can see, the curves keeps going down. So idea was that can we add some immunotherapy to it, but how do we add it? We know that we can't, our patients, and as a trial, I can't afford having full dose immunotherapy. So this idea was that have a small dose of immunotherapy in this setting, and in this patients, when we combine triple metformin chemotherapy to immunotherapy low dose and compare with triple metformin chemotherapy, it appears that TMCI, that is triple metformin chemotherapy plus immunotherapy, is better, and overall survival improves apart from the response rate and PFS, and it is cheaper. It costs around 20,000 rupees per month. Having said that, I don't boast that this can be afforded by any patient, every patient coming to the clinic, but this is useful in our clinic for our patients. And as compared to in the past where 5% of our patients could afford immunotherapy, now with this regimen, almost 50% of our patients can afford immunotherapy in our clinic with this regimen. We got some recognition, so boasting about ourselves, we didn't leave it here. And this is an interesting one. And this is again part of CRSF, this trial was initiated. Asha was supposed to present, finally Vijay presented last year in ASCO. This was for performance status 3 and 4 patient. Please go back and check in NCCN. NCCN allows for performance status 3 patients to be given chemotherapy in head and neck cancer, which was not there earlier. I couldn't get a reference. I went back and checked where they got the reference from. But you do have a randomized trial now, in case you want to prescribe. And apart from this, I don't have any reference that if you have a patient with poor performance status in head and neck cancer patient, can you use palliative chemotherapy? Again, compared with best supportive care versus triple metformin chemotherapy, and what we see that you can give triple metformin chemotherapy and it adds life to the patients. So what I have done is, what I have shown you that you have in first line setting, you have in second line setting, you have in poor performance status patient, and you have immunotherapy. For all of them, in palliative setting, you have evidence from Indian investigator, which you want, you can use in the clinic. I again repeat tomorrow, because almost all of them can be afforded by most of the patients coming to your clinic. I need to thank all my colleagues. Again, this is all messed up. So my colleague, Dr. Vanita, Dr. Vijay, Dr. Amit Joshi, Dr. Amit Dutt for working together with us, my lab people who works with us, and my mentors and my collaborators. Thank you so much. Yes, please.
Biggest challenge, that is the interval progression. If after first cycle patient say has an excellent response after 15 days, that typically what happens. 15th to 21st day, patient actually tells you that tumor is progressing, what to do. So do we actually adapt something, or what would be your take on that?
So we better adapt, but I agree with you. This also we observed while doing DCF in our study when we were doing. We realized a good response in first week, second is okay, and third week. Not every patient. This will happen out of 100 patients. You will have 10, 15 of them which happens, and that worries. And again it goes down, and again it comes back. And that was one of the reasons to plan for a weekly paclitaxel protocol, and which we finally converted to weekly paclitaxel plus metronomy. There we don't see as many. There will hardly see many. You may have non-responder, that's a separate issue, but tumor going down and coming back. Right now we are comparing, that's a randomized trial going on, DCF versus pacli-carbo plus triple metronomic. But this data we have not collected separately. Once you are saying, then we realize we should have kept this data to be collected separately, what happened at the in between interval. But this is true that we don't see that problem in this part of it. But if they are responding and coming back, most likely they want to do good. As early you want to intervene with something else is the better idea. Yeah.
Right. Thank you.
If none, then thank you everybody. Thank you. So, and the next session is starts on the lung cancer, and in the lung cancer, the next session, the chairperson is Dr. B.N. Kapoor, and may I request Dr. B.N. Kapoor sir to come over and start the proceeding, please.
First of all, I thank Dr. Reddy for giving the opportunity to chair the session. And we'll move on the management of non-small cell lung cancer, optimizing therapy choices in non-small cell lung cancer. To start with, I would invite Dr. Professor Vijay Patil, who is the consultant medical oncology at Hinduja Hospital, and he will be speaking on ALK positive non-small cell lung cancer, past, present, and future. Dr. Patil, please.
So, when you play cricket, sometimes you are padded up and it is not your turn. And suddenly the other three batsmen are not ready and you are supposed to go. Actually felt like that. So, let me start with the topic. So, I'm not going to discuss that which is better, which is not better. And that's not my intent also to teach this August gathering, what should you give in ALK. I'm going to point out few things which I always thought that as medical oncologist we did not point out, and it's good that it is happening after Sir's talk only. I'm again going to come on the topic of cure. Now everyone has a definition of cure, but the global body has given a definition of cure which says that if the survival of the cohort which had cancer matches the survival matched for age, gender and comorbidities for the cohort which did not have cancer, then you can say it is cured. And I'll give you an example. If you have an 80-year-old person with CA prostate and if his 5-year life expectancy is 30%, and if you treat him and if you provide the 5-year life expectancy 30%, that would be considered as cure. As opposed to that, if you have a pediatric patient who is at age of 5 years gets an ALL, his 60-year survival or down the line should be similar to what a 5-year child would have without, which is age and gender match, then that could be considered as cured. And there are debates about that. The reason why I'm talking about cure is, and I'll come to this in the last few slides. You look at this Crown data which came in 2024 in ASCO, the 5-year PFS, we are looking at is 60%. If you see the cohort of these patients, the median age is more than 60 years. these patients are elderly, you're talking about the 5-year PFS of 60%, they are not given the curve for the overall survival. I would have put the curve because the events for the overall survival were not there. You can safely assume that at least 10% more will be the overall survival in this patient, which will be 5 years of around 70%. So do we start saying that today probably we have started curing patients of stage 4 ALK positive non-small cell lung cancer patients who are we giving targeted therapy? My question is, why not? Well, we start seeing in this elderly patients if you're seeing such good results. Anyone can guess this is a curve for a curable cancer, which is GBM. And I'll tell you, we may not agree or not agree. In all the schemes, it gets labeled as a curable and it gets reimbursed. When I send letters for GBM surgery, you get money, but not for lorlatinib or for crizotinib. That's the hard part of it. The median survival here with radiation and temozolomide is between 14 to 16 months. Not has changed anything from 2005 to 2025 in spite of TTF1 coming, in spite of interferon coming. I'll give you another stalking example. This is laryngeal cancers. This is RTOG 911. This is for patients who were T3N0M0 taken in that trial. The 5-year survival of patients of T3N0M0 is 53%. The 10-year survival, you can appreciate, has come down to 30%. Now, if I say T3N0N0 laryngeal cancers, the first thing which comes in our mind is one of the most curable cancers. Now, in these cancers, we are having survival of 50%. GBM, it is low. So, why not start labeling ALK positive non-small cell lung cancers, which happens in similar cohort, similar age group of patients, that it has become curable. Now, let's discuss points, which first line choice of drugs which we need to choose. And this differs from institution to institutions. Even if you want to use lorlatinib or alectinib, in most of the government institutes, you stick with crizotinib or saratinib only. And the choice of in ALK now not only depends upon the type of the financials which the patient has, also depends upon what co-mutations the patient has. It also depends whether you have CNS metastasis or not. It also depends upon the reliability of the patient, and it also depends upon what comorbidities this patient has. We know that there are more than 90 partners of ALK fusion, and at least at present we know that the variant 1 and variant 3 do behave differently. We also have good data to suggest that if you have a P53 mutation, and there's a gray zone data that if you have a KEAP1 mutation, they behave poorly in ALK fusion positive non-small cell lung cancer. Now, we have been using crizotinib. It was a great drug when it came. First ALK inhibitor, had poor lyophilic properties. And this is one of the, according to me, one of the most logical expansions in both chemistry, which got reflected in clinics, where the chemistry was modified so that the natural history of the disease could be targeted. Now, one other thing what was done when saratinib was designed was we introduced phenylpiperidine moiety. And this was introduced chemically, specifically to make the molecule more lyophilic. It didn't work, but it did increase the penetrability by 30 to 35%. Then, when we had alectinib in plant, an indole ring was provided, and this is specifically provided again to increase the penetrability and to decrease the dose required to kill the ALK cells in the petri dishes. That did work, and that which we saw subsequently in clinical trials, which we all are aware of. The interesting thing was, in spite of that, still the penetrability and the lyophilic nature of these molecules was not great. And then macrocyclic structures were used, which were chemically very lyophilic, and that was the structure which was used for lorlatinib. Interestingly, the TPX031 also uses a macrocyclic structure, but it's a miniature macrocyclic structure, which has a better penetrability than lorlatinib, and it's devoid of the cognitive side effects which you see with lorlatinib in spite of the better penetrability. So what I wanted to, we all know the clinical results, we all know the side effects, we all know the doses. What probably wanted to point out is we need to give a good round of applause to the chemistry people who made this possible that these structural changes were made in the molecule in such a way that they are reflected in clinics. And not only that, if you see, the first one came in 2007, we are standing in 2025. In another decade and a half, all these chemical changes were done, phase 1s were done, phase 2s were done, and even the regulatory bodies have to be applauded for taking many of these drugs to accelerated approval. Now, this slide is well known to all of us. The median PFS, which was with crizotinib, was 10.9 months, is not reached with lorlatinib with a follow-up up till now of 60 months. Now, doesn't mean that the median PFS will be more than 60 months. Please understand that it was not reached at 60 months. Certain few events might lead to a PFS even below 60 months. That is the power of censoring. Alectinib, brigatinib gave you PFS in the range of 25 to 35 months. Now, if you look at the hazard ratios for OS, was not reached for any of the molecule, and the response rates for all of them extracranially are between 70 to 80%. What actually much differs with them are the response rates which are intracranial. But that is if you take the whole ALK cohort as together. If you look at the response rates for ALK variant 3, for which good data has been reported, you see for alectinib and brigatinib it is between 17 to 16 months, not 25 to 35 months as was seen in the overall group. But for lorlatinib, it still remains in and around of 60 months, suggesting that probably the variation changes does not impact the way lorlatinib is acting. T53 co-mutation, again you could see that data was not, that is not there for alectinib in a good study. The brigatinib, it's around 18 months. For lorlatinib, it's around 51 months, again suggesting that if you have this co-mutation all variant, probably lorlatinib is a better agent. But understand, if you think that 5-year survivals of 60-70% are going to be achieved, which means many of your patients are going to be on this drug for a long period of time, you need to manage the side effects so that the quality of life remains better. The higher the generation, the more are the side effects, and each one of us who has used lorlatinib would be worried about the side effects of lorlatinib, which are enlisted here. I'm not intending to go over those. What I'm trying to tell you is this, apart from your co-mutations, this becomes an important selection point. So there is no direct winner here. We don't have head-to-head trials. 2024, we saw a very nice meta-analysis, a network meta-analysis done between lorlatinib, brigatinib, alectinib, concluding that lorlatinib is better. But such meta-analysis have their own biases, and you never know until they are head-to-head compared. But we select the patients, and this is not based on the finances, co-mutation, if there are CNS metastasis. And I want to talk about reliability of follow-up. Data from all the ALK trials, and if you look at how many patients took second line, you will see that 30 to 40%, and I've cross-checked it today again, 30 to 40% in spite of progression do not receive the second line. So it's very important that if you're going to use a sequential strategy, which has a risk of developing mutations on target, then you need to know the reliability of follow-up of these patients. If no, it's better to use a higher generation agent. You may want to adapt if the patient has hypertension and all, may want to use alectinib. And you need to know the expectations of the patients, because lorlatinib is not an easy drug, and if the patient gets weight loss, rest things can be, or gets cognitive decline, it severely impacts the quality of life for the patients. How to manage the patients? Last 2-3 slides in subsequent. Now, if you are using the second and third generation, on-target resistance is seen, and lorlatinib is the answer in most of the situation. The problem is, if you are using the third generation lorlatinib, 40% of your patients are still going to fail within 5 years, and the answer can be either the fourth generation ALK TKI, or if you have an FLT3 mutation, a FLT3 inhibitor like limitinib. Don't forget that off-target resistance are also seen, and you may require MET inhibitors or mTOR inhibitors, and epithelial mesenchymal transition can also be seen in this cancer as we see in EGFR. Last 2-3 minutes, I'm going to show you Indian data and what other things which we need to do. This is one of the first data which was published by Dr. Vanita Ma'am and Anant. And what this data showed is, in 2016, in first line setting, only 15% of the patients received ALK TKI. Overall, over the journey, over the whole lifespan, only 60% of the patients received ALK TKI. Whatever we have achieved, this is a stark reality of the country where 40% of the patients at that time, and a decade back, were dying in spite of knowing that ALK TKI were great because of financial resources. In this publication, another interesting thing which came was, and that is the reason I brought the concept of cure, because those of you who would have gone to social workers or for CSR funding for the patients or asking to the government for funding, the word when you write palliative, all funding for that patients are shut down. In spite of that, in this VCare Foundation, I need to take their name, enabled us to give TKI to nearly 40% of the patient, and that time they sponsored crizotinib, which was quite costly at that point of time. Now, this is a very recent publication, and a whole lot of work was done by Akhil for this. And this, nearly 70% of the patients are taking a TKI, ALK TKI in the first line setting. Again, this is in government setting, so it is again either crizotinib or ceritinib. Overall, over the lifespan, 85% of the patients are taking a TKI, and that contribution from social workers, because of constantly telling that these patients are doing well, have increased from 30% to nearly 55%. What I'm trying to tell you is, even in 2023, in the major government hospitals in India, most of the, we may discuss about length about alectinib versus lorlatinib or versus brigatinib, most of the patients are treated with crizotinib or ceritinib only. Now, which means that lorlatinib comes in the second line or beyond setting, and this data is there, which also suggests that in a second line and subsequent setting, the response rates with lorlatinib and the outcome with lorlatinib unfortunately are not that great as we see with the first line setting. Now, what do we do about this? This is a great drug. We also know about the, I didn't put that slide, that the IC50, which was selected for lorlatinib of 100 mg, was selected on the basis of the TKI resistance mutation LD50, which was required in the cell lines. And it is said that in the first line setting, you may be able to get away with a very lower dose of lorlatinib. And this is a trial proposed by Kumar sir, and it's, I think, is in a minor revision in the ethics and will be starting soon, in which we are going to compare 25 mg of lorlatinib against crizotinib, and if this becomes successful and shows similar kind of hazard ratio, we may be able to use a very effective drug at 1/4 of the cost and obviously with lower side effects. With that, I'll stop here and thank you for the patience.
Thank you, Dr. Vijay. Very nice presentation, and probably low dose lorlatinib may be a future with low cost. We'll move on to the next talk, and it's an international speaker session. I do invite Dr. Stephen Liu. He will be speaking on neoadjuvant approaches and non-small cell lung cancer. Where are we heading? Dr. Stephen Liu is the Associate Professor of Medicine, Director Thoracic Oncology, Head Developmental Therapeutics, Georgetown Lombardi Comprehensive Cancer Center. Dr. Stephen Liu, please. Dr. Stephen, you are not audible, please. Yeah, now you are audible.
Can you hear me?
Yes, sir.
Hi, thanks for the invitation. I'm pleased to be joining you virtually here from Washington, D.C. Hopefully next time we can do it in person as well. And I have the privilege to talk a little bit about neoadjuvant, a space that I think is going to be very important, not just for improving the outcomes for our patients, but really for understanding lung cancer in a higher degree with a lot more sophistication. I think this will lead to a lot more advances in our lifetime. These are my disclosures. As we know, when we treat lung cancer, we are faced with the fact that most of our patients present with pretty late-stage disease. We see about half of our patients in the U.S. present with distant metastases at diagnosis, and only about a quarter of patients are truly stage 1 or 2, with another 20% regionally advanced with nodal. Why that's important is because that directly correlates with survival, and patients with late-stage disease have a much shorter survival. We want to find patients earlier, and hopefully with CT screening we will do that. But I'll also point out that absolute 5-year survival of about 60% for localized lung cancer pales in comparison to what our colleagues that treat breast cancer and colon cancer and prostate cancer see, which is well north of 90%. For regional disease, when we have nodal involvement, we see that 5-year survival drop down to 30%. So clearly this is an area where certainly we want to find patients at earlier stages, but at the same time, we need to improve outcomes for patients with these earlier stage lung cancers. Surgery can be curative. I'm a strong believer in surgery, but even after surgery, the rates of recurrence remain quite high. And for a stage 2B lung cancer, which is still quite an early stage, our 5-year survival is about 50-50. We know chemotherapy offers a survival benefit, but I think we all know that survival benefit is modest when we look at the latest meta-analysis, a pooled analysis from 5 studies looking mostly at cisplatin vinorelbine. The hazard ratio for death here was 0.89. One wonders if this would even be FDA approved if it were done today. Our 5-year survival benefit of 5% is fairly modest. And when we look at these Kaplan-Meier curves, there is separation, but it is pretty small. No benefit really for stage 1A, modest benefit for 1B, 2, or 3. Yet this has been our standard of care for several decades now. Here's one study, the IALT trial, looking at cisplatin vinorelbine, published in the New England Journal 2004. We see that OS hazard ratio 0.86. If you squint your eyes, you can see these curves do split. This is our standard of care. In the lesser known follow-up in JCO, we see that hazard ratio over time got a little bit worse, hazard ratio 0.91. It loses significance when you get to about 90 months of follow-up. That's what we see with chemotherapy. See a benefit early on, but as the data mature, as we follow patients longer, we see those survival benefits disappear. We see the impact lessen over time. Are we getting that durable benefit? That's what we need. What we need after surgery is something that targets microscopic residual disease that is durable, offers durable response. Now, for stage 4 lung cancer without an actionable driver, we know that immunotherapy is our standard of care. What is the impact of immunotherapy on earlier stage lung cancer? Our first experience collectively was in the adjuvant setting. Pretty simple design in Power 010. Patients had already had surgery, already had chemotherapy. Most of these patients received 4 cycles of cisplatin-based chemotherapy and then randomized 1-to-1 to receive the PD-L1 inhibitor atezolizumab or best supportive care. And what we saw with Empower 010 is that giving immunotherapy afterwards improved outcomes. Here, the update from ASCO 2024. On the left, disease-free survival hazard ratio 0.70. On the right, overall survival hazard ratio 0.77. A clear improvement in DFS on the left with curves that split right away, that widen over time, and that separation a lot easier to see than we see with chemotherapy. And on the right, again, you're seeing that with more time, those curves widen more. We see a deepening of the benefit. We see increased benefit over time. And if we look at the PD-L1 high, using that 50% cutoff, and EGFR-ALK wild type, enriching this for the population that really gets the most benefit, I think even more substantial results. The DFS hazard ratio 0.49. The OS hazard ratio at interim analysis 2 hazard ratio 0.44. We're not talking about 0.90 with longer follow-up with chemotherapy. An OS hazard ratio of 0.44 for PD-L1 high. Clear separation. This strategy of using immunotherapy after surgery is leading to longer survival, leading to more cure. We don't just delay relapse, though. We really change how relapse occurs. These are the relapse patterns. This was presented a few months ago at WCLC by Enriqueta Philippe. Now, if we look at red, these are patients who have best supportive care. So surgery, chemotherapy, and observation are historic standard. And what we see when we do that is when relapse occurs, it's usually distant. About 43% of recurrence is distant only, 34% being local only. But if we give immunotherapy, one, we make relapse much less common, but when relapse does occur, it's usually local. The impact of immunotherapy primarily on distant metastases. Here you see that 29% of recurrence is distant, over half, 57% are local only. Now the absolute number of local recurrence is the same in both arms, 16, a higher proportion in immunotherapy. Immunotherapy is targeting distant microscopic disease, preventing relapse for patients, but it does not make up for sort of an incomplete surgery. And looking at these data, one wonders if we need to revisit local strategies such as radiation therapy, and do we maybe need to be a little clearer about our selection criteria for patients that are undergoing surgery. Immunotherapy prevents distant relapse that translates to better survival, but doesn't make up for an incomplete surgery. It also changes the timing, and I think this is important as well. When we look at patients receiving immunotherapy with local relapse, it occurs about 16 months, 12 months with chemotherapy. If we look at distant metastases, one, it's less common with immunotherapy, but when it does occur, it's later. Instead of 10 months at the time of relapse for chemotherapy alone, it's more like 30 months. CNS only 45 months. What does that mean? It means that we need to observe people longer. In our surveillance strategies, we need to change those paradigms. Everything with immunotherapy is pushed back. These are durable benefits, but when relapse occurs, it's usually much later. So our surveillance strategies might need to extend longer, and maybe doing scans every, up to 2 or 3 years isn't enough. We might need to go to 5, maybe even 10 years. We're pushing things down. We need to rethink relapse, and so surveillance paradigms also need to change in the era of immunotherapy. The problem with adjuvant therapy, though, is it's been confusing for us in the oncology space because we've had inconsistent results. We know the PEARLS trial of pembrolizumab, the KEYNOTE-091 study, showed that adjuvant pembrolizumab improved disease-free survival. That hazard ratio here is 0.81, and this was an all-comer study. This led to approval of pembrolizumab in this space. But if we look at that PD-L1 high group at 50%, there was no benefit. And here in the update from Benjamin Bess a few months ago at ESMO IO, hazard ratio 0.83, not significant. That subset did not get benefit. We don't understand why. This goes against everything we've learned about PD-L1 strat and prediction of pembrolizumab. This is an approved drug, but these data don't quite make sense, and perhaps a little glimpse to how little we understand about how these drugs truly work. At ESMO a few months ago, Glenn Goss presented the CCTG BR31 study. Very disappointing. This was adjuvant durvalumab, a completely negative study. Looking at that PD-L1 25% or greater in the eGFR wild type, that's the primary endpoint. The DFS hazard ratio is 0.935. We look at these curves, they are overlapping. No benefit here. How do we reconcile this? And I think that there are a lot of different variables in the adjuvant setting, but the reality is we have inconsistent results in the adjuvant setting. In the neoadjuvant setting, not the case, where everything has been very consistent, and their experience in the neoadjuvant setting has really reinforced this strategy. We know from years back that neoadjuvant chemotherapy was comparable to adjuvant chemotherapy, a modest benefit, about 5% at 5 years, slight separation of these curves. Neoadjuvant was better tolerated than adjuvant, and so the initial systemic therapy really preferred before surgery for stage 3 lung cancers, but neoadjuvant and adjuvant in our mind, pretty equivalent, and so could we explore neoadjuvant immunotherapy? We did that with Checkmate 816. This actually relatively smaller phase 3 trial, 350 patients, randomized to nivolumab plus chemotherapy versus chemotherapy alone. This is our first experience with a neoadjuvant. And what we saw in patients that are already resectable at the time of study entry is that giving nivolumab with chemotherapy increased the likelihood of pathologic complete response. 24% of patients had no viable tumor at the time of surgery, 1 in 4, pretty remarkable. We see that sometimes with chemotherapy, but it's rare, about 2%. In 816, there also was an exploratory arm of nivolumab, about 20% pass CR rate there, that was exploratory. But over time, we saw that translated to an improvement in event-free survival. But a pathologic complete response translated to a benefit in a clinical outcome. Here, the EFS hazard ratio, 0.66. Curves that split after about 9 months that maintain their separation over time. And we see at 4 years, the event-free survival really about 11% different with the addition of nivolumab. Now, patients that have a pathologic complete response do particularly well, with event-free survival years out, very close to 100%. And we see that patients who do not achieve path CR still get benefit with nivolumab. And so it really does show the impact of immunotherapy in this setting. But we want more patients with path CR. We'll note, though, that this follow-up needs to continue because, again, with immunotherapy, we're pushing everything back. And so we do need to see how these data mature. I also want to point out that neoadjuvant nivolumab and Checkmate 816, while this is an approved regimen, really the first immunotherapy approved in this space, it is not yet translated to a survival benefit. There is a clear trend, but it is not yet statistically significant. This is the update from ASCO this year. We're not reaching significance now. It's a fairly mature study. It remains to be seen whether this will translate to an OS benefit. We don't know. It's not the case for perioperative. Here, considering our experience with immunotherapy and 3 cycles of neoadjuvant, Was it enough? We don't use that little immunotherapy everywhere else. And so the question asked, should we combine pre and post immunotherapy? That was Keynote 671, where patients received pembrolizumab before surgery up to 4 cycles, and then after surgery continue for up to 13 cycles, a little short of a year after surgery. And what we saw was the addition of pembrolizumab before and after surgery. Well, first, the before portion did improve pathologic complete response. We see 18% versus 4%. Again, this is a larger study. These are probably more realistic numbers. We also saw an improvement in major pathologic response. We're defining that as 10% or less viable tumor, 30% with a major pathologic response. And that did translate to an improvement in event-free survival. Hazard ratio of 0.59. This did translate to an improvement in overall survival. And so the survival benefit here is 0.72. Pembrolizumab before and after surgery improved PCR, event-free survival, and that translated to patients living longer. We see similar trends with lots of different agents. Checkmate 717, the PD-1 inhibitor nivolumab. PCR rate 25% versus 5% with chemo alone. EFS hazard ratio of 0.59. Aegean with the PD-L1 inhibitor durvalumab. PCR rate better with durvalumab. EFS better with durvalumab, hazard ratio 0.69. And toripalimab. Toripalimab in the Neoadjuvant study, a slightly different design here. Here patients received 3 cycles of toripalimab, a PD-1 inhibitor plus chemotherapy versus placebo. And then after surgery, they received toripalimab or placebo with chemotherapy for 1 cycle, and then maintenance toripalimab or placebo ongoing after that up to 13 cycles. And so chemotherapy sandwiched here, 1 dose of chemotherapy after the surgery, a slightly different design. When we look at these data here, the demographics, this was published in JAMA this year. We see this is primarily a male study, 90% male, 10% female. This was about 3/4 squamous, 1/4 non-squam. And these were advanced cases, about 2/3 were 3A, but 1/3 were 3B. Now, an important note of the perioperative strategies is that when we look at patients who receive neoadjuvant or perioperative treatment, not all patients go to surgery. Here, about 18% of patients did not go to surgery in the toripalimab arm. Now, that is lower than the placebo arm, which was 27%, but that number of about 20% in that ballpark, that's pretty consistent with all of these trials. What is different between the arms is why patients don't go to surgery. And if we look at the toripalimab arm, it's primarily patient decision not to undergo surgery, whereas in the placebo arm, it's primarily disease progression. Now, fortunately, it does not seem to be primarily from toxicity, which is important in that neoadjuvant space. And so about 18% here not going to surgery. I think a reminder that if we're thinking of a neoadjuvant strategy for our patients, which we really should consider, we need to be sure those patients are resectable up front and open to surgery up front as well. And so those are discussions, patient selection, very important for these cases. And the bottom line is toripalimab improved outcomes. It increased response. The radiographic response doubled, 64% versus 33% with chemotherapy and placebo. The major pathologic response, which is a co-primary endpoint, improved from 8% with chemo to 49%. Very high major pathologic response rate, and the path CR rate 25% versus only 1% with chemotherapy alone. Giving the PD-1 inhibitor toripalimab, improving outcomes up front. Does that translate to clinical benefit? It does. When we look at event-free survival here, we haven't yet reached the median. These were published in JAMA this year versus 15 months with chemo, so the control arm did not underperform. That hazard ratio for EFS, 0.40. Pretty striking event-free survival benefit. And this was across PD-L1 strata. PD-L1 negative, the hazard ratio of 0.59, very impressive. The PD-L1 positive, whether it was low or high, the EFS hazard ratio of 0.31. These are exciting numbers to see. When we look at these curves, they split immediately, they widen over time. And this was seen across histologic subtypes as well. For non-squam, hazard ratio 0.54. For squam, hazard ratio 0.35. This is a well-powered study for squam as well, 300 plus patients with squamous histology. If you achieve the major pathologic response, the event-free survival is better. But importantly, toripalimab improved outcomes whether we saw MPR or not. Toxicity is always a concern, but most of the side effects we're seeing with the strategy are the chemotherapy side effects. Cytopenias, paper toxicities, things that we're very familiar with. You do see more immune-related adverse events with toripalimab, certainly, because we're getting an immune inhibitor, but overall it's a well-tolerated agent. So we deal with several questions when we look at the perioperative strategy. Is the adjuvant component providing value here? Here, the single-arm study, LCMC3, looked at neoadjuvant atezolizumab. This is an important study, a single-arm study, but after surgery, they were allowed to have atezo, but they didn't have to. Now, there was a lot of patient selection with the strategy, but if we just take a glimpse at this, we can see that those who did get the adjuvant portion did much better. Here, the DFS hazard ratio 0.44, the OS hazard ratio 0.48. Do we need to give the adjuvant component? We don't yet know, and there are studies that will ask that question, but what I do want to stress is that the benefit here is delayed, and it really would be my practice to offer the adjuvant component to anyone tolerating it. I do think it is going to translate to improved outcomes in the long term. What about biomarkers to guide care? We don't have great ones. ctDNA is intriguing. We know it's prognostic. If ctDNA is present after surgery, that's bad. If we clear it, that's good, associated with better survival. And if we have clearance and PAT-CR, we'll have a much better event-free survival. We're seeing this across the randomized trials. In addition, if we clear our ctDNA, we are much more likely to have better EFS. If we don't clear ctDNA with the neoadjuvant portion, here on the right, we are not going to achieve a pathologic CR. And so this is a good surrogate telling us we're on the track. If we've cleared ctDNA, we're going to do better. If we don't clear ctDNA, not only is the EFS worse, we have essentially no chance of getting a pathologic complete response. And if that really is our goal, perhaps this is a tool we can use to escalate treatment and looking at novel combinations. At WCLC a few months ago, we saw NeoCOAST-2, looking at a couple of different agents. Here on the right, datopotamab, the antibody-drug conjugate targeting TROP2, when we add that, we see the path-CR rate shot up from 17% with data alone to 34% with ADC. We're adding more tox. We have to worry about jeopardizing the risk of surgery, but in patients that don't clear the ctDNA, where we know there's virtually no chance of a path-CR, are those patients where we should escalate care. And so one could conceive of a study where you start with neoadjuvant chemoimmunotherapy, you check for ctDNA clearance after 2 cycles. If you're not clearing, should we add something else there if you've got no chance of getting the path-CR? And so I think this is what the next wave of treatments will look like. What about targeted therapy? These are my last couple slides. Neoadjuvant osimertinib was studied. Here's a paper looking at resectable EGFR lung cancer. They received osimertinib for 1 to 2 months before surgery. Now, the major pathologic response rate here is actually pretty low, 15%. No chance of pathologic CR. So when we look at this in terms of clinical benefit, while we do see a radiographic response, we are not getting that path-CR. And since the benefit of a drug like osimertinib in the adjuvant setting is so profound, will the neoadjuvant really lead to better outcomes? And I do think the neoadjuvant studies are important. I think they will have less of a clinical impact than immunotherapy does for driver negative, but really the value here is understanding what's left. And if we look at neoadjuvant osimertinib, patients who had osimertinib then had surgery, we now have a surgical specimen of residual tumor, of surviving disease, of tumor and tolerant persister cell populations that we can study. How are these cells surviving? Why aren't they completely going away with osimertinib? And we can use this to better inform future combinations, not just for this perioperative space, but even for the stage 4 setting. So I think this is going to be the key to really unlocking how we could maybe cure patients with targeted therapies if we really understand resistance and persister cell populations. So perioperative immunotherapy in resectable non-small cell lung cancer improves path-CR, improves EFS, and improves survival. And all of these randomized trials really reinforce each other. This is the strategy for the future. We should be considering this for all patients with stage 2 or 3. Future directions, we need biomarkers. Can we use ctDNA to sort of guide escalation or maybe even de-escalation? We need novel drugs to really push those path-CR rates. 25% is tremendous, but we want 100%. And we want to expand this to even earlier stages, 1A, 1B, and later settings, maybe 3C. So I'll stop here. Thanks again for the invitation. I think this is a very important space for us all, though.
Thank you, Dr. Stephen Liu. Any questions from the audience or comments? Oh, so may I invite Dr. Rakesh Piniti, who will be the discussant, and he will put the queries to the speaker and have questions from the audience and have the discussion. Dr. Rakesh, thank you.
Pleased to be here after discussing and after seeing the discussion here, such an illustrious discussion by very accomplished researchers. So I have few queries. As a discussant, I was given a mandate to bring out few things that were not highlighted in the discussions. It was very difficult for me to bring out those couple of things I felt was relevant for the audience here. So my few questions for Dr. Patil. So if we have come such a long distance since we have the crizotinib since profile 1014. How relevant is crizotinib for clinical practice, and how relevant is crizotinib as a control arm in the clinical trials? So we have seen that it has, other drugs have outperformed crizotinib, especially with respect to PFS, CNS penetration, and still we are having newer trials, newer phase 3 trials with crizotinib as a control arm. How relevant is that?
So in country like India, as I have shown in the data, many of the government setups are still using crizotinib because of the finances. So it still remains a viable option for many other low and middle income countries. Saying that, I think there was a case report first in New England Journal of Medicine a few years back of lorlatinib resistance being overcome by crizotinib. I think it was L1198F. Yeah. And I was looking at one of the papers, studies called ALK-TORCHLIGHT by the Dr. Benjamin Solomon's group, in which he's trying to work in a strategy in patients who have failed on second generation TKIs on giving alternate crizotinib and alectinib, alternate crizotinib and lorlatinib, so that the pressure milieu is different for making new mutations. So first thing, yes, crizotinib still remains relevant to us. Second, we may have to use, if the cost of other drugs don't come down on the lower doses of lorlatinib doesn't work, we may have to think in lines the way we did for FLAURA2, like combination of crizotinib with chemotherapy if it can give better outcomes. Third, in strategies where you can give if those studies become successful where you are giving lorlatinib and crizotinib and as an alternate drugs, it might be useful. But I think time has come probably in phase 3 randomized trials that we start using alectinib or lorlatinib as a control arm. Crizotinib does not seem to be a suitable control arm, at least to my eyes at present. So that is my take on this.
Just one more question. Again, I think you are the right person to answer this question because you have experience of doing trials in poor performance status patients, in head and neck cancer at least. So again, most of the clinical trials have excluded performance status 3 and 4. Should we also look at performance status when we use these newer drugs with high efficacy? Do performance status have the same relevance in the driver mutation positive non-small cell lung cancer patients? And especially ALK positive non-small cell lung cancer.
For ALK positive, I think in this hall there would be no one who knows that if the patient's performance is poor and it's ALK positive, he won't try ALK inhibitor. Saying that, we had data of 441 patients, which was analyzed, I think out of 100 out of them, I think Ajay published that data in early part of 2024 of 100 patients who had poor performance status. And these were patients with PS2 to PS4 with nearly 50% being PS3 and PS4. And in these patients also, obviously because of the constraint, most of the patients either received crizotinib or ceritinib. In this patient also, we saw a response rate of around 60%. And the median PFS was, I think, around 8 or 9 months, if I'm not mistaken. So that is one data. There's another data which got recently published from Dr. Benjamin Solomon's group. It was an analysis of around 771 patients, in which again around 90 odd patients were a poor performance status. And in that study, lorlatinib, alectinib also was received by the patient. And again, the response rates were upwards of 50%. So I think we may not have a phase 3 data, but there are multiple retrospective real world evidence which show that poor performance status, PS3 and PS4 patients benefit with ALK inhibitors. And that has been my personal experience also. And I'm very sure if you ask across the group, that would be the personal experience of most of the clinicians here.
Thank you, sir.
So, Rakesh, can I comment on both the aspects? The first one for design.
So design will depend upon what you want to achieve. For example, you want to achieve beyond what the science has achieved today, then it's a good suggestion that, hey, this is what I go beyond improving the outcome of the patient. Second can be designed what you have been able to achieve in your society and community. If that is the idea, then your design will be different. And I'll say multiple times we have been beneficiary. For example, all the Chinese drug which has come, you have got 3 Chinese immunotherapy drug coming in India. It has come because that time already nivolumab was there. But it happened in China and those areas because that time immunotherapy was not freely available, so they could do that trial. And the beneficiary is the society that more patient can get access to it. Similar is our low-dose immunotherapy trial. Ideally, we should have been comparing with the full dose. But that would never have happened. But that was not the aim. Aim was moving science in our society, then that design becomes absolutely relevant. So also the background decides what will be the design, not necessarily what has happened in some other place. Coming to poor performance status, there is a 2 paper beyond what Vijay suggested. One by Prabhat has done for chemotherapy, and one by Minit Shah in our group for poor performance status. And appropriately choosing patients, you do have some data that apart from the TKIs, you do have some activities in these situations.
Thank you, sir. So my question to Professor...
And you will get a randomized trial data for poor performance status next year. We have randomized almost 160 or 170 odd patients, or EGFR mutation positive patient. So we will get the data next year from ours.
Looking forward, sir. So my question to Professor Liu. So we give systemic therapy in localized cancers to improve survival, overall survival for that matter. So if OS is the only endpoint of interest, which strategy has impressed you the most? The neoadjuvant, adjuvant, perioperative, specifically for unselected patients, or for non-squamous, high PD-L1, and also for squamous, in that order, please.
Yeah, I think that really OS is the important benchmark here. Pathologic complete response and EFS have value because they seem to be surrogates for OS, but I do think we need to demonstrate that with new strategies. So when we first saw PathCR from CheckMate 816, we were excited, but we didn't really know if that would translate to an EFS or OS benefit. And it did translate to an EFS benefit, still hasn't yet translated to OS, but I think that's more a matter of design and power and time. But we do know that the perioperative strategy improves PathCR, improves EFS, and improves OS. So in my mind, this is a strategy that has clearly improved the outcomes. Unlike chemotherapy, which I think the benefit wanes over time, I think the benefit will deepen over time with immunotherapy, and really the benefit is delayed. So I think that we will see more OS benefit with strategies, and I think this is really across the board. Now, squamous generally tend to do worse in the stage 4 setting. They do have pretty good responses in this perioperative setting. So for squamous and for non-squamous, I do think that the perioperative strategy is one that I prefer. I understand that there is a cost advantage to the neoadjuvant only. If you're only doing neoadjuvant, you're only giving 3 doses, and you're sparing patients with that year of extra. So there are many who wonder, do we need that adjuvant component? This is a question that we will answer. And there are cooperative group studies going on now. But I think a lot of our job is to try to anticipate what those data will show. And my expectation is that there will be a benefit to continuing immunotherapy. I think that it's too heterogeneous of a population to treat them all the same. And I think the neoadjuvant group alone will see better PathCR, better EFS, but I think the survival benefit of continuing immunotherapy afterwards will be borne out in larger studies. To me, we do need, I think, additional therapy. I think if you follow 671, those curves, for people that had PathCR even, I do think there's a little bit of separation over time. So it's too early to say there's no benefit. To me, when I see a patient in clinic, neoadjuvant only versus perioperative, my preference, my default is perioperative. Unless patients are having a lot of toxicity, rather continue the treatment afterwards, and I do think that will pay off with longer survival.
Thank you, sir. And a follow-up to that, how do you improve outcomes for those who have not achieved PathCR? Is there anything that we can do today in our clinic?
Yeah, that's a great question. And we're really looking at 2 different strategies. The easiest one is to say, if you don't get a PathCR, should we escalate the adjuvant component? If someone has a PD-1 inhibitor plus chemotherapy and we don't see a path CR, maybe we don't even see an MPR, do we continue that same drug that seemed to underperform? Is it just that there wasn't enough time? Possibly. But is this a case where we need to escalate treatment by adding things? And this is where I think most of the trials are looking at basket studies of randomizing people to different combinations. The challenge here, and I had a long discussion with Mariana Provencio, this is a very simple design. After surgery, no path CR, randomized to receive just a PD-1 or PD-L1 or some combination. The challenge is what's the combination? We don't know what drugs to give here. We know the patients will need something different, but we don't really know what to give. So today, when we do that study, we're just kind of guessing, and we're just reaching for whatever we have. Ideally, we better understand sort of why patients aren't achieving path CR. It's going to take some time. So I do think that changing therapy for people that don't get a path CR or an MPR makes a lot of sense. That's the easiest. But I think that patients will benefit more if we can do that earlier. And that's why I think ctDNA will be important, because that really is a glimpse as to whether we are on target for a path CR or not. So if patients start with PD-1 inhibitor plus chemotherapy, and midway through, we still see that ctDNA, we're not clearing, we know that there's no chance to get a path CR, why not escalate therapy then? And then continue patients to push towards PCR. I think that's a better strategy. More importantly, I think that'll lead to better outcomes. And that's, I think, a pretty easy study to do. We have to be careful in that neoadjuvant setting because we don't want toxicity that will jeopardize surgery. That's a no-no. We can't have patients get sick from our therapy, and now that window closes because they're recovering from pneumonitis and not able to undergo a curative surgery. We can't do that. So we're going slowly, intentionally, we're treading carefully, but I think that's going to be the winning strategy.
Thank you. Can I have a question to Dr. Stephen? Hi, this is Dr. Mulakade from India. So this is regarding the Harmony 2 trial, ivonescimab, the new drug which has shown some benefit in PD-L1 more than 50% subset in that particular trial. So I just wanted to have your views. How far do you think this particular bispecific drug of PD-L1 VEGF inhibitor will go? Do you think it will show equal results in the perioperative and neoadjuvant setting, because the trials are coming up? So do you think that is the solution, that the question you have? If you don't get path CR, what to do next? Which new drug? So do you think this is the new drug that probably shows some bright future in the perioperative and neoadjuvant setting also? What's your thoughts on that drug?
I hope so. I truly hope so. When we saw those data at WCLC from Harmony 2, this is ivonescimab, a PD-1 VEGF bispecific antibody, I think we were all blown away. We knew from press release that it was a positive study, but I don't think any of us were anticipating how significant that difference was. And this wasn't just PD-L1 high, even PD-L1 low. The benefit was profound. And so if that is real, yeah, I think that has the potential to improve outcomes across the board. One could see a world where these types of drugs, the bispecific targeting VEGF and PD-1, really replace all PD-1 and PD-L1 indications. But we do need to confirm it, and we will see those studies being replicated in the U.S. And I think there are really a couple different concerns. Number one, is it true in a different, more heterogeneous population? Personally, I don't think that there will be a difference based on ethnicity or ancestry here. I don't think that explains it. I don't think it's something unique to the Chinese population. And, you know, between you and me, I probably have more in common with that population than I do with the Caucasian U.S. population, right? So I don't think it's a biologic difference based on race. I think the concern, when you see people have some degree of skepticism, I think the concern there is that we know that clinical research in China, sometimes there's just a little bit less oversight. And I think it's sort of the nature of the research infrastructure. And so will we see the same adverse events profile, the same survival and PFS benefit when it's sort of under a more rigorous study? So to me, it's not so much a biologic difference that are causing some to be skeptical. It's more, if we do this under a more rigorous oversight, like the US FDA, will we see the same outcome? And I'll tell you now, I think we will. I think it'll be a little bit less. I don't think it'll be quite that much, but I think that will translate. Unfortunately, we won't have that answer for a few years because it takes those studies a little bit of time to do. So the U.S. has taken a pretty firm stance. They are not going to approve the drug based on Chinese-only data. I don't think that's true for the rest of the world. And so I think we'll see in the end who's right. But I'm very excited by those strategies. I mean, drug development now is going so quickly, and these new molecules, these bispecifics, make a lot of sense. Really, why would this drug be so much better than looking at, we've done PD-1 inhibitors plus VEGF before and really been disappointed. I think the difference here is that cooperative binding, and if this really is greater than the sum of its parts, I think this could be something that replaces PD-1 and PD-L1, but it'll take a little time to know for sure.
Thank you. Thanks for the answer.
Thank
Thanks.
you.
Thank you. Thank you, Dr. Rakesh. Dr. Stephen Liu will go ahead with your next presentation, and that is on personalizing therapy for driver-negative metastatic non-small cell lung cancer. So, Dr. Stephen Liu.
Yeah, thank you. So we'll continue our discussion now, moving into that stage 4 space, looking at that driver-negative population. Disclosures have not changed in the past 10 minutes. So we know that the treatment of driver-negative lung cancer, we're really talking about immunotherapy, delivery of immunotherapy. But when we talk about driver-negative, I just want to take a second to really stress the first step is to be sure that this truly is driver-negative. And a lot of what I do here at Georgetown are second opinions mostly. I think my biggest job is to make sure that the testing has been done properly. Why is it important? Because if we look at our experience collectively, immunotherapy doesn't really work in a lot of driver-positive cancers. This was a phase 2 study led by Eddie Guerin at UCLA. And this was made on the observation that there were some patients in the initial keynote studies, keynote 001, with EGFR mutant lung cancer that seemed to get benefit from pembro. So we did this in a prospective study, metastatic lung cancer, EGFR positive, PD-L1 positive. Most of these were PD-L1 high. No TKI, we started with pembrolizumab alone. The response rate was 0%. Now the study stopped early. There was no activity, but importantly, there was a lot of toxicity when we then went to EGFR TKI. Patients would progress on pembro. They would then go to, at that time it was mostly erlotinib, and we saw patients really dying from toxicity, something we don't typically see. And so there was clearly some consequence to giving immunotherapy, to changing the tumor microenvironment that made these tolerable TKIs very dangerous, and that was not acceptable. So kudos to Eddie Guerin, UCLA, for stopping that study because he knew it was exposing patients to harm. And that's now true for a lot of different drivers. We see from the immunotarget study led by Julian Mazieres that immunotherapy is pretty disappointing for most drivers. There are exceptions. KRAS, for example, BRAF and MET, we can see some, but for EGFR, ALK, RET, ROS1, NTRK, we're not seeing responses with immunotherapy, and there's too much toxicity. We don't really understand why the toxicity is there, but it is across drivers. We see it with EGFR. When we give a TKI after immunotherapy, like osimertinib, we see higher rates of colitis, pneumonitis, arthritis. We've seen terrible outcomes here. With ALK, it's mostly hepatitis. With ROS1, with RET inhibitors, you have this diffuse immune reactivation with rash and hypertension and thrombocytopenia. So we want to avoid TKIs after immunotherapy. But if someone gives immunotherapy, they don't respond, and then we find a RET fusion, we want to give a RET inhibitor, but now we painted ourselves into a corner where all of a sudden these super well-tolerated drugs are a little bit dangerous. And so we really need to be sure before our first dose of immunotherapy that these patients truly are driver negative. So the question really is, has proper molecular testing been done? When we look at the results, we don't just see EGFR, ALK negative, ALK wild type. We want to say, was there adequate tumor content in the biopsy? Was this a bone biopsy that was decalcified and sort of degraded the DNA? Are we going to get some liquid biopsy versus look at Ian's tissue? And then we're looking at DNA and RNA. And while I appreciate that RNA sequencing is more expensive, it can be important. Here's a case series led by Rima Benaya. This was a study, very simple study at Memorial Sloan Kettering for patients that had driver-negative non-small cell lung cancer on DNA sequencing. And all they did was just took those tumors and sent them for RNA-seq. And what they found was an actionable alteration in 13%. 13% is not a small number. And a lot of these ones we see are things like ALK, like ROS, NRG1. We are missing a lot of these fusions and a lot of these mutations if we're only doing DNA-based sequencing. And all liquid is DNA, and most tissue, at least in the US, is also DNA. So if we're only doing DNA-seq, we are missing some of these fusions, ROS1, ALK, RET. And so the question is, how many of these are okay to miss? And hopefully, as this technology becomes more accessible and less costly, we'll be able to use RNA sequencing because it clearly does increase the sensitivity of finding these drivers. But if we focus on true driver-negative lung cancer, we can see dramatic responses. And here's a case that we'd all be familiar with. This was an older gentleman with a history of smoking, presented with a non-squamous lung cancer in the right lower lobe. He had several bone metastases. Here's his baseline scale on the left. We see after the induction chemoimmunotherapy, a response, and then over time, we see that response has deepened. Now, I show this case because it's very special to me. This treatment on the left was September 2013. This was the first patient that I treated with immunotherapy. It was on a phase 1B trial when I had just joined Georgetown right out of fellowship. This was my first trial enrollment, my first experience with immunotherapy, and the scale on the right is from earlier this year. 11 years. He's been off therapy for about 8 years. We continued for 3 years in him. But frontline immunotherapy, not only alive 11 years, but I truly believe that he is cured. And this was something that was unfathomable at the time in 2013. It's not that long ago. So really alive for now 11 years, I think cured from his disease, immunotherapy. This is what we hope for. This is the power. And when we look at immunotherapy, this is really why it's so important, because we've raised to the ceiling, we've eliminated the ceiling, and we've achieved something that we thought really not possible. I do think it's worth reminding ourselves that this is rare, that we don't see this in most patients, and how do we get there? Immunotherapy gives us the potential for durable response. It's changed the context of what we're capable of, and we saw this in the second-line setting with docetaxel, but really it was the front-line setting that changed our practice. Keynote 024, presented by Martin Reck in Germany at ESMO 2016, standing room only, randomizing patients with PD-L1 high lung cancer to chemotherapy alone or pembrolizumab. And at the time, there were people in the field, leaders in the field that we're very familiar with, that were worried about this design, saying we've been giving chemotherapy for decades. This is our standard of care. And if patients don't respond to immunotherapy, they won't survive long enough to get another second chance. And so there were some that didn't really have true equipoise with this, that felt this was a little bit too fast. But I'm glad that that was the minority, because this clearly improved outcomes. That pembrolizumab, not only just as good as chemo, was far superior with a higher response rate, 45% versus 30%. The time to response was the same. There was this conception that we had a decade ago that immunotherapy took longer to work. That initial response, we really saw at that first scan. Progression-free survival, 10 months versus 7. The OS at 6 months, 80% versus 72. Hazard ratio for death, 0.60. Not only better response, better survival, but fewer adverse events than chemotherapy, 73% versus 90%. The grade 3 treatment-related adverse events, half with immunotherapy. Immunotherapy better tolerated, more effective. When we walked out of that room in 2016, pembro was a standard of care. Chemo alone for PD-L1 high lung cancer was inferior in every possible way. These data weren't updated. Here we see 5-year survival data. How many of us 10 years ago would have thought we'd be talking about 5-year survival rates of 30+%? And at 16% with chemotherapy is far better than historical standards, because this study had crossover and patients could receive immunotherapy afterwards. In the world of immunotherapy, we achieve 5-year survival, not for everyone, not for the majority, but for some, for a significant number of patients. And so when we see someone with a metastatic lung cancer, we know that at diagnosis, there is a chance that they will be alive 5 years from now. It's not 1 or 2%. Here, 30% for PD-L1 high. These are profound numbers. True cure, we'd have to look at PFS. That number a little bit lower here, 13%, but you do sense that there's a plateau, that some patients truly cured from treatment. The addition of chemotherapy to immunotherapy was explored. This allows us to extend our benefit where PD-L1 alone isn't quite as impactful, including PD-L1 negative and PD-L1 low subgroups. Here in the overall population, PFS hazard ratio 0.50, the 5-year PFS rate 7.5%. But if we look at overall survival, about 20% of patients alive at 5 years. However, we don't achieve this for everyone. And here in Keynote 189, this is patients who completed 2 years of therapy. And what we can see is that patients in follow-up, if we look at progression, these black circles, we do see late progression. And I think that all of us are understanding that getting to 2 years doesn't mean we're out of the woods. We stop therapy and observe, but there are late recurrences. And one question that every patient asks, and that we don't know the answer to, will this cancer come back at 2 years? Should we continue longer? And we're looking at decreasing the duration of therapy, largely because of cost, but there are some patients that will relapse quite late, and the question we have, and we don't know the answer, if we continue treating longer, will we prevent that, or would that have happened anyways? And we don't know the answer to that. There's a lot we don't know. about how immunotherapy works or why it works or in whom it works. But clearly we have much better outcomes now than we had in the past. Here's another study, toripalimab study, TORCH-01. This looked at toripalimab plus chemotherapy. This was for patients, this is more recent data, patients with advanced lung cancer, any histology, received chemotherapy, either pemetrexed or nab-paclitaxel, with toripalimab or placebo. And what we saw in this study with fairly representative demographics is that adding the PD-1 inhibitor improved response rate. 46% versus 66%. Improved the duration of response from 4.2 to 8.4. Improved progression-free survival here. Hazard ratio 0.49. If you look at the 1-year PFS rate, 17% with chemo, not bad. 37% with toripalimab plus chemotherapy. And we know from update earlier this year, that translated to a survival benefit. Hazard ratio 0.69, the OS median 17 to 24, 3-year OS rates 18% to 33%. An improvement in EFS, an improvement in OS, really across all of our subgroups, including PD-L1 and histologies. When we add immunotherapy to chemo, we are adding more toxicity here. Chemo alone versus IO alone. IO is better tolerated, but chemo plus IO versus chemo alone, clearly more drugs, more toxicity. But the discontinuation rates due to adverse events, only 14%. So most patients are not stopping due to adverse events. I think we're getting better at managing these. So we look at frontline immunotherapy either alone or in various combinations. We know that this improves survival over chemotherapy alone. It gives us the potential for long-term survival in a subset of patients. How can we further personalize delivery? Well, the only biomarker we really have here is PD-L1 expression. This is still the best biomarker. It is an imperfect biomarker, and it's not as powerful as we want, but we do see that with higher PD-L1 expression, we seem to get greater benefit. And if you look at the Similar study in PowerLung-1, we see that PD-L1 is a continuous variable, and that cutoff of 50% was established using algorithms in KEYNOTE-001, the phase 1 study of pembrolizumab, but within PD-L1 high, we do see greater benefit with higher PD-L1. If we look at PD-L1 of 90% or greater, the response rates are much higher than those with a PD-L1 of 50 to 60%. So PD-L1 is a continuous variable, and the higher we go, the better the outcomes. How do we use that data? Well, we're still trying to figure that out. If we look at KEYNOTE-598, just to sort of get a glimpse to what these mean, let's look at PD-L1 high lung cancer, pembrolizumab alone versus pembrolizumab plus ipilimumab. And what's interesting is that in this PD-L1 high subset, the addition of a CTLA-4 inhibitor to PD-1 did not improve outcomes, increased toxicity, but no difference in survival at all. And so within that PD-L1 high, it's not just PD-L1 expression. That PD-L1 high really represents a different biology, where CTLA-4 maybe not really as important as it is in PD-L1 low or negative groups. And so PD-L1 really is surrogate for a different biology. We're still trying to understand what that means. Are there other biomarkers we can use? We look at STK11, we look at KEAP1. Very consistently, in the STK11 and KEAP1 mutant subsets, we see less benefit with immunotherapy. That the addition of a PD-1 or PD-L1 inhibitor not really adding as much in the STK11 or KEAP1 subgroups. Worse outcomes with IO alone, worse outcomes with IO chemotherapy, really chemotherapy driving it. How do we use that data today? Well, if I see someone with STK11 or KEAP1 mutation, even if PD-L1 is high, I'm not giving IO alone. I'm giving it with chemotherapy. Question is, can giving other combinations overcome that? Here's some data from Poseidon, presented at ESMO Asia, looking at giving the CTLA-4 inhibitor tremelimumab, and it did seem to overcome some of those limitations in that STK11 or KEAP1 mutant subgroup. See, the STK11 and KEAP1 mutations really tell us that there's a cold microenvironment underlying this tumor, and can we prime those tumors with CTLA-4 inhibition and sort of force those immune responses? And this is encouraging for CTLA-4, but these are small numbers. Here we're looking at a handful of patients once we get out past a year. There is a prospective phase 4 study, the Triton study, which will compare carbopen-pembro versus carbopen-durvalumab in non-small cell lung cancer with an STK11 or KEAP1 mutation. But that study just ongoing now, so we won't have that answer for quite some time. Is chemotherapy needed? Is chemotherapy better? We don't know the answer to that either. Many of us will use chemotherapy in the U.S. where we have the option for either if patients have a lot of disease, if patients are symptomatic, if we're a little bit worried about the IO response based on STK11 KEAP1, based on no smoking status. But we will have an answer. This is the Insignia trial being done in the U.S. This is patients with PD-L1 positive lung cancer, and they're randomized to pembro alone or pembro plus chemo. And so we'll get that comparison. In addition, at progression for patients with pembro, they're randomized to receive chemo alone or chemo pembro. So we'll also address the question, should we continue pembro when we have progression on pembro? Is it doing anything other than adding cost and toxicity? We'll answer both those questions. The Insignia study, an important phase 3 study, this included both PD-L1 low and PD-L1 high, was stratified. This study has completed accrual, and so hopefully we'll see results later this year. What do we know about immunotherapy in the brain? Well, here's a study led by Sarah Goldberg at Yale, looking at the PD-L1 inhibitor atezolizumab in patients with untreated brain mets. And here the response rate, about 30%, not bad. Not as high as we see with targeted drugs, but we can see immune responses. But note, in the PD-L1 negative group, there were no responses. So if someone has PD-L1 positive lung cancer, small asymptomatic brain mets, I'm actually pretty comfortable using IR alone, and we're watching carefully. PD-L1 negative, though, we usually will radiate those at our center. So when we know about toxicity, really it runs the gamut. We can see toxicity everywhere. We're doing a better job, hopefully, at predicting toxicity, and some of the newer studies are really looking at radiomics and deep machine algorithms to really try to identify who is likely to have an immune-related adverse event up front. We're looking at using these immune inhibitors in people with baseline underlying autoimmune toxicities in some ongoing NCI studies. But we do know immunotherapy events usually occur early, generally in the first 6 months. But if we do see toxicity, patients that stop treatment due to treatment-related adverse events have a much better survival than average. And the thought here is if we see such a powerful immune response to cause such significant toxicity that we have to stop treatment, many times those patients do particularly well. And so if someone experiences a significant toxicity, an immune-related toxicity, we give steroids, we overcome that, that's the priority. But afterwards, we just watch, and many of those patients won't need more therapy. Not always the case, unfortunately, and in cases that do progress after that, I think outcomes are particularly poor, but there are some patients that do very well without further therapy and don't need any other treatment. I'd like to mention this, I'm going to close here in just a minute. Tuberculosis, there have been multiple cases of TB reactivation. I think this is underappreciated. When we give a PD-1 inhibitor, we shift Th1, Th2 macrophages, and that completely disables our defenses against TB. Not all mycobacteria, not avian, not Kanzasi, but specifically mycobacteria TB. And so I do know there are cases of pneumonitis and colitis that are refractory, that are giving steroids, giving other immunosuppressants, and at autopsy, they end up being miliary TB. So importantly, if someone has latent tuberculosis and you're going to start a PD-1 or PD-L1 inhibitor, you got to put those patients on suppression. And if patients have toxicities, we have to remember that TB can really look like IO toxicity. We know immunotherapy is our standard of care. All patients really have the chance. We have a lot of room for improvement. We're looking at new biomarkers, at predicting toxicity, and at novel drugs like anti-TIGIT, which showed an increase in response here in the Cityscape study, a significant improvement in PFS, hazard ratio of 0.3, but in phase 3 trials, we saw at ESMO IO a few months ago, SKY2, adding tiragolumab to chemo IO, really no improvement in PFS, no improvement in OS, really inferior, hazard ratio of 0.133. So we can't get too excited about these phase 2 studies, particularly if we don't have biomarkers and if we don't understand how these drugs work. But we talked a little bit about ivonescimab, a PD-1 VEGF bispecific. And in that Harmony 2 study, in the PD-L1 positive group, we saw a significantly superior PFS, hazard ratio of 0.51. Questions remain. Will this be replicated in the Western population, and will this translate to an OS benefit? Stay tuned for that. We also have bispecifics and other novel molecules that will force more immune responses here in small cell, but these are being explored in non-small cell as well. So I think the future is bright with a lot of rational drug development, a lot of new molecules emerging. The key here really make sure that there are no drivers present. We have to give early immunotherapy up front. We can't make up for it with later on treatment, but we do need to customize our strategies, watch for toxicity, and really supporting the development of new molecules. And I'll stop here. Sorry for going over a little bit.
Thank you. Thank you, Dr. Stephen Liu. We'll take questions in the panel. Dr. Ullas. Sure. So we'll call Dr. Ullas, who will be moderating this session, and he needs no introduction.
Thank you, Dr. Kumar. And can I please invite my panelists? Dr. Stephen Liu will stay with us. Dr. T.P. Sahu, Director, Senior Consultant, resident of Goa. I mean, the Dr. Sahu stays more in Goa nowadays than he stays in Bhopal nowadays. I don't know the reason behind it. There was a reunion, I heard, this Dr. Sahu. You know the reason. Please come to the panel also, Amol, then in that case. we would rather have that discussion over here, you know. The reunion for Dr. Sahu next is going to happen in Bhopal because Gaur is doing more in Goa nowadays. Okay, Dr. Aditya Murli. Okay, now Dr. Ahmed Bhatt, Dr. Muzammil Sheikh. And since all the senior oncologists were there, I thought I'll get a junior oncologist also, Dr. Senthil Rajappa. If you can please come onto the stage. Okay, fantastic. So we have been asked to discuss about the management of driver mutation negative non-small cell lung cancer and some real world cases. And my first reaction when I think about a driver mutation negative cases, can I have the slides please? Okay. When I think about this, it's like, a car which is going to be driver negative. You are going to have in a era Musk has this way, you are just going to leave the driving to the car, and when you sit on a Goa beach, Sahu will have more experience of that. But my subsequent reaction when I think about driver mutation negative is this is what we don't want to happen. We need to have some control and we need to have some checks and balances. So Dr. Sahu, this is for you. This is not for this control, Dr. Sahu control. At least, if not in Bhopal, at least have some control in Goa, else you will have to have frequent visits over here. Okay, jokes apart. So, we have a case. Just to fill you in, Dr. Stephen, Dr. Sahu has been having a reunion at Goa in the last 1 year, every 12, every month he comes to Goa for his reunion. I don't know what reunion is having. Okay. So we have a 55-year-old female, never smoker. She has come back with history of cough and breathlessness. PET scan shows a left lung mass with medicinal lymphadenopathy, liver, brain mets. No brain mets. MRI brain, there was no abnormality. Biopsy was done, which came as adenocarcinoma, TTF1 positive. NGS was done, no actionable mutation detected. PDL1 was 40%. The patient was started on the Keynote 189 regimen. Reevaluation showed a partial response to treatment. The patient was continued on Pembro and Pemetrexed maintenance. After 8 cycles of Pembro and Pemetrexed, the creatinine was 1.8. The baseline was around 0.9. So what next? I will start with Dr. Amit. Patient is doing absolutely okay. PS is 0.1. Creatinine has now increased to 1.8. So how would you? There's no time. There's only one case that I'm going to discuss throughout.
What for the creatinine, why it is it nephritis because of the immunotherapy? If there's no reason, if there's clear, you just monitor the creatinine, continue the regimen. If there's some specific reason for the creatinine rise, then you try to treat that.
So how do you find that out? Or what are the things that you kind of do? Is it because of Pembro? Is it because of Pemetrexed? How do you do? And what do you do tomorrow? I mean, you withhold the Pembro, you withhold Pemetrexed, what do you do?
Usually withhold the Pembro because Pemetrexed is virtually, we don't see so much of renal toxicity present. Pembro is which we will evaluate for nephritis, look at the albumin, look at the urine creatinine ratio, the usual things, and then see.
Dr. Sahu?
I will probably look at Pemetrexed very carefully because
you want to stop Pemetrexed.
Because that is a data set that once you use and go on using, the Pemetrexed has a nephrotoxicity. So that's probably would be my first go-to drug of stopping it. That's how I look at it. But
so you would want to stop Pemetrexed and really maybe continue pembrolizumab, or
yes, because after 1 year, nephritis is not a very common thing, which I see.
1 year nephritis is common, but it can happen anytime.
Yeah, it can happen.
So immunotherapy things can happen anytime.
I know, the duration is making me point towards.
We actually do feel as a group that it is because of Pemetrexed. The patient Pemetrexed was stopped. Patient was continued on Pembro maintenance. The patient responded well, and the CT scan showed the maintenance of response. So patient on single agent this thing. In fact, in our clinical practice, approximately 40% of people actually have to stop Pemetrexed somewhere down the line and just continue on Pembro maintenance. After 17 cycles, Aditya, PET scan was showing, remember this patient had a lung mass, medicinal lymph nodes, liver lesion, bony lesions, and now some mild increase in the activity of the paratracheal lymph node. Patient is absolutely asymptomatic, PS 0. What would you do now?
So, paratracheal lymph node activity could mean anything, not just disease. it's not unreasonable to wait. At least in my practice, I would have probably waited maybe image again after 2 months or so to see what's happening there. That's because of two reasons. Patient is asymptomatic and has not had a progression anywhere else. So it's not wrong to investigate, but probably I would have waited for 2 months to see where the patient is going.
Okay, Dr. Muzammil Sheikh,
Same strategy.
you would want to wait, you do not really want to continue, and
So mild increase is a very loose term. I don't know what mild means, but then for a patient who is symptomatic on such a bad disease doing well for now 17 cycles, I will not change anything.
you don't fix something which is not broken really over there. And we all know that whatever pseudo progression happens with immunotherapy happens mainly in the lymph nodes. And even in the neoadjuvant trials, we have seen that majority of the lymph nodes which have shown increase, they have finally turned up with granulomatous, and especially in India, you don't really need to do. So that is absolutely fantastic. The patient, as you all are saying, opted for observation, was continued on pembro maintenance. Reevaluation showed stable disease. Now the patient is taken 25 cycles of pembrolizumab, and now the creatinine is 3. So this was 1.2, it became 1.8. It had gone down to 1.2 or 0.1 again, and now it is showing 3. Dr. Senthil, how would you now approach this patient?
Call a nephrologist.
Call a nephrologist, and then what?
So ask him to do whatever he's supposed to do. Right. So I think we need to look at all the other reasons that the kidney can get into trouble.
Okay.
Look for comorbidities, look for other drugs, the patient is telling you and not taking.
Patient denies, says, doctor, I have been, no Navjoti Sidhu diet, no nothing diet, patient just says.
As you are saying in the morning, if somebody in Delhi is saying that means they're doing it. Right?
Fantastic.
So, I mean, approach it like any kidney failure, right? So, oliguric, non-oliguric, look at the other causes, drugs, everything, and then ultimately, if you need to do a kidney biopsy, go ahead and do a kidney biopsy.
Okay, there is where I was coming out to be. The kidney biopsy was one thing. Dr. Stephen Liu, I think you have been itching to answer this question. So, what do you think is the culprit right now for this nephrotoxicity?
Well, nephritis can be seen with pembrolizumab alone, but it is generally early within the first 6 months, and usually those cases do have active sediment. So if we do a UA and don't see any casts or any signs of inflammation there, it makes it a little bit less common. Yeah, look for other medical things, maybe the contrast that we just gave, maybe they are using a lot of NSAIDs or some over-the-counters. But if it is persistent, we will sometimes give a course of steroids if that's the only course. And we have done kidney biopsies. I haven't had a lot of cases where they've been revealing, but certainly if you saw glomerulonephritis, you'd be worried about that. So I think a biopsy is not unreasonable if it persists.
Okay. So this is what I saw from the ASCO guidelines, and what really came to me very surprisingly is, routinely before giving any immunotherapy, you are not supposed to do a urine routine microscopy, but you are supposed to do a urine routine microscopy if you get, as Dr. Senthil rightly said, get a nephro consult and do a urine analysis. What was very surprising was, if no potential alternative cause of AK is identified, one can presume it is ICPI related and should forego biopsy. So, I will, Dr. Sahu, your comments about, how commonly do you see this and do you biopsy? Because prior to looking at this, I actually have got a kidney biopsy done for 2 or 3 of my patients, and it just showed 10.
So luckily, I have not come across such cases. So, but before stopping, and as I told, normally you don't see it early. If you see it so late, I would rather do a biopsy. I'd love to do a biopsy. Okay. Because the patient is responding so well, and there's another 10 cycles to go before I stop.
Wait, there are still 10 more minutes to go. So we will see. Aditya, I specifically want to ask about biopsy and how do you manage, because the more and more of keynote 1-8 regimens that we are giving, more and more nephrotoxicities that we are seeing. So would you biopsy or not? That is the question that I'm going to really ask.
In this case, personally, I would. That's because this is happening very late, and there can be many other factors also. And if you're, just going to take it as ICP related and give steroids, what is the end point? If the patient does end up responding, and then would we restart it again? So many other questions are necessary.
Yes, you would want to do a biopsy. Okay. Dr. Stephen Liu, again, your word, would you do a biopsy in a patient whom you are not being able to find out any other cause of this thing, or you would just scratch your eyes?
I think a biopsy is reasonable. It's generally our practice to start with steroids, though. If we really don't find anything else, we'll give a pulse with prednisone. And if we see it respond very quickly, then we're celebrating the better creatinine, but you're right, in that setting, we probably wouldn't re-challenge, and so we've fallen short. Because the data for 2 years is somewhat arbitrary, we don't feel too bad about that. But in cases where we've given steroids and the creatinine has not responded or continued to progress, those are cases where we've done biopsy. But again, my personal experience here is the handful of biopsy we've done have all been pretty normal.
Yeah, I mean, so that is what exactly our point is. This is also IO-induced hepatitis, the grade 1, 2, 3, 4. Very important is the grading of that, the CDCAE version, or the ASCO guidelines. I think we all should keep a copy of all these guidelines of this the grading of the toxicity of IO, and treat the patient accordingly. Again, if you say what they also say, the ASCO guidelines is reflex kidney biopsy should be discouraged until steroid has been attempted. All the 3 biopsies that we have got done have shown 10. We actually did not read this, and we wanted to really prove what is happening. The patient underwent a biopsy, HB showed TIN, he was tried on steroid, she was tried on steroid, creatinine gradually became normal. Now if you look at this, this was creatinine 2 to 3 times above normal. Creatinine has come back to normal. Would you re-challenge? I'll go to Dr. Aditya. Would you re-challenge this patient with pembrolizumab? So what I did was, this patient had approximately 1.5 to 2 months of steroids. We had a slow taper. The creatinine now has come back to 1.2, 1.4. It is grade 1 now. We did a scan once again to find out what is happening to the disease. The disease was stable. So patient has taken 25 cycles of immunotherapy. It's a grade 2 toxicity. Would you re-challenge? Difficult question.
I would have a discussion with the patient with a personal suggestion.
Doctor, you are God. You do whatever you know the best. We will do whatever you say.
I'll show them the guideline and say guideline says re-challenge, so I will re-challenge.
You may re-challenge. You can re-challenge. Dr. Muzammil, what will you do?
So I think there is no defined landmark that we could take 2 years or 35 cycles. If my patient is stable without therapy for 2.5 months, and this was a risky toxicity, I will hold for some time. Maybe this patient will achieve what we are aiming at, a long-term disease control, and re-challenge when it need arises.
Okay. So you think 1 year, 1.5 years of thing is good enough, and you may not re-challenge. Dr. Senthil?
When you say disease is stable, what is the residue?
There is a residual disease in the liver, in the lung, and
1 centimeter, half centimeter.
Come again? No,
1 centimeter, half centimeter.
You are torturing me now.
I think the point is, and also there is also data that patients who develop autoimmune side effects of immunotherapy also have a more sustained response to the immunotherapy itself.
So what would you do?
So if the residual disease is not very significant, I mean, it's very difficult to say what's significant, but if you feel that it's been going down and it's kind of plateaued off, stopping it and waiting, watching is absolutely an option.
For this, the nephro people have guidelines, but that what is they do.
Nephro people said
whatever nephro in my institute.
Yes.
So if you are taking immunotherapy, creatinine borderline 3. So more than 3, they say that you can.
But now it's normal.
Yeah. So if that normalization period is less than 6 weeks.
Yes, it was around 6 weeks.
So then you can challenge. That is what the nephro guys clear me.
Okay.
If it takes 3 months or more, then say they not clear. They not challenge it again.
Okay. Okay, so I think the data is there, but by grade 2, you can re-challenge, and that is what Dr. Senthil said. So patient was re-challenged with immunotherapy after very high risk consent. We took it from them. There is 1/3 of people can actually get a toxicity once again. She tolerated well, finished 32 cycles of 33 cycles, I think, of immunotherapy. And then a PET scan was done, which showed an increase in the metabolic activity of the primary lung lesion and mediastinal lymph nodes. Again the same one, and this is the lesion which was there, and along with that the lung lesion also had increased. So now this patient initially had a creat toxicity. We said no pemetrexed. Then this patient had increase in creatinine, 1 mediastinal lymph nodes. This time we convinced her to do a biopsy, and the biopsy came positive for non-small cell lung cancer. So now at the fag end of her 33rd cycle, when in the PAP that we, in the patient assistance program, Dr. Stephen, that we have, you have to buy again just in case you want to go after 35 cycles. So we did a PET scan only because the insurance was running over, and she wanted to ask, whether she really has to buy 3 more new. So at this site, there is no liver lesion, there is no brain lesion, only this lymph node which is there. and along, I'm not showing, but there is a contralateral N3 kind of a distribution of mediastinal lymph node and a small 2 centimeter lesion. What would you do? Patient is absolutely okay right now.
But we have contralateral nodal involvement,
Yes, you
right?
have contralateral node. Yes.
Yeah, so if there's a single spot, often we'll radiate those spots, but here you're talking about really radiation to the entire mediastinum, and so while that is an option, you're looking at a 6-week course, that is something we could consider, but this was someone with stage 4 disease up front, it's already recurred. My fear is that it's probably the tip of the iceberg. In these cases, we will often restart the immunotherapy, and we know from Keynote 010 and from Keynote 024, the response rate here is about 50%. So about a 50-50 response rate. So we would re-challenge with immunotherapy. And if we got a response, unfortunately, it probably means lifelong therapy.
Dr. Stephen, just to correct you, the patient is already on pembrolizumab. So after 25, we had sharp creatinine. We give 7 more cycles. The next scan is showing an increase. It's an N3 distribution. As you rightly said, the radiation oncologist said, and the patient also had liver and bone to start with. The radiation oncologist, we did put in tumor board that, whether you would like to, give radiation to that. But he said N3 lymph node with this, they were not very happy. So what would be your choice?
So in this case, if the patient is receiving pembrolizumab with progression, really I think the answer is chemotherapy. If the creatinine clearance is over 45, we could revisit the Alinta, but as terrible as it sounds, outside of the study, I do think this is probably a docetaxel case for most.
Okay, Dr. Sahu?
I think if the radiation
I really wanted everybody's opinion because there's something very strange that we did.
So if the radiation oncologist has
They wash their hands off.
So the option would be the docetaxel plus minus VEGF. That's a go-to. But sometimes because of that, people have tried in real life getting back the pemetrexed in with the
Getting back the pemetrexed, so do not give docetaxel or give docetaxel plus ramucirumab. Dr. Aditya.
Was there an anatomic increase in the disease as well?
Yes, there was. There was an
increase
increase in activity and the size. Yes.
The size.
The radiation people have said no. The surgeons actually were interested, but the radiation people said no. The surgeons are always interested in getting out the entire thing, and I told him it's the N3 disease. Please don't do anything about it.
No, but looks like this patient is on her way to a frank relapse. I think time for change in therapy.
Okay.
I will differ a little bit here. Patient is now 35 cycles.
33.
No other site has progressed in last whatever time.
Correct, sir.
It's only lung and this. I will change my radiation oncologist.
You change radiation oncologist, fantastic. I hope you don't change your moderator. Okay. Dr. Senthil, what would you do?
I agree with Muzammil. So it's 35
Change your
cycles.
radiation oncologist.
Change your radiation oncologist. Change the medical oncologist.
Change the medical oncologist also as well. So that's why Dr. Senthil is here in the panel,
So I think if I entirely agree with Muzammil's thought. If this had happened in 6 months, I would have said, let's change whether you radiate or you don't.
Yes.
But after 2 years, if it happens, I'm a little hesitant to jump into another line of treatment. Docetaxel again is not a great drug. The honorables would do that, but I would like to hold on for a little longer. So change
what
the
would you
radiation.
do?
I would radiate the primary and the N3 and then continue the immunotherapy, do an early scan. And then if you're finding new areas of disease, obviously, we have to change.
So, just in case you think your job is worse, there are far more worse jobs in life, to see. Okay. So, what we did was, since I knew Dr. Amit Rautan was going to be in the crowd, we also sent a fresh tissue biopsy and a liquid biopsy from your favorite lab, Dr. Amit, after A, B, C, D, E, F, that lab we sent, and it came still as negative. We actually gave pembrolizumab and paclitaxel because we did not actually get, the radiation oncologist was just not willing. And the patient also was very wary of getting toxicity from the mediastinitis. I think that the major risk was esophagitis and mediastinitis. So they were also not very keen. So we gave pembro and pacli. We did not give pemetrexed in view of past history of deranged KFTs. She responded well. I don't know to what, whether it was paclitaxel or this thing. After PET scan, 4 cycles, the PET scan was showing a responsive disease with
Abscopal effect.
abscopal effect of the panel actually. And after 4 cycles, the patient responded beautifully well. Is it a fair statement? Is it the right treatment, Dr. Stephen? Patient is paying out of their own pocket. She's outside of a clinical trial. Is it a fair way to do? So what I wanted to ask you is, plan B, Is there a difference if patient does not progresses within the first 6 months versus patient progresses at the fag end of 2 years? Is it okay to give, in the morning we had a discussion about breast cancer, you should continue with anti-HER2 therapy as long as, with multiple lines. So is it okay with pembrolizumab also? Your take on this?
We do a lot. There's not data for it. There's a little bit of data from the Empower Lung 1 study that was single arm. The randomized data is the Insignia trial, and hopefully we'll have a readout as to whether there's value in continuing the IO. I do think there's a difference between early and late relapse, especially in someone that stopped the pemetrexed and was getting pembro alone and had that response ongoing. It tells us that our immune system is capable of responding, and those are great patients for clinical trials or other combinations. But here, I think it's certainly a reasonable thing, but we don't really have data to show this might have just been a paclitaxel response after 6 months relapse.
Fantastic. So after 4 months, Dr. Kumar, would you do a similar thing? What would you do? Similar thing, because you wanted to end early. You were 7:30 flight, that is why probably. Okay, so just in case you think patient lived happily ever after, the patient was put on to pembrolizumab maintenance, and just last month, she came to the OPD, so after 6 cycles of pembro and pacli, 4 cycles of pembro pacli, we gave her pembro maintenance. She came to the OPD with history of cough and diminished vision. The disease is still under control, but the HRCT showed bilateral GGOs. Ophthalmic examination showed uveitis. She was started on steroids, both ocular steroids and now systemic steroids. She responded beautifully. Right now, vision is 6/6. HRCT is absolutely okay. So, Dr. Muzamil, do you have the guts to re-challenge the patient on pembrolizumab now?
The patient will tell you, "Ab mujhe chhod do."
So either patient को मैं छोड़ दूँ या वो छोड़ दे, I am not taking the patient. Okay, fantastic. Aditya?
Time to change the patient.
Okay, fantastic. Change the doctor. Dr. Sahu?
I will not. I will try to hold on.
Now you have burned your hands, fingers, eyes, lungs.
It's okay. We have achieved quite a lot, and I will wait for a frank relapse to happen before I really jump.
Okay. Dr. Amit?
There's some disease remaining. I'll go back, ask my radiation oncologist.
You can do something. Okay, fantastic. Dr. Senthil?
No, you are at high risk. Not the patient anymore. So I think I agree with everybody that it's time to give it a break.
Give the patient a break.
Correct.
Dr.
So,
Stephen, you?
because-
What would you do?
Yeah, I think both the patient and us, I think I would go for a break.
Okay, I think break. So the learning points from this case, basically, immunotherapy drugs are different from traditional drugs. Different drugs, different toxicity profile. Oncologists need to have a high index of suspicion for any possible toxicity. Steroids is the treatment of choice. Rechallenging of immunotherapy drugs is possible after toxicity, but please remember 1/3 of them will have our IRAs once again after resumption, and that is very, very important. We need to carefully weigh the pros and cons of rechallenging immunotherapy. Either we have these take-home messages, or this for you, Dr. Sahu. What happens in Goa stays in Goa at the end of it. And with this, I think I have only one case. Thank you all for a very lively discussion.
Since the panel is here, I am currently treating a patient of melanoma, adjuvant and 6 cycle mycelium. So we are giving IVIG currently. Will anyone challenge? It's a pharyngeal, only pharyngeal mycelium.
It's time to change the city, sir. Not only the hospital or the patient trying to change the city. So I would just like to okay, no. So the last one over here is just this. I think what I have learned from immunotherapy is medicine is a science of uncertainty and an art of probability. But also, this is also my favorite thing. The greater the crisis, the more significant the opportunity. So choose your patient properly. Manage the patient well. I mean, it's difficult to say, but give more time, learn toxicity management, and then things will be fantastic. So with this, thank you. Thank you for a fantastic discussion. Thank you.
Thank you, Ullas, and all the panelists. It was a wonderful discussion. May I call upon the chairperson for the next session, Dr. Sunil Gupta. He is a consultant medical oncologist from Delhi. Sir, may I request to come on dais, please.
Good afternoon, dear friends. At the outset, I thank the Reddies who has given me this opportunity to chair this scientific program for evolving treatment strategies for a lung cancer. And for that, I would like to call the first speaker, Dr. Murtuza Bohra, consultant medical oncologist from Nagpur Cancer Institute, Nagpur. He will tell us about the exploring antibody drug conjugate in lung cancer, finding from Destiny Lung 03.
First of all, very good afternoon, everyone, and thank you, organizers. So, as we move on from immunotherapy, now it's time for antibody drug conjugate. As we know, is the only antibody drug conjugate in lung cancer now is transformer deruxtecan. So, the already TDHD has been established in by Destiny Lung 01. Now, TDHD monotherapy in pre-treated HER2 overexpressed non-squamous non-small cell lung cancer by Destiny Lung 03 Part 1. So, just as a background, you know HER2 overexpression, IHC 3+ and 2+, identified in almost 3 to 20% cases of the NSCLC and having very dismal prognosis. And we have very limited HER2 directed therapy. It's not similar to like breast, where we have so much targeted therapy for anti-HER2 directed. So TDHD is approved in several regions, including US and European Union, for previously treated HER2 mutant and unresectable or metastatic NSCLC. The approval is based on the Destiny Lung 01, where the objective response rate is almost 34.1% in overall population and 52.9% in IHC 3+ subgroups. So Destiny Lung 03 is evaluating the safety and efficacy of TDHD based on the regimen in HER2 overexpressed NSCLC. So the part 1, arm 1D, which evaluated TDHD as a monotherapy in the patient with HER2 overexpressed NSCLC who has progressed on the prior line of therapy. So this is the study design. The similar eligibility criteria as in the Lung Destiny 01. So the part 1D, which consists of the TDHD at 5.4 mg per kg every 3 days. The key endpoint is the objective response rate, duration of response, disease control rate, PFS, and the overall survival, and safety and tolerability. The patient disposition, like almost 36 patients was assigned to this study and 100% has received the treatment. Majority of the patient discontinuation because of the disease progression, rarely by the adverse event. Median duration of the treatment is almost 7.2 months and the median duration of follow-up is 14.9 months. The patient demographic and the clinical characteristics, if you see, the PD-L1 status is more or less 50 similar, either PD-L positive or negative. And the majority of the patients who have received the previous therapy is in the form of the target therapy, either EGFR TKI or platinum-based chemotherapy. Some patients receive immunotherapy also. So, if you see the result, the objective response rate is more or less 44.5% among all 36 patients, and the majority of the patients has achieved the best objective response in the form of the partial response or the stable disease. Disease control rate at the 12 weeks is almost 77.8%, with the median duration of response is 11 months. Survival outcomes for the PFS, median PFS is 8.2 months, the median overall survival is 17.1 months. If you see the waterfall plot, majority of the patient has responded in the form of the partial or stable disease, rarely progression. Now, exploratory analysis, it shows that those patients having the HER2 status is 3+, having more objective response rate, it's obvious the drug will work more if the HER2 is 3+. But if you see the median progression-free survival, it is on a higher side with the HER2 IHC 2+. Might be because of the better tumor biology compared to the IHC 3+. That's why the dismal prognosis of the HER2 3+ patients. Similar objective response rate is on a higher side with the HER2 2+. And those who have received the EGFR TKI as a first-line therapy having more objective response rate as well as the high progression survival compared to the those who have not received any EGFR TKI in the first line or those who are on the conventional chemotherapy first.
if you see the safety summary, more or less similar to the previous studies of CDSD, no new safety signal are observed. Though some patient has discontinued because of the ILD, grade 2 ILD pneumonitis has been seen in 2 of the all the 36 patients. Other toxicity like nausea, anemia is easily manageable. So to conclude, result of this Destiny Lung 03 Part 1 confirmed the clinical benefit of the TDXD as a monotherapy in those patients who were pre-treated with the first line of therapy, either EGFR TKI or conventional chemotherapy. All the exploratory analysis showed that the promising activity of in HER2 overexpressed patient, including those who have received the prior EGFR therapy. These data suggest that the TDXD is associated with the improved outcomes over current second line standard of the care for metastatic HER2 overexpressed NSCLC. Major of the patient we used to give docetaxel based regimen. So no new safety signals were identified and the safety profile was consistent with the known profile of the TDXD. So Destiny Lung 03 is ongoing. Part 3 and Part 4 are assessing the TDXD based different regimen or combination in the treatment neo HER2 overexpressed metastatic NSCLC. So these results reinforce HER2 overexpression as the actionable biomarker in NSCLC and highlight the need of the HER2 IST testing in the routine NSCLC diagnostic work. With this, I would thank you all of you for the patience.
Thank you, Dr. Murtaja. Now I would like to call Dr. Manoj Mahajan, Senior Consultant Medical Oncologist, Paras Hospital, Udaipur, and he will tell us about the transforming limited stage small cell lung cancer management, the ADRL studies breakthrough. What is the breakthrough? Dr. Manoj will tell us.
Thank you, sir. So it's a transforming limited stage SSLC management ADRL study breakthrough. Next slide, please. So as durvalumab has been proven its role in limited stage, stage 3 in NSCLC, this has also come in small cell lung cancer and now in the limited stage. That is what we are going to see. Next slide. So ADRL studies durvalumab as consolidation treatment for patients with limited stage SLC. So with the background, there are hardly any major advances in the systemic treatment for limited stage for several decades, and median OS for this group, even with the treatment, is around 25 to 30 months, and 5-year survival rate is around 30%. So this study was designed to evaluate durvalumab plus tremelimumab as consolidation treatment in patients with limited stage who had not progressed following CCRT. So probably I will give the similar example of stage 3 NSCLC specific study, which has a similar strategy post CTRT with no progression and consolidation with the durvalumab. And is there any role of durvalumab in small cell? Yes, that has been proven in the Caspian study where durvalumab plus platinum etoposide significantly improved OS versus platinum etoposide alone in the first line ES extended stage with hazard ratio of 0.73. So what is the study design? Stage 1 to stage 3 patients, inoperable, PS01 had not progressed following CTRT, PSI is permitted before randomization, and 730 patients randomized in 1:1 fashion, 264 in each arm, durvalumab versus placebo maintenance with dual primary endpoints, durvalumab versus placebo, OS and PFS. So looking at the baseline characteristics, most of the parameters are quite well matched. The only thing I would like to highlight is stage 3 patients, most of them are stage 3, 87% in both the arms. So stage 1, stage 2 are very minimal. Prior chemotherapy regimens, etoposide plus cis or carbo in most of the patient. And best response rates, again, PR as we commonly see, almost nearly 72% patients or 75 in each arm. Patients who have received the treatment, ongoing study, patients who completed 24 months of the treatment, nearly 33% versus 26%. Disease progress, discontinuation of the treatment happened in nearly half of the patient with the due to disease progression. In durvalumab arm, 46%, and in placebo arm, it was 58%. And due to adverse event, 16% in the durvalumab arm, placebo 10.9%. So if you look at the overall survival primary endpoint, at the end of 32, the median OS of 55.9 months versus 33 months, quite significant, with hazard ratio of 0.73. And if you look at the subgroup analysis, most of the subgroups had benefit irrespective of the age, sex, time from end of CTRT. This group has slighter benefit when the durvalumab was started between 2 to 4 weeks with hazard ratio of 0.59. If it is started delayed, so hazard ratio is 0.9, though the number of patients are small, but that has to be kept in mind. Looking at the PFS, the median PFS is around 16.6 months versus 9.2 months. Again, clinically significant with hazard ratio of 0.76. And in this subgroup analysis, again the similar, most of the subgroups benefited with the maintenance durvalumab. But in this case, the time from the end of CTRT to randomization is not significant in terms of delayed start of durvalumab. Exposure and safety summary. If we look at the all grade 3 events, maximum grade 3-4 events around 24%, serious adverse events slightly more in durva arm, nearly 30% patients. Adverse event leading to discontinuation 16% versus 10%, and adverse event leading to death are higher in durvalumab. Most common frequent AEs, obviously with CTRT, radiation pneumonitis stopped in both the arms, and again other side effects mainly GI and endocrine, and pneumonitis was one of the side effects, nearly 10% patients in the durvalumab arm. So looking at the pneumonitis oblique radiation pneumonitis arm, in the durvalumab arm, any grade nearly 38%, maximum grade 3 slightly higher in the durva arm, leading to death. One death happened in the durvalumab arm. So to conclude, the OS with the consolidation treatment in this subgroup is 55, median OS is 55.9 months versus 33 months. PFS is 16 months versus 9.2 months. So this is the standard of care for patients with limited stage who have not progressed after CTRT. Thank you.
Dr. Mahajan. Now I would like to call Dr. Vaibhav Chaudhary, Consultant Medical Oncologist, KDA Hospital, Mumbai, and he will tell us about unveiling the Mariposa study implications for targeted lung cancer therapy.
Yeah.
Dr. Vaibhav Chaudhary.
Thank you, sir. Thanks for the kind introduction. Thank you, DRL, for having me here. And today I am going to speak on Mariposa study. It is regarding the update, the longer follow-up update, 31.5 months, which actually was presented in WCLC this year, late last year. After that, there have been further developments as well. So the trial actually tests amivantamab plus lazertinib versus osimertinib in first-line EGFR positive and NSCLC, in first-line EGFR mutant advanced NSCLC. And this is about the longer follow-up data. A bit of a background. Since the inception of this EGFR TKI, since around 2 decades back, this story has evolved quite a bit. But since past 5 years, it had hit a roadblock, osimertinib being the first-line therapy, and there was practically no challenge to it for almost a long time. Now we are having more and more options, because even that standard or very good third-generation TKI was supposedly not that good enough. Median OS of 3 years actually, and the real world 5-year OS, there are multiple reports that it is less than 20%. So even after having a fantastic mutation, if you have a fantastic drug, the 5-year survival of less than 20% actually is an unmet need. Approximately, on top of that, 25 to 40% of the patients do not actually receive second line because they are so much, they prolong, I don't know what happens. All these patients who are put on EGFR TKI, they are so comfortable, they are reluctant to go on second line, and to the point that eventually they are not fit for it as well. So this is again a real world thing, that 25 to 40% patient only end up taking first line, and that impacts the long-term survival. Amivantamab we all know is the EGFR met bispecific antibody with some immune cell directing activity, and lazertinib is a third generation TKI akin to osimertinib. We are all aware that this regimen has got FDA approval based on the median follow-up of 22 months, which was presented last year in ESMO, and it did show significant PFS benefit, which was the primary endpoint with a hazard ratio of 0.7. This interim analysis was not mature, but it did show a trend towards superiority. So this is the study design. In one arm, these are all EGFR positive, locally advanced metastatic NSCLC. Stratified 2:1 in amivantamab plus lazertinib versus osimertinib versus lazertinib. And the lazertinib monotherapy arm was included just to assess the contribution of components, and we got an answer to that. Late ESMO they presented the data that the curves of lazertinib and osimertinib, they are actually, there is nothing to separate them. So whatever advantage we have got in the results is mostly due to amivantamab component and not due to lazertinib. That also is clear. So here the primary endpoint is already met, that was the PFS, and the endpoints reported in this presentation are intracranial PFS, intracranial DOR, intracranial ORR, time to treatment discontinuation, time to subsequent therapy, PFS2, and OS. So as we all know that brain mets is quite common in this EGFR patient, and they usually fail in brain most of the times. So this strategy of amivantamab and lazertinib actually showed a favorable trend in intracranial PFS and sustainable durable CNS control at 3 years. So at 3-year landmark intracranial PFS here for amivantamab plus lazertinib was 38% as compared to 18% with osimertinib. And though the intracranial ORR was same at 77% in both the arms, but what was different was the intracranial DOR, and it was 51% at the 3-year landmark in amivantamab lazertinib arm versus 0% in osimertinib. So time to treatment discontinuation again was the patient who were longer on this therapy, amivantamab lazertinib 26.3 months average versus osimertinib 22.6 months, and more patient at 3 years, 40% remained on the therapy, and same was the story with the time to subsequent therapy, which at the 3-year landmark was 45% in amivantamab lazertinib. It delayed the subsequent therapy. In 45% of the patients were still not yet started on second line therapy, whereas 32% in osimertinib. And these are the breakdown of the subsequent therapies. Obviously, chemotherapy was a go-to drug for most of these drugs. Most of these failure in both the groups. PFS2. Now, PFS2 has been defined as from the randomization to the progression on the subsequent therapy. And that actually is an indicator of the quality of response and quality of the effect of the first line therapy. That again was at the 3 years landmark of 57% in amivantamab lazertinib versus 49% in osimertinib. Updated overall analysis, overall survival analysis did show a trend towards amivantamab lazertinib, 61% in the combination arm versus 53% in the osimertinib at 3 years after this. In ESMO later on, actually they did come up with the data from the resistance mechanism, which was in both the arms, and it was quite intriguing. They found out that the resistance mechanism in osimertinib, where we all know MET amplification and secondary EGFR mutation, and they were quite less in amivantamab plus lazertinib arm. It decreased from 14 to 4% in osimertinib versus amivantamab lazertinib MET amplification. So virtually the biggest roadblock which was there with osimertinib has been circumvented by this approach, and also the mutations which actually became resistant after amivantamab lazertinib, they were simpler mutation rather than a complicated kind of a mutation set which we get in osimertinib progressed patients. Very recently, 4 days back, J&J just announced that they have hit the OS as well to the level of statistical significance. The data is yet to unravel. They are yet to present the data. Maybe very soon we will hear from them in the form of a complete paper. And but the speculations are that the OS advantage with amivantamab lazertinib versus osimertinib, which is now standard of care standing for 5 years, is over 1 year. So that is actually some food for thought. But obviously, we have to weigh against the toxicity of the drug. More the choices, now we have FLAURA2, OSI plus chemo, we have OSI as well as this combination. All three are approved in first line. It gives a lot of scope as a medical oncologist for personalization of therapy for different kind of patients. So thanks a lot. This is the conclusion, and thanks a lot for patient listening. Any questions are welcome. Thank you.
Dr. Weber, I have a personal experience with the single agent amivantamab, not well tolerated by the patients. In a exon 20 have used once the
yes, it's very difficult drug to give.
I don't know about the combinations. Even as a single agent, my patients didn't tolerate. This is my clinical experience.
Yes.
I don't know about the house experience. What about the combination? I don't know, but the results are increasing. Yes. But this drug is really...
Yeah, it's difficult to give, sir. Obviously, it's not everyone's cup of tea. First of all,
yes,
the reactions which happen. But now I think
reactions is most important thing. Tolerance.
They are challenging, but now they are coming up with a subcut formulation, and they are claiming that they have cut down this infusion reaction to quite a bit. So let's see, we might get better drugs in the future.
Any comment from the house side regarding this? If no comments, then I would like to call the another speaker, Dr. Arun Warrior, Senior Consultant Medical Oncologist, Esther Medicity Cochin, and he will tell us about toward better outcome in the first line treatment for PD-L1 positive advanced non-small cell lung cancer, the clinical significance of Harmony 2 trial. Dr. Arun Warrior, please.
Yes. So we'll be discussing about Harmony 2. So this was Dr. Stephen Lee also touched upon this during his talk. So this is about the Harmony 2 is a phase 3 study of IO-NSC, which is also called as AK112 versus Pembro as first line treatment for PD-L1 positive advanced NSCLC. So the background, anti-PD-L1 therapy in combination with chemo has been the standard of care for the last couple of years. All of us have been using that. Monotherapy with these drugs has also showed some limited clinical benefit for PD-L1 positive NSCLC. So actually this IO, if you when we search the drug development has been quite fast. However, the phase 1 trials were seen in 2021-22. Then phase 2 came just 1 year later, and phase 3 came. So it has been a quite rapid development because it was a very effective drug from a pharmacological point of view. It could specifically bind to human PD-1 and VEGF with a high affinity. And the reasons that they gave from this landmark paper is that they form soluble complexes with VEGF. And there is something which Dr. Stephen called as a cooperative binding, where the affinity of PD-1 to the VEGF is increased by 18 times. And in this drug, in the vice versa, the PD-1 increases the VEGF solubility, the affinity by almost 4 times. So it's a cooperative binding which happens here. So that is the reason which they are telling about greater anti-tumor efficacy. So this is the data which shows that there's a rapid increase is there about the affinity, the phenomenon of cooperative binding, which is very important in this type of drugs. So we all of us are aware of the combinations of how anti-PD-L1 and anti-VEGF, which has been in clinical use for a long period of time. We have various agents which are combining like ADCP regimens and all. But here the thing is that both are given, it's a combination of drugs, and the combined effect is there in one drug itself. So so this is the phase 2 which came in, which was there in 2023 ASCO. So it is again in patients without actionable mutation of EGFR and ALK. So in this phase 2 results, it was the follow-up was around 11.5 months, and the responses was around 75%. Both squamous and non-squamous cells were there, and being phase 2, the focus was on the adverse events here, and it was tolerable. So that's why they went ahead and did the phase 3, which is a very bold thing to do, because the direct comparison was there against pembrolizumab. So this the phase 3 data came in WCLC in September. So around 388 patients were there. So stage 3 then stage 4 without any prior systemic therapy, without EGFR or ALK. The PD-L1 more than 1% was there. So it is a direct of IO versus pembrolizumab, and the primary endpoint was PFS, and PFS is being reported here. So if you look at the baseline characteristics, almost less than 60, more than 65, almost 50% were there. Males, almost 82% were males. Good performance status again, PS1 was around 88%. The never smokers was a small subset of just 20%, while the current and former smokers compress around 80%. The 3B was a very small, minuscule of 8% only. Pathology was again squamous 45 and non-squamous around 55% was there. PDL1 1 to 49 more than 50, 60, 40 ratio was there, again balanced across the two groups. So the primary endpoint was about PFS. So the IO showed a PFS of around 11.1 versus Pembro showed 5.8. So this was a dramatic jump was there, hazard ratio of 0.5, which was highly significant. And for the subgroup also, you can see that almost all are there, almost all are falling in the narrow range here, except the PS0 patients, a small number, and which what is sitting on the fence is the clinical stage 3 again very small, maybe 8% only. Otherwise, we can say the majority of them are falling into the hazard ratio of maybe 0.5 to 0.6. And this is about the key PFS analysis of the PDL1 expression, that is 1 to 49 and more than 50%. Again, the hazard ratio of 0.5 and 0.4. Whether it is squamous or non-squamous, again the hazard ratios are quite similar, 0.48 and 0.54. So in all the relevant groups, the hazard ratios are remaining same. And if you look at the overall response rate and the disease control rate, again we can see that compared to Pembro, there is a big jump is seen here. The response rate 38 versus 50, and the disease control rate 70 to almost 90%. And the safety summary also, we have to expect the combination of the side effects of immunotherapy and anti-angiogenic will be there. So that was what's expected here. So definitely the proteinuria, all the other side effects will be more. But then again, it was comparable. And we have the immune-related adverse events. So comparing Pembro to IO, we can know that all grades is 28 and 29. And definitely the VEGF rate will be definitely higher. So it was 21 versus 47. So more than grade 3 was around 10.2. So we have to be a bit careful of the VEGF rate adverse events like proteinuria, hypertension, all of us know how to manage. So definitely that is expected to be more compared to Pembro. So again, one important thing, because it's our palliative setting, the global health status also was compared, and the median time to deterioration was actually similar across both groups. So numerically better, but not much of a difference was there, the hazard ratio being 0.92. So well tolerated drug. So I think more one or two extra points from the ASCO post, the invited discussion was there. And what they, the three main questions what they asked was that whether there is a need, that is what they're on. And is there a mechanistic reason? Definitely we know that is a cooperative binding is a reason here. And whether there is a greater activity than the combination, that is the most important question here. So the answer that he gave was that it may be there. Although because of the unique mechanism, because it blocks the VEGF alpha, and the VEGF receptor 1 and 2 are blocked here. Because for the tumor angiogenesis, the VEGF receptor 2 is a driver, but the anti-immune effects are mediated by the VEGF receptor 1. So because it is blocking both, that is a unique reason why the IO-NSIB is definitely is going to be more effective here. So the issues are that like Chinese subjects alone were there, and whether Pembro monotherapy is the appropriate comparator is again an issue here. And outside China, we have to have the results here. So definitely there was a harmony for a long time, almost a decade here. But definitely the progress will come only when there is disharmony happening. And a lot of drugs are there among this in this subset. And these are all drugs which are all entering into phase 2, phase 3 trials. And as recently now, there is the Merck has also actively brought these drugs, and definitely it is going to be an important class of drugs in the future. So conclusion, I think I have almost told all the main things now. So the PFS improvement is so, and it is there across all the subsets. That is a TPS high or low, or squamous or non-squamous, definitely it is more, and the response are also more. And we have to see that is a more side effects will be there. So that's all from my side. Thank you.
Thank you, Dr. Arun. Now the scientific presentation is over. Now it's a time of an expert discussion once we have a full presentation. And for expert discussion, I would like to moderate the session by Dr. Amol Akhade, Senior Consultant Medical Oncologist and Hematologist at Sir L.H. Hirandani and Godrej Hospital, Mumbai. Dr. Amol Akhade will call all the experts, those who will discuss the scientific feast, to the host. Now, Dr. Amol Akhade, please.
So can I have the panelists who are supposed to be there? Can I invite Dr. Manohar? Yeah, Dr. Manohar is there. Yes. Then can I have Dr. Rohit? Dr. Vijay? Dr. Ajay? And we, of course, will have Dr. Sahu and Dr. Senthil as honorary panelists. Yes, thank you. So then Dr. Ajay is not there. Dr. Kumar sir is there, so please invite him. No, it's not delayed. Dr. Sahu is delayed, everybody's slide. So let him also come. So thank you at the onset, organizers, for having these interactions. And everybody is coming outside. Oh, his slide is on time. So I think we'll start with the panel discussion. I have no conflict of interest as of now. Thanks to Dr. Sahu, he is not doing anything to get me conflicts of interest. I have repeatedly told this. So to begin with alternative study design, so let me ask Dr. Manohar, what's your opinion about the study design? Are you happy with it? So they have taken stage 1 to stage 3, limited stage small cell lung cancer, they have given CTRT. Then those who are not progressed, they have taken divided into 3 arms. One was placebo, one was Durva plus Tremi. Kumar sir, please.
Yeah, there is a.
So are you happy with the trial design?
Yeah, I hope so. Since in this space we have had a lack of development since several years. So this.
Are you happy with the 3-arm design?
Yeah.
Okay. Anyone else has any comment, Dr. Rohit? You are also happy with the 3-arm design? Okay. Because the issue is that anyone else, Dr. Sahu, any comment on the 3-arm design, or Kumar sir?
So maybe I have not looked into statistics completely. The key will be that how is the design done? How is the alpha being shared or not? Was it the third arm only to many times, like for example, Lazatinib trial plus Lazatinib plus amivantamab.
The Marigold.
Lazatinib arm was not for evaluation. That was to get a hang of it. How it was done, that will be the key. But key is that you have got 730 patients randomized of localized small cell lung cancer. This is a Herculean task.
Actually, they have a secondary endpoint which is looking into the IO versus the placebo. So that it's a pre-planned.
But do you have any idea about the results of the third one?
We don't have. So my point here is, yes, you are going to get some data set on IO. Yes, you are not going to get a comparison of a IO versus IO. That's how you typically see every AstraZeneca trials being designed now. I think we have seen in ovary, we have seen in endometrium. You won't get what
happens. Sometimes we do not get the third arm in the clinical trial, and sometimes we get a third arm, but we don't get the result of the third arm. So what has gone through the trial design, and what has happened is that we of course don't know yet the results of the third arm, and we hope that one fine day we'll come to know that. The randomization of course is done post CTRT. That means we are selecting those who are having good biology probably. And if you see the methodology, the first 600 patients were randomized to 1:1:1 in 3 arms, but the protocol was amended in 2020, and the next 130 were randomized only into 2 arms. So, of course, they have done the statistical analysis saying that no, the power of the 3 arms is not changed and all other explanation. But this is not the ideal situation, that they are starting with 3 arms, then they are only going into the 2 arms, that also way back in 2020, and I don't know whether the third arm results will be ever out. So this is somewhere where I am uncomfortable slightly, and I agree with Kumar's point that it is a Herculean task to get 730 patients and to randomize into the 3 arms, but at the same time the third arm is probably, I don't know whether we will get any results. Any thoughts about this?
Couple of things, Amol. First thing is, I'm glad they didn't give durvalumab during the induction, because what you're getting from Pacific 2 is a failure. 30% of patients don't get into the consolidation arm. So I'm very happy that they didn't do it, because it would have been another wasted exercise. So that's number one. Number two, it's also important to know why they stopped enrolling on the third arm. Right? It might be for multiple reasons, futility.
So that explanation they are not given in that list.
Okay. I'm just saying, so that it could be for a patient-centric reason. We don't have to always suspect that it's for a industry-centric reason. So it could be a patient-centric reason. So I think till we know what happened, it's not appropriate for us to comment on that. And third is, as long as the statistical power of the first two arms and the primary objective is satisfied, that's okay for us. I think that's the way I look at it.
So the last line is important, and it's very clearly mentioned in the text that it does not change the statistical power or the design or anything.
So all I hope is that I hope the third arm results eventually comes out.
It's a secondary endpoint. It's a design secondary endpoint, I think.
Yeah. So now another point that I want to raise is that, as was said by Kumar sir also, that they have taken good biology patients, and I wanted to raise the similar trial in a similar group of patients with a different IO. And what the only difference is here is that they have given 2 or 3 additional cycles along with radiation. And then if you see at the overall survival curves, they are drastically different. That means just change of the drug and give 2 or 3 additional cycles. That's the only difference. Plus, they have taken everybody. They have not taken only those who are responding. Then, so are we justified to say that the trial is as good as the drug is as good as the trial design, or it is just by sheer luck that one trial got positive, one trial got negative? Because this trial, if you see the overall survival curves, they are absolutely, there is no difference. But at the same time, the previous trial with a similar design, there is a lot of difference. The trial is positive. So what are your thoughts on this?
So I think what is important to see is what was the progression-free survival in this.
So if you see the OS
is okay. I agree with you. So the point I'm trying to make is, did Atizo add to the toxicity and end up a lot of patients maybe dying? You just don't know. What was the PFS even that led to the problem which ultimately ended up in a poor overall survival is important to see. And it's just exemplifying what happened in Pacific 2, that it's not a great idea to do chemo and immuno along with radiation, is what my take home from both of these studies would be. So correct. So there's some.
So if you see, the grade 3 pneumonitis in Adriatic was 3.1%, in Atizo was 5.6%. That means there is a 102% increase in the grade 3 pneumonitis. So just by basis of increased pneumonitis rate, grade 3 and grade 4, significant pneumonitis rate, we cannot explain the difference in the OS. It is hardly 2% increase.
Sorry to keep talking so frequently, Amol. I think we need to know much more about what happened before coming to this conclusion. There could I'm saying that your own favorite censoring issue. Let's say 10% had grade 2 pneumonitis and all of them withdrew consent. Right? Okay. You just don't know what happened. I think it's a little too early to come to big time conclusions with just an abstract that was presented in a conference. I think it's important to wait to see what else has happened, what caused the events that we are talking about, and then probably come to a good conclusion regarding what it is versus not. That's the way I would look at it. I wouldn't jump to conclusions.
The median PFS was not different. That's, I want to clarify this. It was the similar, 11.5 versus 12. The only thing I need a clarity in this Atizo is the concurrent use of the immune checkpoint with the radiotherapy. So that is something that I am not pretty sure. So if that is the concurrent use, then we have...
Yes, concurrent use is done.
So that's what he pointed out, and that's what I learned with Pacific. So the radiotherapy with immune checkpoints is something that...
So that's what my point is. There is an additional 2% increase in the grade 3-4 pneumonitis. Does that explain the lack of OS? And what, at this point, unless the trial is fully published, we cannot...
There is no PFS benefit.
So, you have a valid point that you have one trial positive, one trial negative, and we need to have the discussion what happened. Now, in this situation, I have one anecdote, and which is one way to learn about it. When the lung cancer second line trial came, we all remember Pembro and Nivo, which was positive, and Atizo. What we forget, at the same time, there was trial for durvalumab and there were trial for evolumab, and both failed at the same time. So you had
3:2. And again, the issue used to be there why 2 failed and these 3 succeeded. And as the time went by, we have many other indirect evidence which validated that, hey, what we are seeing that is real, and then we need to also focus on the drug we are using in certain situation. They may be acting differently. Initially, I also used to believe and always to say, hey, PD-1, PD-L1, take any of them, they are similar. Looks like not necessarily. Maybe they are different. As you said, trial design, as Senthil said and Sahu said, we may have certain information which may get as the time goes by. But we learned from lung cancer that subsequent data may help us understand, hey, where, what happened. And this will happen more and more because now you have got 7, 8 checkpoint inhibitor and different places, different combination will be used where we'll get some positive and some negative. But in the places where you start getting consistent data, we will be, and again, we learned from bladder cancer, you have 5 of them approved based on phase 2, and you had 5 out of 4 of them got withdrawn, had a withdrawn from the FDA. And subsequently, again, you have now more than one looking good in first-line setting.
So basically, there is no set rule that something will work.
At this moment, ensure they were not going to stop here. For example, pemetrexed, and this was famous because this is our era, in my era drug, not your era drug is this one. Pemetrexed, first randomized trial which was done, it was criticized, but subgroup analysis got a label.
Yeah,
but that was the basis we think pemetrexed is good. We started thinking it is good enough because you have next to more trials of maintenance in a different way. Switch and combine and say, hey, wherever you are putting looks like it is giving consistent results. So these drugs will be tested in this situation. This is the first trial, so we are excited and we will be saying for and we will be criticizing, but they will be using in certain situations and that will give us a clue that in this situation, this is going to stay. Or not going to stay.
And then the other causes of mortality are more, because again, Pacific, sorry to go back to Pacific again, more than the pneumonitis related mortality, it was infection related mortality that was different. So, correct. So we just don't know whether it was a pneumonitis related infection or it was something else unrelated. So I think we need more data.
Yeah. So moving on, of course, any comments on, are you happy that KM curves or the athletic? Any comments on censoring, Dr. Sahu?
Not exactly censoring, it looks balanced for both the arms. Yeah. I'm more impressed with the duration. If you look at the survival for the placebo and the durva, look at the things in 37 months versus not reached, and in the placebo you do find the maximum that is happening is around 39 months. So here you have a drug that is really effective. So that is the thing which I believe.
The good point about the trial is that I went through the literature of the publication. The censoring is same on both arms, and they have mentioned that in the NAGM publication. So yes, the KM curves looks good, and we are happy.
Upper the middle OS, it's the range which has impressed me more.
Yeah. Now moving on, is it necessary to know about the post-progression therapy, Dr. Rohit?
Yeah.
Because, will you be interested in knowing what happens to the control arm? Did they receive the durvalumab on progression?
Yeah, crossover definitely is something that we need to look at because how many of these patients post-progression actually received immunotherapy? That's something that we need to.
Okay, Dr. Manohar, will you be interested in knowing post-progression therapy?
Yeah, I agree with Rohit. And
because unfortunately, I have not found it anywhere, and I had asked 2-3 experts on the X also, and the data is not yet released. So, is it necessary to know? Because one theory is that the durva is approved in the latter setting, but on combination with the similar chemo. So, if you are using chemo plus IO upfront, on progression, are you justified to use the same IO with the same chemo or different? What's your thought on this, Dr. Sahu? Or in this scenario, you are not interested in post-progression therapy? Whether the patient has received on control arm IO or not?
Two things. After the use of IO in small cell, at least I understand it's a limited versus a extensive stage. You don't have much data that the IO works beyond the first line. Even the people who used it concurrent, it has not been found beneficial. Even beyond, it has not been found. I don't think the second line IO, I don't know what will be the chemotherapy skeleton with the IO. I'm not sure of how much benefit will happen.
So you are interested in finding out how much control on that?
I would be interested. It is not that any more information is always a good information, but will it make an effect on the duration of the survival curves? That I feel.
The crossover was not mandatory according to you.
I don't think so. I don't think so. When there is not an effective second line, which you know, which is as good as in such trials, I don't feel it should be mandatory.
Your thoughts, Sandil sir?
So I think in the control arm, it is important to know. The reason why I'm saying that is that if your patient relapsed with disease after 3 months, then you would end up reusing the platinum.
Yes.
So if you end up reusing the platinum for a relapse, I would add the IO at that point in time. So it probably makes sense to know that. But if you belong to the school of thought which says that the incremental benefit of IO over chemo is very small, if you just look at the median, overall survival, then it's okay, So I would say yes and no. I'd love to know about it.
Why wanted to search for that? It is their own trial. Caspian was already out at the time.
I would definitely love to know that. But if most patients didn't get it, I would still be okay because it's not going to make a big difference because the difference in PFS that you're showing is huge. And that's for me good enough to get onto this because when patients with small cell lung cancer fail, they kind of blast all over the place and most of them are not fit for therapy. So a clinically significant PFS in the first line for me is good to get on with this treatment.
Kumar, your thoughts?
Yeah. So can you go back to the slide? Yes, correct. So, and this is one of those issues which we see in many drugs, and this was not in my era. If something doesn't work so well in second line, it is not changed in first line, and adjuvant also used to be equally bad. Now, this in modern era, we have drugs, and when you start shifting where they are used, the impact is also different. I'll give one classical example and then come back to this example. One is docetaxel. So docetaxel was in prostate cancer, the publication came when I was doing my DM. Dr. Ian Tanak, who was the first author and corresponding author, and it was first time that in prostate cancer some chemotherapy works, and it was 3 months survival benefit. And it was new for me also as because I was in oncology university. 3 months, it was so striking, and it was considered a landmark paper. Now come to hormone sensitive. It was CRPC. It was 3 months. Come to hormone sensitive, depending upon low risk, high risk, which one you want to choose. It varies from 10-11 months to 21 months. So it means when you put the drugs at different situation, you start getting a bit of a result which is a far different striking than what used to have in different situation. Now let us see here in what happens. The median survival, if you use in a metastatic setting in small cell, median is 2 months. I'll come to 5-year survival also. But first median, it is around 1.5 to 2 months. That is what you add. Here, you are adding 14 or 15 months, 33 months, what are 54 months. Yep. Now, let us see that you best possible scenario what you add, 2 months, 4 months, 5 months. But whatever we look, looks like immunotherapy added here, it's giving far more value for money than when you are using there in that situation. But there can be argument, and that one argument is that if you take long-term survival data, now it is there for durvalumab and atezolizumab both, it varies from 12% and 15%, and we say all the benefit is because of immunotherapy, then we can have a separate argument. But we all know that may not be fair way of looking. So if this data stands true, it is very useful. Now, we can go back to the slide again. It really happens in oncology that you use immunotherapy and the curve starts separating so early. It's not very early. It is not from
around 9 months.
Yes, and usually if you go to the palliative trial for atezolizumab and durvalumab, it starts very late. It doesn't start so early. So it looks like again it is doing something in these patients where the impact is relatively early, impact is relatively wider than what we have seen in the past. but criticism is absolutely valid. This data is usually there. Today in immunotherapy trial, usually they deliberately put that table because they want to claim that, hey, or 30% or 40%, we have given immunotherapy in second line or given in a metastatic setting if we didn't give adjuvant to validate the point. So I'm a bit surprised that they have not put it. Most likely they will put it because this will be questioned to them again and again by people.
So now moving on, are you okay with the duration of over 2 years? Because if you see the trial data, the median cycles, number of cycles that the patient received is only 9. So is it really 2 years required, especially in our country in cost point of view? Do you think that the less number of cycles also will be okay? Because actually median number of cycles that the patient has received in trial is only 9.
So
this is a very important point. Do you really have to give it for 2 years or maybe less than, maybe 1 or 1 year?
Yeah. So in principle, I agree with you. We have learned from many other drugs and especially zoledronate. Trastuzumab, we have learned from that. Given lesser duration is a good idea. Only thing which I was very gung-ho till got that that trial of which one is nivolumab. I'm forgetting the term. Nivolumab trial, 2 years versus less than 2 years, and that that was striking, and that troubles me. But having said that, I am very keen that that maybe duration we don't know, but duration gap in between definitely can be because we are running at this moment. We can share with you next year.
So I just wanted to ask anyone who has used it more frequently, this particular regimen, how many cycles your patient is able to take?
I have not used this regimen as of now. First thing.
But I think so I'm not alone.
The first question that I wanted to start, I
think you're missing a point here. If you look at the OS curves or the PFS curve, you have the PFS curves?
No, I don't have put up here.
If you have a PFS curve, you'll get your answer that it's a mean. So if you look at the range, it is 1 to 26.
Yeah, it is a 1
So basically there is a drop that happens and there is a stabilization of the curve. So you cannot tell by the mean that this is the lesser duration is required. So this is a bad disease. All of us know that within 6 months you have maximum relapses. So what it has done is the duration of 2 years has prolonged that plateauing, and the plateauing has happened at a little earlier point of view. I hope I have got that.
So this is one Amol, and the second is 18 for cervix. There also I think 2 years is a little too long.
Yeah.
But
most of the people, I don't know why they take 2 years.
We just don't know the answer to that question. But just like we take patients to 2 years in stage 4 disease, I don't have a single patient who has taken it on dot at 3 weeks for the past 2 years. In fact, patients will ask, in fact, sometimes I might start prompting you to ask that question. Should he be coming so early, so frequently?
So moving on, in this trial, they have the subgroup, which is planned subgroup, PCI versus no PCI. So, and if you look, so what is your practice? I want to ask Dr. Manohar, what is your practice? Do you give PCI or don't give PCI in a limited stage small cell lung cancer, or you go for MRI surveillance? Because the trial has not shown any difference, but our patients may not be receiving durvalumab. And what I've shown, if you see the control arm which got PCI, the results were 56.5%, and the other arm, and the control arm, which did not get PCI, there was 37% results. So if PCI was a drug with 19% improvement in OS, everybody would have said, yes, use PCI. So are we using PCI all our patients, or we are okay for MRI surveillance for those who are not able to receive Durva? Those who are able to receive Durva, there is no much of a difference. But what about the control arm? So what's your thoughts? Do you routinely do PCI or go for MRI surveillance?
It's a shared decision making, and I would discuss with the patient. My choice would be PCI.
What about your thoughts?
Yeah, definitely we go with PCI. MR surveillance is being tested in 2 trials. We don't have the data yet to go for MR surveillance.
Anyone else before the regular agrees that especially the patient is not going for Durva, you go for the PCI, knowing that there is a 19% difference. We will require some more time here, please. Of course.
So we do use PCI, and I agree with you. We also do use a PCI in this setting, not necessarily because of this 19% difference. This is like there is a randomized trial for PCI versus PCI, and it was 4% difference. But small cell 4% is important. You do take it.
So everybody agrees that we will like to go for PCI, especially for those who are not receiving Durva. Those who are receiving Durva doesn't make a difference.
That conclusion, last part is something which I have a problem with. The first part is okay. If you are very clear that the MRI is going to be costly, a patient not going to be adherent to it, PCI is the safe way out. That we know. Will not giving Durva PCI overcomes that? Not giving Durva is something which I am not.
No, I'm just extrapolating the result from the control arm. That in our real world situation, most of our patients don't afford
I don't think they meant that way. This trial, the answer.
100% not based upon the trial results. What the trial says that whether you use PCI or not, Durva adds the benefit. I am just trying to analyze the control arm because our situation is in the control arm. So that is what I'm trying to analyze, that in our situation, should we give for PCI, saying that there is an additional benefit?
Amol, to really, interpret that 19%, you should then look at how many of them failed in the brain and died because of that.
Yeah.
We don't have that. So I think subsets, we tend to overinterpret. I think we should leave it at that, I suppose.
And the last
last
question on this particular trial, how are you able to treat them on progression? Suppose they have received Durva and then progressed on Durva. The CTRT plus maintenance Durva. Any thoughts? Dr. Vivek?
It again depends on what, like if the patient has completed all cycles and progressed after 2 years, if the disease-free interval is more than 6 months, I think there's no data to it, but probably I would use immunotherapy again. But if it's less than that, we would go for only chemotherapy.
Anyone has any difference of opinion?
No, I think.
Because there is a guideline which is published just now.
I have not seen that, but point is I would normally look at 6 months as a platinum free, but I am more comfortable with. Otherwise, a single agent irinotecan or a taxane is probably how I would do that.
So what they have used is a cutoff of 3 months, what Dr. Senthil was saying. Instead of 6 months, if the patient is progressed after more than 3 months of chemo IO, then
how did the 3 months come in? Normally you are taking platinum, in head and neck, we had that issue.
I would say our time, maybe you can also add it. Our time, the easy way that people used to teach is 6 months in ovary, 3 months in small cell, and 3 weeks in germ cell tumor. So that's easy for you to remember. So this is not something new. This is 20 years.
So now I think we have some more time, so at least we will discuss one more trial, Mariposa. So, yeah, one quick question. Now that we have a press release few days back that the median OS is improved by 1 year, and if you have patients with all drugs available, no brain mets, common mutations, what will you do on Monday morning? Will you use the Mariposa, will you use OC alone, OC plus chemo, or you will use subcutaneous amivantamab plus lazertinib? No, if you have a patient on Monday morning and you have all the drugs available, now that there is 1 year OS difference, as per the press release.
No, in this, actually, to be very honest with you, amivantamab is not a very easy, I mean, it has a extended dosing schedule, and also amivantamab is a very comfortable drug for patients to take.
So, if it's difficult to treat disease, you are going to ignore 1 year OS difference.
No. The thing is, it should be a shared decision making, because how the years that the patient survives, what's the quality of life in these patients also needs to be taken into consideration. I think we need to present the toxicity of the drug.
Use subcutaneous amivantamab.
So I think the Paloma 3 is something that will change practice. The subcutaneous amivantamab is considered to be much safer and will be more doable to us. The cost will definitely play a role, but in most of these cases, practically today we go to osimertinib single agent, that's for sure. But with the Paloma and the drug being made available subcutaneous someday, I think people will shift towards the combination because that is superior.
So everything is available. You like to go for subcutaneous amivantamab plus laser, and you will not keep the OC later. So you will keep the osimertinib later and use subcutaneous ami plus laser.
I'm not sure.
There is 1 year median OS difference.
I'm not sure how osimertinib OC will work after the failure of lazertinib with amivantamab, because ultimately lazertinib is also a third generation TKI. So
what will you do? That's what I'm asking. Will you still OC?
Chemotherapy? No.
First line. First
line. At some day when subcutaneous available.
Everything is available.
I think that will be the protocol which I will go for.
So you are forgetting the OC. Fine. Anybody else? Or everybody is going to forget the OC and go to the
first line? You're not going first line, huh?
First line.
But why is OC coming in here?
No, first line, all drugs available, EGFR mutated patient, and patient has common mutation and no brain mets. What will be your regimen of choice for the first line?
I told about the why did you tell docetaxel?
No, I'm not going to OC method. He's not happy with the LG, he's forgetting the OC method.
No, I just spoke, as on date, OC will be a go-to drug. once Paloma is there, the data is mature and looks it's safer, the subcutaneous is within the range, I think that would be also a good option to go for.
So anyone else would like to refer to sir?
So do we have, Mariposa curve, do we have OS curve is there?
No, not yet. You only press on this.
No,
original curve is this.
No, this is the original curve. This is of which one?
Mariposa.
Mariposa. Do we have for osimertinib plus chemotherapy?
No, I'm not put it here. I'm not put it here.
So I'll give you a perspective. We always talk about that, pharma trial we have and which is statistically significant, clinically not meaningful. And that's a fair criticism. I'll say other way around is true. And we should remember that many times it will be statistically not significant, but clinically meaningful. And that is what has happened with osimertinib plus chemotherapy. I'll say go back and see the survival curve. If you see the survival curve looks like, for a clinician, for me to decide, if you see the curve looks fairly mature. It doesn't look like this is going to change significantly. If you see the median, you see the hazard ratio. In no way, and I'm assuming I don't have the curve, I have this OS curve for lazertinib. I don't have the curve for updated. Looks like it will be similar what you have. Not with 1 year, don't get me wrong. The median and hazard not necessarily go together.
Yeah, I agree.
We have a randomized trial of PFS. One can go back and check. Nimatinib, the median PFS was from 30 to 60 months, but hazard was 0.8. So not necessarily they go together. But if you go to hazard and see, it will look similar. Sure, they have got in the analysis the way the trial was designed to go to press release that you have a survival benefit. Same like Checkmate 816 not able to claim, but 671 is able to claim that they have a survival benefit for pembrolizumab trial, but not for Nivo. But we all think that they are similar outcome. For this also, my feeling is it looks similar. The decision will be primarily based on the kind of side effects and the logistics what you want to deliver. That will decide this combination when we deliver, because chemotherapy in osimertinib, what it has done, it has overcome many of the problems which we had with the osimertinib alone for Asian, the exon 20, many other things which we had, which is not the case when you combine.
So for you, what will be the first choice?
For me, because easier for me, because lazertinib is not available, amivantamab is damn costly, so it remains for me osimertinib plus chemotherapy today in my clinic. So now, if I go again, if they have both of them available, I will measure. There are patients who doesn't want chemotherapy, and I do understand that. There are patients who doesn't want chemotherapy. But I have also seen amivantamab based nail changes. I have seen amivantamab based skin changes. But yes, if patient doesn't want febrile neutropenia, they are okay with skin reaction, I'll be choosing it. So again, repeat, it will be side effects and logistics which will decide that part. Sorry, I took it longer.
No, I just want to tell, once we get the Paloma data of subcutaneous, the skin changes are much lesser, 1/5 or lesser. I think we get a hang of it. It will be between OC chemo versus lazertinib, subcutaneous and lazertinib. But you're not going to use chemo OC for everything. So it will be between the three, osimertinib, OC plus chemo, and lazertinib plus subcut amivant. IV is going to go out. That's my take, number one. Number two, as we get hands-on experience, we will know exactly, like the TP53, we had a discussion, I understand it's exploratory analysis, that the osimertinib plus chemo does not work that differently in a TP53. In lazertinib and OC it does. So my point is, it is not going to just be that easy, but these three options are going to stay.
Fine, I think we have discussed 2 trials, and I think that should be the end of it because we're running out of time. Thank you.
The only reason you think about lazertinib, where it will be, there's a strong point is, hey, I'm saving chemotherapy somewhere. And if you've used it, but counter argument is that you're saving amivantamab subsequently. But the data for amivantamab post OC chemo is not there. It's post osimertinib is there.
Other than Mariposa, also the third arm again like the Mariposa.
How many had amivantamab after progression? Hardly anybody, nearly zero. OC will not show, Flora will not show overall survival benefit, or less likely, I would say, because significant proportion will get it sometime. So that's very important to look at here. And I think at the end of the day, we will get to some biomarker is what I suppose, so that we can
And the last point is that I don't think so. We have again the third arm results of the Mariposa, the only laboratory arm. Again, that result is.
It was not competitive. So don't get me wrong. So they have never powered. They have written in the trial. No.
What is the contribution of amivantamab and what is the contribution of lasertinib in that combination?
That I get. That is the problem. But in fact, okay. So that was one of the reasons why they had this third arm. The third arm was to show that there is a randomized trial for lasertinib versus osimertinib, which is already there, which looks like they are similar. But here they also wanted to show that lasertinib, osimertinib, do they go together? And it looks like in the study they go together. And that was to prove that they wanted to show somehow they are attached to lasertinib. So they wanted to show that lasertinib is as good as osimertinib in another study also. And that was the reason. There's a comparison.
So somehow they are attached to lasertinib. I like that.
They will be.
Thank you.
And again, they wanted to put 216 patients for it. So remember, again, highlighting, you have different ways of doing trial. Here they put it like they say, hey, you have comparative. They say, hey, don't compare. They are not part of a comparison. In fact, the first time when they submitted, because I was part of the study, when they submitted to IEC, they also had that as the time goes by, they will get the interim data and then they will have final statistics. The final statistics was not there. Was it wrong? No. They wanted to have data to have a final statistics. So there are multiple ways to do a right study. And again, this is one of them.
Yeah. Thank you. So I think we're running out of time and maybe we'll run out of the flight also. So thank you very much. I thank all my panelists. Thank you. Then my room is empty. You can come back.
Good evening, everyone. And before we begin the next session, that is the GI session, would love to thank Dr. Amol and other panelists for helping those who are present here survive beyond the coffee and tea, that those rounds that have been going on. So I would like to welcome Dr. Amit Ratan. Now, Dr. Ratan requires no introduction. He's a session director for GI cancer and the head medical oncology, Manipal Hospitals, Bangalore.
Good evening, everyone. First of all, thank you, Dr. Reddy's, for having me here. So we've had a long day sessions, and this is the last session, and we can see everything is empty from the first row to the second. So there's going to be very limited people. So let's do it quickly and maybe make it lively as possible. So the reason, the few topics which we selected for GI are, GI is unique in many ways, it's leading in many ways in oncology in various solid cancers. One especially MSI-high disease. It's from GI we have learned that in neoadjuvant setting, getting away with immuno and not doing even surgery. And I don't think that's ever happened ever in any solid tumors. So only immuno, no surgery, no radiation, and that's curative treatment. And I think that's very interesting. It's worth talking about because that's a learning experience for all of us. Second, MRD testing. We keep saying minimal residual disease, molecular residual disease, but we don't use it anywhere in solid tumors. And we are learning how to use it, and GI oncology, colorectal cancer is teaching us how to do it, and I think that will be another very good, important discussion. Of course, new markers, that's very important always. We're getting new therapeutics. So let's put all this together, and maybe then with that, I'd like to kind of invite our chairperson. Dr. Prabhakar is our chairperson. He's a senior consultant medical oncologist from Kunukan Hospitals, Coimbatore. Welcome, Dr. Prabhakar.
Good evening to everyone. At the outset, I'd like to thank Dr. Reddy's Laboratory for having me as the chairperson for this wonderfully organized scientific program. Without much ado, let's go to the scientific program. So the first talk will be by Dr. Sumit Goyal, who is the Associate Director of Medical Oncology at Rajiv Gandhi Cancer Research Center in Delhi. He'll be talking on advancements in the management of MSI-high rectal cancer. Over to you, sir.
Thank you, Chairperson, sir. Thank you, Dr. Reddy's team, for giving us this opportunity. Dr. Amrit, what you said absolutely makes sense. But lung, can we extrapolate lung to other organs is very difficult. I know in lung there are studies like 1 + 1 is 2, 2 + 1 is 3, but in colorectal cancers and GI cancers, the scenario is little different because there are subsets. We don't know whether we will ever have a consensus because there is so many things which are exciting and about to happen in GI. As you rightly said, ctDNA and all, and newer markers, they are worth watching in the coming era. So colorectal cancers, so I will be talking on the MSI-high rectal cancer. So not everything is black and white. There are a lot of gray areas and gray zones in between. So epidemiology, we all know colorectal cancer is third most common cancer worldwide. Close to 19 lakh people are diagnosed every year, and about 50% of them, they die. So there is a huge unmet need, definitely yes. And talking about MSI-high patients, about 10 to 15% of all colorectal patients are MSI-high. So IARC feels it anticipates the likelihood of increase, about two-third more incidence is likely to be there by the time we reach 2045, and about 80% is the likely mortality for all these. So definitely there is a need which we need to address both in the preventive and the therapeutic areas. So MSI-high, conventionally we are diagnosing by IHC or PCR based. So in the coming era, we don't know whether we will be diagnosing by NGS, AI method or ctDNA method. So again, this is the algorithm we go for at this point of time, MSI testing, and we need to check if MSI-high, whether it is genetic or epigenetic changes are there which are leading to it. So if we look at the clinical practice guidelines for locally advanced rectal cancer as provided by ASCO, so we need to assess the MSI-MMR status, which is important. So not only we need to have a good high quality, high resolution pelvic MRI with dedicated rectal sequence, we also need to have a sequence and systematic reporting pattern. So immunotherapy for tumors that MSI-high is recommended. So this is one of the few places where the evidence quality is low, but strength of recommendation is quite high. So TNT approach is there if the patient has contraindications or is not affordable, or there are other reasons for not giving immunotherapy. So this is the NCCN guidelines, the latest version, which clearly says for locally advanced rectal cancers, if the patient is MSI-MMR deficient, definitely we can give up to 6 months of immune checkpoint inhibitors, whether we can give dostarlimab, nivolumab, pembrolizumab, and we need to evaluate them every 2 to 3 monthly. And if there is complete clinical response, the surveillance is one of the options, so which is very exciting, and that's what we want, whether we can preserve the organ. And other option being the total neoadjuvant. This is the same thing in the nutshell. We need to assess the patients who are MMR status, MSI status high. We have IO option, and we need to discuss, and other option being TNT. So this was the study which created a lot of interest in 2022. So this was the dostarlimab study, which was a prospective phase 2 single group study examining the efficacy and safety of neoadjuvant therapy with dostarlimab in patients who were MSI-high or MMR deficient in stage 2 and 3 rectal cancer. So in this study, patients were given dostarlimab every 3 weekly for 6 months, followed by chemotherapy, and total mesorectal excision was planned. However, the patients who achieved complete clinical response, they could forego chemoradiation and surgery. So 12 out of 12 patients in this study, they had achieved complete clinical response, and adverse events again were manageable. So clearly, this is very exciting. This is what Dr. Amit was referring to. We have a new era which is beginning, but we need to choose and identify these patients very carefully. Though we need to have better and longer follow-up of these studies. So coming to nivolumab post chemoradiation arm. So background of the study was basically sequential use of PD-1 antibody after radiation has demonstrated synergistic effects in vivo models, and we also know that it is effective in MSI-high patients who are metastatic colorectal cancer patients. So in this study, there were 2 cohorts. Both were MSS patients and MSI-high patients. Cohort A was MSS and cohort 2 was MSI-high patients. So 240 milligrams of 2 weekly nivolumab was given for 5 cycles, and the patients were assessed. So clearly here also in MSS cohort, there was PCR which was achieved with this study, whether it was the chemoradiation alone, what was the benefit of adding nivolumab, we do not know. But in MSI patient, clearly there was more benefit. And none of the patients have recurred in the MSI high cohort, whereas 2 patients have recurred in this cohort. So keynote 177, we all know immunotherapy works in patients who are metastatic and have MSI high status. So this study randomized patients between pembro versus chemotherapy plus minus targeted therapy. So clearly this study showed improved PFS in the first line, 8.2 versus 16.5 months. So OS, though not statistically significant, the trend was towards the use of the IO therapy. So if we talk about all the studies in locally advanced rectal cancers, whether they were MSI high or stable, we have Nivo, Pembro and Evolumab, which were used in combination with long course chemoradiation in Voltage A, NRG GI002 and Avana trials. They produced PCR rate between 23 and 32%. Clearly, the use of IO drugs in induction therapy has led to improved pathological CR rates. That is the crux of all these studies which have been done so far. So summary algorithm, we know if there is MSI high status, single agent immunotherapy is an option. So the newer treatment options that are being explored for rectal cancer. So this is the upcoming TORCH study, which is ongoing. It is a randomized prospective multicenter double-arm phase 2 study involving the toripalimab. Here 130 patients which are locally advanced rectal cancer, T3, T4, node positive and lower rectal cancers. They were treated with the TNT approach. They were assigned to either Arm A consolidation group or Arm B induction group. In consolidation group, 4 cycles of toripalimab, 6 cycles of toripalimab along with capox was given after short burst radiation. In Arm B, 2 cycles of induction were given with the same regime, followed by short course and followed by 4 cycles of toricapox. The primary endpoint of the study was complete clinical response. So the results that we have, there were 121 evaluable patients out of 130. There were 62 patients in group A and 59 in the induction group. So CR was achieved in 56.5% in group A and 54.2% in group B. So both groups reported a pathological CR rate of 50%, which was like huge. This is in MSS status. And still 15 patients in both the groups remain on the wait and watch policy. So the conclusion of this trial was the short course-based TNT approach combined with toripalimab achieved excellent CR rate and good tolerance in patients who were MSS status, which has achieved a great clinical value. So based on this, the future studies, the phase 3 studies are coming up in this summary. So summarizing, so we have these different medicines, the IO drugs, addition of which has definitely led to increase in the PCR rates. And even in the MSS patients, there are options which maybe in coming days, which will have better understanding. So summarizing, so management of locally advanced rectal cancer has undergone paradigm shift in last 2 decades. We need to tailor our treatment plans depending upon the the disease status and the molecular status of the patient. So non-operative management can be an option for selective patients with early stage disease or who have significant morbidities or those who wish to preserve their quality of life. So consolidation therapy following RT can improve patients' chances of achieving a complete response. So radiation is there. So MSI high locally advanced rectal cancer can benefit from single agent immunotherapy, and the role of this treatment in MSS tumors is showing promising results in that early clinical trials. With this, I'll stop here. Thank you very much.
Thank you, Dr. Sumit. Let's move on to the next talk. It will be given by Dr. Anup, who is an additional professor in the medical oncology at the RCC Trivandrum. He'll be talking on MRD testing in operable colon cancer.
Good evening. I'm Dr. Anu from RCC Trivandrum. So I'll be talking on minimal residual disease testing in operable colon cancer. Are we ready for it in clinical practice? So first of all, we'll discuss about what is ctDNA and MRD. So cell-free DNA, that is cfDNA, originates basically from different sources like apoptosis, necrosis, exosomes, etc. And in patient with the cancer, a fraction of cfDNA that originates from cancer cells is called circulating tumor DNA, that is ctDNA. So these ctDNA levels are always associated with clinical factors, pathological factors, including staging, tumor burden, localization, angiogenesis, and treatment responses. So when you talk about MRD, MRD is basically a state in which patients have not achieved complete remission even after receiving a radical treatment. And that means there is some residual disease after your treatment. So that is always a worrying factor for the patient as well as the treating physician. So how we detect this? So we have different techniques nowadays, like Sanger sequencing, biosequencing, NGS, PCR, beaming in tumor-informed assays, and serial monitoring of various genomic and epigenomic signatures. And the percentage of the allele fractions also varies in different techniques. And the sensitivity for this detection of ctDNA is also varies. But nowadays, there is a sensitivity has been increased in the recent years with each techniques. So liquid biopsies in colorectal cancer. So we have NGS-based platforms for molecular profiling of advanced or metastatic cancers, and they also can detect what is the acquired or resistant mechanisms behind the progression. And we have tumor-informed platforms, plasma-only platforms, colorectal cancer specific assays, as well as multi-tumor assays. So why we worry about MRD? So we have unmet clinical need for personalization and precision with adjuvant therapy for colon cancer. This is because 20% of patients with stage 2 and 35% of the stage 3 patients develops recurrence within 5 years, even after the use of what we call the optimal adjuvant chemotherapy. So we have existing literatures on roles of ctDNA in all stages of colorectal cancer. Most of these trial studies are basically focused on stage 1 to stage 3, but there are also studies which focus on stage 4. And all these studies, mainly the MRD is mainly used for the guiding postoperative management as well as for monitoring the recurrence in CRC. So compared with conventional imaging as well as the biomarker testing, MRD detection can predict tumor recurrence in advance, so make the patients more better treatment possibilities. So what are the updates and advances for MRD testing in colorectal cancer? So we have a study called BEST CRC study. So this is a study which evaluates the utility of tumor-informed personalized ctDNA assay informing the use of adjuvant chemotherapy in stage 2 colon or stage 3 colon cancer. So in this study there is MRD cohort as well as a surveillance cohort. And MRD cohort, the ctDNA was taken 2 to 12 weeks before the start of adjuvant chemotherapy. Then for surveillance, that is more than 2 weeks post adjuvant chemo or more than 12 weeks post surgery. So if you see the interim analysis results, the median DFS among patients who were MRD negative was not reached in compared to MRD positive. That was 15.98 months. And then if you see the 2-year DFS also, it was 91.59 versus 29.86, such a huge difference. So ctDNA positive is always associated with inferior DFS in stage 2 and stage 3. So benefit from adjuvant chemotherapy was surveillance are better in MRD positive than MRD negative patients. So ctDNA positivity at MRD time point was predictive of inferior DFS. ctDNA detection can lead to high number of individuals who might be a candidate for oligometastatic directed treatment. So when you see the patient reported outcomes also, 73% patients felt that the ctDNA results reduced the anxiety about the cancer recurrence. 87 patients felt that they were receiving proper treatment after receiving the results, and 92% would continue the medium to monitor their disease, and 96% valued the additional information provided. So this helped to mitigate the doubts and myths about patient perception regarding the ctDNA testing. And looking from dimensions of well-being from a patient standpoint, ctDNA was overall very positive. So we have another very good study, which is Circulate Japan Galaxy study, which is an ongoing study. So this is in this study, they examined the stage 2 to stage 4 radically resected CRC, where they used a tumor-informed assay detection for quantification of ctDNA. And samples were collected at months of 1, 3, 6, 9, 12, 18, and 24 months after the surgery until recurrence. And MRD window was 2 to 10 weeks post-surgery and prior to the initiation of the chemotherapy. And if you look at the 2-year DFS, it shows that ctDNA negative patients and those who were ctDNA positive patients, 2-year DFS was 85 versus 28%. The huge difference. So in patients with stage 2 or stage 3 disease, ctDNA positivity in a MRD window is again predictive of inferior DFS, and sustained clearance of DNA, ctDNA clearance was associated with superior DFS compared to transient clearance and or no clearance. So this provides evidence for the utility of ctDNA monitoring for post-resection recurrence and mortality risk stratification that could be used for getting the adjuvant treatment. There is another trial called dynamic rectal study. So this also used the utility of using ctDNA analysis to inform the use of adjuvant chemotherapy. So in this patient, those patients who underwent chemoradiation and surgery were randomized to ctDNA gated management versus standard management, and ctDNA gated management positive at ctDNA positive at week 4 or week 7 after the surgery prompted 4 months of oxalic based chemotherapy. Then ctDNA negative patients were put on no chemotherapy YPN 0, and YPN positive patients, it's clinician's decision. So primary endpoint was adjuvant chemotherapy use. So oxaliplatin based doublet was used in 28% and 25% of patients of ctDNA gated treatment compared to standard management. And if you see the 3-year recurrence free survival for ctDNA gated and standard management, it was 76 versus 82%. So this ctDNA gated approach resulted in reduced rate of CT administration, and the recurrence rate in treated ctDNA positive patients were low when compared to untreated historical control. And there is another program called Intercept program. It's a real world evidence from large prospective cohort. So patient underwent curative intensive surgery for stage 2 to stage 4 CRC at MD Anderson Cancer Center were assessed for post-op MRD assay. If you see the DFS among patients who are ctDNA negative, it was not reached when compared to 5.7 months in ctDNA, at least one ctDNA positive patient. And if you see the 1-year DFS, it was 86 versus 15.9. So patients with post-operative ctDNA were found to have inferior DFS when compared with no detectable ctDNA post-operation across all stages. So takeaway messages from these trials are: longitudinal ctDNA monitoring in CRC is useful for identifying patients at high risk for recurrence and mortality and who are likely to benefit from chemotherapy. So incorporation of ctDNA clearance assessment is into the clinical trial has the potential to streamline and assess in the efficient drug management. And research from ongoing RCTs evaluating the efficacy of novel therapeutic strategies in ctDNA positive patients will be crucial to fully harness the potential of ctDNA as a biomarker in the management of resected CRC. So what are the future directions? So what we lack is the understanding of the nuisance of what a positive or negative ctDNA test indicates. So we have to validate and research, improve the test validation. That's the way out. So what are the uses in future? One is inform novel drug development of targeted populations of patients with CRC. Then ctDNA clearance could be used as a molecular, same way as the molecular profiling to assign a targeted treatment into a given patient, or ctDNA presents as a new opportunity for pairing drugs with novel therapeutics. Then it may be incorporated into a clinical practice, not just as a prognostic tool, but as a predictive tool. Thank you.
Thank you, Dr. Anu.
Thank you. Any questions?
Then we'll go to the third talk. It will be given by Dr. Nagesh Sirsad. He's a consultant medical oncologist at Ruby Hall Clinic at Pune, and he will be talking on HER2/neu BRAF KRAS G12C as prognostic and predictive genetic biomarker in metastatic colorectal cancer.
So good evening everyone. So I am going to speak about HER2/neu BRAF KRAS G12C as prognostic and predictive biomarkers in metastatic colorectal cancer. Okay, so we are in the era of personalized medicine, precision medicine. Next slide. We know that increasingly biomarker expression is driving therapeutic decision making in oncology, including metastatic colorectal cancer. We have many small molecules, monoclonal antibodies, which have shown promising results in metastatic colorectal cancer. We know that colorectal cancer is a molecularly diverse entity. We have KRAS mutations, the common as well as the uncommon KRAS G12C mutations. We have BRAF mutations, MSI-high tumors, HER2 positive tumors, and the less common NTRK fusion positive tumors. All patients with metastatic colorectal cancer are subjected to now molecular testing for MMR deficiency, extended RAS, BRAF, HER2, NTRK fusion. We know the importance of this testing. We know that the benefit with anti-EGFR therapy is restricted for patients with extended RAS and BRAF wild type of tumors. For MSI-high tumors, now there is upfront role of immunotherapy either alone or in combination. We also know that for RAS, BRAF wild type and HER2 amplified tumors, we have various combination of HER2 targeted therapies, and for later lines, appropriate therapy against NTRK gene fusion and RAT fusion are available. So we see a little bit about HER2 amplification. It is seen in around 2 to 4% of metastatic colorectal cancer. It is enriched in patients with RAS and BRAF wild type of tumors. It is more likely in left-sided or distal CRC. It is associated with frequent incidence of lung metastasis and brain metastasis. The importance of HER2 amplification as a prognostic biomarker is still uncertain, but HER2 is a negative predictor for benefit from anti-EGFR therapy. So what are the options for HER2 positive colorectal cancer in patients who are progressed on initial line of therapy who are RAS wild type? So this is a Heracles A trial. Patients were given lapatinib plus trastuzumab. Patients who are progressed on more than 2 lines of therapy for metastatic colorectal cancer, RAS wild type. So here that lapatinib plus trastuzumab was associated with overall response rate of 30%, median PFS 21 weeks and median OS of 46 weeks. Other option, my pathway study, trastuzumab plus pertuzumab, again for metastatic colorectal cancer, progressed on 2 or more lines of therapy. Here both RAS wild type and RAS mutated and HER2 positive patients were included. The objective response rate overall it was 32%, for RAS wild type it was 40%. And for mutated it was less. Median PFS for RAS wild type 5.3 months and mutated 1.4 months. Another important study is Mountaineer study, the combination of tucatinib plus trastuzumab. Again, pre-treated patients, RAS wild type, HER2 positive, progressed on 2 or more lines of therapy, including anti-VEGF therapy. Patients were given tucatinib plus trastuzumab. There was a small cohort of 30 patients who were given single agent tucatinib, and they were allowed to cross over to combination upon disease progression. Primary endpoint was objective response rate. The response rate was 38% with tucatinib plus trastuzumab. With single agent tucatinib it was only 3.3%. Median PFS was 8 months and median overall survival was 24 months. The treatment was very well tolerated. There were no treatment related deaths. Discontinuation due to adverse event was seen in less than 10% of patients, and grade 3 or higher adverse events either tucatinib related or trastuzumab related were seen in less than 10% of patients. This trial is comparing, the Mountaineer 3 is comparing tucatinib trastuzumab with chemotherapy, and it will be compared with bevacizumab or cetuximab with chemotherapy in frontline setting in HER2 positive metastatic colorectal cancer. For later lines, for patients who have progressed on more than 2 lines of therapy, including trastuzumab therapy in HER2 positive cancers, we have the option of TDXD. The Destiny CRC 01 trial, here nearly 1/3 of patients had been treated with trastuzumab. Patients were given TDXD 6.4 mg per kg every 3 weeks, and the cohort A was HER2 positive and cohort B and C were HER2 low. The objective response rate was 45% with a median PFS of 6.9 months and median OS 15.5 months. The most of the responses were seen in HER2 positive, that is IHC 3+ or IHC 2+ with FISH positivity, and for HER2 low there were no responses. Now coming to the other mutation, BRAF mutation, we know that BRAF is a component of RAS, RAF, MEK, MAPK pathway. BRAF mutations which are mutually exclusive with KRAS mutations are seen in around 10% of the patients. 90% of these are BRAF V600E mutations. We know that they are associated with poor response to anti-EGFR therapy, associated with poor outcome in early stage colorectal cancer. Many of these patients are having MSI-high tumors. This is the Beacon trial. Patients with metastatic colorectal cancer who are having BRAF V600E mutations progress on 1 or 2 lines of prior therapy. Patients were given either a triplet of encorafenib, cetuximab plus MEK inhibitor or encorafenib plus cetuximab, and this was compared with the control arm of investigator choice of cetuximab with either irinotecan or FOLFIRI. The primary endpoint was OS and objective response rate comparing triplet versus control arm, and the secondary endpoints were OS and objective response rate comparing doublet versus investigator choice of control arm. So here triplet was definitely associated with better objective response rate as well as overall survival as compared to control arm, but again doublet was also associated with similar overall survival and associated with good response of around 20%, and it was less toxic as compared to triplet. There is a trial, breakwater trial, which is comparing encorafenib plus cetuximab with or without chemotherapy in first line setting in BRAF mutated metastatic colorectal cancer, and it will be compared with chemotherapy doublet or triplet in combination with bevacizumab. Moving on to the other less common mutation, KRAS G12C mutations. We know that majority of KRAS mutations are in exon 2, 3 or 4. The KRAS G12C mutations, uncommon 1 to 3% of the patients, they are associated with aggressive tumor behavior, poor response to anti-EGFR therapy. Now we have oral inhibitors, the sotorasib and adagrasib, which have shown response in pretreated patients. In refractory metastatic colorectal cancer, sotorasib showed objective response rate of 9.7% with disease control rate of 82%, adagrasib 22% objective response rate with disease control rate of 87%. The combination of adagrasib plus cetuximab showed objective response rate of 43%. And we have this code break trial where sotorasib plus panitumumab was compared with trifluridine, tipiracil or regorafenib. Here sotorasib was given in 2 doses. The objective response rate, if you see the median PFS benefit was seen with both the doses of sotorasib as compared to standard of care, and the grade 3 or higher adverse events are also less as compared to standard of care arm. So a biomarker driven treatment algorithm identifies metastatic colorectal cancer patients who may benefit the most. Companion diagnostic and predictive biomarkers are crucial to predict the response to targeted therapies. Thank you.
Thank you, Dr. Nagesh. Let's move on to the next talk. It will be given by Dr. Priya Tiwari, who is a senior consultant and head in medical oncology, Artemis Hospital, Gurugram. And she will be talking about current evidence of first-line treatment of left-sided KRAS wild-type metastatic CRC.
Hello everybody, I can already see people going in the Burmese mood, so I'll just finish it quick and fast. So a very important topic about the left-sided colorectal cancer metastatic disease. We already know that what are the guiding factors. You have molecular markers, patient comorbidities, whether you want to give the patient benefit of conversion therapies. And yes, now the sidedness is also very important. The thing is that now we are doing a molecular analysis, and if the patient has deficient MMR, MSI-high, you already heard very beautiful talks about it, then immunotherapy alone is one of the options based on the keynote 177. But in the left-sided colon cancer patients, this MSI positivity rate is lower compared to the right-sided. So most of the time we end up giving chemotherapy with some kind of targeted therapies. So let's discuss the chemotherapy first. The capecitabine of the 5-FU is the standard of care. The bonus 5-FU is going out of the usage because of the increased toxicity of neutropenia. S1 is also becoming increasingly used because it causes less cardiotoxicity and less hand-foot syndrome. Doublets are the standard of care, be it either Capox or Folfox or inoticane-based regimen. Inoticane-based regimen with capecitabine are less used because they cause a lot of diarrhea, but we do have a modified capide regimen with a lower dose of capecitabine, which is proved that as compared to the oxaliplatin-based regimen, even with this lower doses of capecitabine and capide regimen works equally good. And yes, in a subset of patients, you can also give intensified treatment in the form of Folfox-CD. But yes, what beyond chemotherapy? We don't talk about without any targeted therapy or immunotherapy. We will give some kind of benefit of these agents to our patients in colon cancer. We're just not limited to the chemotherapies now. So this is what the ESMO guidelines or the NCCN guidelines are on the similar lines. You do a molecular analysis, like I said, if you have an MSI, and now we also talk about the pole mutations in the first line. You give the patient the benefit of immunotherapy. Then otherwise you do and you also do KRAS and BRAF mutations and NRAS. And if you find that these are the mutations which are present, then we know that we cannot give them EGFR inhibitors. But if you have a KRAS wild type, NRAS wild type, and BRAF negative, then in the left-sided tumor, the EGFR inhibitor such as cetuximab or panitumumab becomes the combination therapy to go forward in combination with chemotherapies. So like I said, that something which is very important now is the pole mutations. Again, what the pole mutations are rare. But yes, we know that as compared to MSI, even the response rate to immunotherapy are actually higher. And they are treated on the line of MSI positive tumors itself, that the response rates to immunotherapy is up to the tune of 89%, to contrast to the MSI positive tumors. If you have an MSI positive tumor, again, you can give immunotherapy, isn't it? But there again, you can see a response rate of 56%. Pole mutation positive patients are the one which respond most beautifully to the immunotherapies. So yes, now the data, especially the NCCN guidelines, have started taking these mutations in the first line treatment on the testing. The limited panel that you do, the NGS panel, that actually is not covering the pole mutation now, so you should additionally request for these mutation testing. So yes, the common question about the anti-GFR versus the anti-VEGF, and we know that the data started from the Crystal trial, and now you have the data from the FIRE-3, which actually showed that the cetuximab plus FOLFIRI improved overall survival. And how much was the difference? That the overall survival was better in the FOLFIRI cetuximab, 31.1 versus 25.6 in the bevacizumab arm, with estimated 3-year and 5-year survival rates of 43 versus 33 and 18.8 versus 9% respectively. And most of the data was driven by the left-sided tumors. As you can see, the part of the graph above, that the median overall survival in the left-sided tumor was 38.2 versus 28.6. And this is the reason that you use compared to the bevacizumab, you tend to prefer EGFR inhibitors in the left-sided tumors and not in the right-sided tumors. What was also important is that addition of cetuximab to the chemotherapy showed much better responses. Okay. In whole population, left-sided and also in the right-sided tumors, the response rates were actually higher in all these three groups in the cetuximab group compared to the bevacizumab arm. So even for the right-sided tumors, if you see the guidelines, they say that if you want deeper responses, then maybe you can use these agents even in the first line. Swab 80405 trial again did not show much of the difference between the EGFR versus VEGF, but then they did another analysis seeing the sidedness, and they did find that again the left-sided tumors were better with the cetuximab-based treatment options. Paradigm on the similar lines using the panitumumab in the first line FOLFOX regimen. It did show better median overall survival in overall population and also in the left-sided population. But here I want to present a very important analysis, a pre-specified exploratory biomarker analysis of paradigm. Now we know that there are certain resistant pathways to the EGFR inhibitors, isn't it? The KRAS and the NRAS are the much talked about, but there are certain other genetic markers which actually tell you that the drug is not going to work. So they devised a panel, a broad panel, and they tested for these. And based on this, they divided the patients in the two patient populations. So they had a broad panel of gene alteration associated with resistance to EGFR inhibitors such as KRAS, NRAS, PTEN, extracellular domain, EGFR mutations, HER2 and MET amplification. Patient with no mutations were labeled as negative hyperselection, patient with mutations, gene alteration. Now here what you see is that this I'm talking about the left-sided tumor. So we understand the left-sided tumors, patients with EGFR inhibitors, we tend to prefer over bevacizumab. Now in left-sided tumor, what they found that the patient who had no mutation did better. So already what we see in the left-sided tumors. But patient who actually had one of these genetic alterations, so those labeled as genetic alteration, that group of patients, they did not do well. So even in the left-sided tumor population, there is a group of the patient which is not going to do better compared to the bevacizumab on panitumumab, and this is what the molecular analysis will actually help you to find out. Also, on the similar lines, if you see the overall population, we realize that this is true for the overall population. Any overall population, irrespective of sidedness, if they don't have these mutations, then of course you can also give them panitumumab compared to the bevacizumab, as you can see by the separation of the graphs here. So overall, what we understand that maybe this is how the way the world is going to move forward. We always want to understand why the sidedness is actually, what is the biological explanation for the sidedness, but maybe it's the genetic alterations which are actually playing a role. So that is why it's very important that down the line we will all do the genetic mutations and the alteration in our patients to decide what is the course of action and the best possible treatment for these group patients. There is always a subset of patients where we will actually want to give an intensified therapy. So what is the data of intensified therapies with various targeted therapies? Now the data is more supportive and convincing for the bevacizumab. You have a TRIBE trial, you have a NATALEE also, and you have a TRIBE 2 trial also. Now TRIBE 2 is a very beautiful study. Why do I say so? Because they have given FOLFOXIRI with bevacizumab followed by maintenance, and if there is a progression, they again give FOLFOXIRI with bevacizumab compared to the standard arm of FOLFOX plus BLEB followed by FOLFIRI plus BLEB. And they have found that yes, this combination works nicely in terms of PFS2, which was the primary endpoint, as well as the overall survival. So across all the guidelines, if the patient was a preserved and a good performance status, this is one of the treatment options, and bevacizumab is the target therapy which can be used. Now what about anti-EGFR drugs? Can you also use them in combination with the intensified chemotherapy? Now this was a very small phase 2 comparison where the FOLFOXIRI was used as a chemotherapy backbone, and panitumumab with or without panitumumab, and they did show that the overall response rates was better with the addition of panitumumab. However, a larger trial, which was triplet study, it looked at the intensification differently. It has a doublet versus triplet chemotherapy with panitumumab in both the arms. It did not find that intensification of chemotherapy when in using combination with panitumumab actually leads to better response rates or survival rates. So based on this, the guidelines don't recommend using anti-EGFR agents with an intensified chemotherapy. So overall, what we understand from here is that the treatment is decided by the molecular analysis, patient comorbidities, and the patient choices. Anti-EGFR therapy with the doublet chemotherapy is considered the treatment of choice for patients with left-sided RAS and BRAF wild type and MSS metastatic colorectal cancers. But importantly, you have to take into account the newly emerging molecular markers. Also, the role of ctDNA needs a better definition so that we can actually decide which group of patients are going to benefit maximally from which kinds of therapy. Thank you.
Thank you, Dr. Priya. So the next talk is going to be by Dr. Amit Bhatt, who is the Director and Consultant Medical Oncologist at Avinash Cancer Clinic at Pune, and we'll be talking on management of locally advanced esophageal and esophageal gastric junction cancers.
Thank you so much, Chairpersons. What a lovely day it has been. Impactfully designed program and then lovely discussions throughout the day. But it's already 6:30 and I guess we have stretched our attention span quite so much. So we'll try to finish before the buzzer. We're going to talk about management of locally advanced esophagus and G-junction adeno-CS. Quick 4 points and then we'll wrap it up. Basics, what is the basic demography, prevalent practice, what we are doing today. What is the best that is available today and what the future holds. So that is what we are going to look at today. So basics, it is high time that we started going away in our medical conferences away from breast and lung and giving more the time to esophagus rather than just a single lecture, because over the last 10 years you can see in males it is now the 3rd commonest cancer. It's no longer down the line 8th or 9th, and overall it's the 5th commonest cancer. So esophagus is coming up in a big way. A lot of obvious reasons, and it's time that we discussed it in more detail because we're seeing a lot of more patients. What is the prevalent practice? Neoadjuvant therapy, all would agree, neoadjuvant therapy followed by radical surgery is the the way to go. In the West, more than 70% of them are diagnosed in advanced stages, and the preoperative chemo is the dictum to go. In our practice, in my center, we see it as only 30 to 40%. It's not that high. Most of the times we have metastatics. But all those who don't have a pathological complete response after the neoadjuvant protocols, these are tend to fail. So we're going to look at even this as well. So NCCN guidelines, the latest version, we are going to look at T2N0, the high-risk lesions, or the T1 or T3, T4A node positive disease. And we know that chemoradiation or chemotherapy is the way to go. Let us just discuss that in a brief. These are all the regimens. I won't go into the detail for the lack of time. In the last 5 minutes, I'll just talk about 2 or 3 main trials. 2012, the cross protocol preoperative chemoradiotherapy. This came up in a big way, and this all changed. This was practice changing. We all changed our practice to go on to cross protocol. And in 2015, they came up with the long-term results of the cross protocol. And after a median follow-up of 84.1 months, those who got chemoradiotherapy was the overall survival was 43.2 months as compared to the 27.1 months who went upfront surgery, thus establishing chemoradiotherapy as the standard of care in all locally advanced adenocarcinomas of esophagus and the G junction. And that practice remained for quite some time. A lot of clinical trials were designed till the FLOT came and they disturbed everything. Again, FLOT, where a combination of chemotherapy with docetaxel, oxaliplatin, and 5-FU. And I won't go into the trial in detail. The survival of FLOT was 50 versus 35 months. This is chemo versus chemo, and the previous trial of cross protocol was chemoradiotherapy. But it was again compelling to understand that this was improving the overall survival, and is this better than the previous cross protocol? The only issue with that, and I am sure most of the medical oncologists who are using the FLOT protocol will agree, that 1 out of 4 patients are going to land up in the hospital again with toxicity. So when you are using FLOT versus cross, it's very important for us to understand that you choose your patient rightly. If it's an elderly, frail patient and you are doing FLOT, you might probably do harm than benefit that patient. These are other trials, a similar play of drugs, Folfox, oxaliplatin, and the cross protocol. I won't go into the detail. So what is best? These are the 2 protocols which I'm all across India, these two, most of the centers practice. And then there was a head-to-head trial. It's very few times in oncology where we have a question and it gets so easily answered. Otherwise, it never happens as in other diseases. The ESOPEC trial, it was a head-to-head comparison between a phase 3 trial, FLOT and cross protocol. I won't again go into the details. The cross arm versus the FLOT arm, they completely rested the debate of what is better. For the cross arm, the median overall survival was 37 months. For the FLOT arm, it was 66 months. 3-year overall survival was 50 versus 57, and pathological complete response was 13.5 versus 19.3. So this proved that FLOT improved survival in resectable EACs as compared to neoadjuvant cross, and this gave us the clear-cut dictum that FLOT is the way to go. So as far as possible in clinical practice, if you have a patient who's fit enough to undergo the FLOT regime, that is what you choose. The issue was with 50% in clinical practice, those patients are very frail, weight 40-45 kg, and probably very difficult, poor nutritional tastes, very difficult to tolerate that FLOT protocol, and we still end up giving cross, which is a little much more tolerable. But if you seen, like you said, the seen in cross, almost 20% of patients have complete response, and 80 to 84% people still have residual disease at the end of chemo and radiotherapy, and that is where recurrences come. What can be done for that? And there were, like in all other diseases, starting from lung, immunotherapy always gives us the answers. So looking at the last trial, last 1.5 minutes to go, Checkmate 577. This was again a trial where nivolumab was given 240 mg every 2 weekly for 16 weeks, followed by 480 mg every 4 weeks. This was given to patients who had finished the chemoradiotherapy and there was some kind of residual disease. 794 patients were there. And if you look at the improvement, there was significant improvement in median disease-free survival, 22.4 versus 11 months with a hazard of 0.69. So this was a pretty impressive trial, and this again dictated the protocol for adjuvant nivolumab in those patients who have some kind of residual disease. Going further, this trial predominantly had squamous cell types, but when you divide into subgroup analysis, you can see the adeno CAs who got nivolumab who didn't have pathological CR also did pretty well. So what the future holds, we have enough of answers as of now. How do we improve the survival? Most of the trials are now looking at combining the two giants, the FLOT and the CROSS. The question remains that are we going to get good survivals at what cost? The toxicity might be always a big risk. And so coming on to the last key points, neoadjuvant therapy is the rule. That is, if you have a locally advanced, the patient has to undergo some kind of therapy. Surgery upfront is not advisable. FLOT or CROSS, you need to diversify according to a patient oncologist, what is the prevalent practice at your center and how good your backup is. And immunotherapy gives us answers in almost every disease. Immunotherapy is what it does the best. Adjuvant nivolumab and all PCRs is important. Thank you so much.
Thank you, Dr. Amit. That's bring the end to the lectures today. So for the final session, we'll be having a panel discussion, which will be moderated by Dr. M. Vamshi Krishna, who is the Director and HOD of Medical Oncology at the AEG Hospital, Hyderabad. I request Dr. Vamshi to introduce his panelists also.
Good evening. The few of you who are still here, let's do this quickly. It's 6:40. The sun has set. It is Goa. So I think we need to go. I'll call my panelists, Dr. Shashanka Shekhar. Mr. Shashanka, I can see. Dr. Parikshit. Dr. Parikshit is here. There he is. Okay. Dr. Neeraj. Dr. Neeraj Jain. Okay, right. And Dr. Mansi. Mansi is there. And Dr. Suresh Kumar. Dr. Suresh Kumar is here. B. Suresh Kumar, no? Okay. And Dr. Harish. Dr. Harish Peshwe. Okay, so we have 4 people. So that kind of reduces our time because we'll have less questions to ask. I guess that's how it goes. This is what I think when I come to Goa. It is Susegad Goa. We need to be relaxed. So I think that's the number one thing. Let's relax. We'll just have a small discussion. Now, I know there have been 4 sessions before us. I don't see the point of going into too much detail in everything. We'll just talk about mostly the MRD testing in CRC and is the genie now out of the bottle. So we'll start with the panel. And again, I think anyone who's not done this or not experienced this, that's fine. Nothing to worry or nothing to feel, why are you not doing? Because again, there are issues in this testing. So Dr. Shashank, do you use ctDNA in monitoring for CA colon either relapse or for deciding therapy?
No, sir.
No. Okay, perfect. Dr. Parikshit?
No, sir.
No. Dr. Neeraj? Dr. No. Okay. So I think I can stop the discussion. Nobody wants to use the test. Excellent. Amit is using. Amit is the big doctor from Bangalore, so I'm sure he'll be using this very frequently. The more important question really, even though we are not using, so Dr. Mansi, we have Garden 360, nothing of that is ready, so I think I'm allowed to use such words here. We have Garden, we have Signatera, we have some Indian labs, all of which are available in India. Do you think all of them are equal, or do you think specifically we should use for which we have some trial data?
So there are tumor informed assays and tumor agnostic assays. So most of the trials have used tumor informed assays.
Garden is tumor agnostic.
Garden is
tumor agnostic.
Yes,
Yeah,
but I think the dynamic study has used the tumor informed assays. So I have limited experience with this.
So I will ask you why I'm saying this. Again, for those of us who don't go abroad and listen to too much foreign speakers and stuff like that, we rely on somebody coming to the lab or to our OPD and telling us we have started this test. And there are 10 Indian companies who will come and say we are doing ctDNA or we are doing CTC. So Dr. Neeraj, how do you decide that, yes, this is a good test or a bad test?
So I have no experience with this test.
So that's why I said, sir, to next 6 months, you're going to get 10 people coming and telling you we are in Indian lab, state of the art, blah, 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 wonderful facilities, and we do fantastic ctDNA. How do you decide on that? Or do you say that all are equal, or how do you decide that?
No idea.
No idea. Okay. Dr. Parikshit, what would you do? Because this is going to happen and this is happening already.
So I would like to ask them what are the platforms they're using, have they used it on Indian,
Indian patients, okay?
Like Indian patients and
So
what's
neither Guardant nor Signatera has published any data from India, except I think from Dr. Ankur Behle has used for this year ESMO, but they did only the metastatic disease. I don't think they did too much of this.
So as of now, the majority of the data is from the Signatera, but I'm not sure that, that it's being used.
Dr. Shashank, your take on this?
Indian patients.
So the Indian company will say we are doing ctDNA and you can use it for doing, and we are doing it at 1/4 the cost of what Guardant or Signatera is. Would you like to do the test?
Yes, sir. So most of the what I know of the ctDNA from this Guardant 360, and based on Guardant Reveal. Yes. So based on that, I haven't came across the Indian data till now.
There's no data as such. It's just a data.
Yes. So Guardant 360, Guardant Reveal seem to be promising, but though it is not.
Fine. So again, the reason why I'm bringing this question is because Guardant uses this epigenomics. What they claim is that they are not doing a tumor-informed assay, as Dr. Mansi said. Essentially, tumor-informed means you use the tissue, find out the genomic signature of that particular patient's cancer, and then look for that genomic signature to identify a relapse. Whereas in Guardant, they do a tumor agnostic, in which they don't look for that tumor signature, they look for epigenomics, which apparently improves the outcome. Even I'm not sure how they do it, but this is the claim to fame. Indian labs are not using this. That is the reason why I asked whether you should rely on it or not. Okay, right. So let's just do a case. 68-year-old male, CKD, creatinine is 1.76, well maintained, not a problem as such. He had anemia, so he was evaluated. Sigmoid growth, non-metastatic, LAR, and this is the pathology report. 13 lymph nodes removed, no LVSCI, no obstruction, no perforation, and grade 2. So moderately differentiated, grade 2. Okay, this is the report. PT3N0 MSI stable. So what are your options? And I have given you some. You do a ctDNA and decide the therapy based on the report. You do a ctDNA, do not give any therapy. You only simply prognosticate. Or you do ctDNA but treat irrespective. Or you don't do any ctDNA, observe or treat. So 5 options. Mansi, we'll start with you. PT3N0, 68-year-old male, CKD. Which clinical risk would you put this patient into first?
So this will be like I'll ask for other high risk features like
I told you, no LVSI, no obstruction, no perforation.
So according to current guidelines, it will just come for observation.
Observation. So would you then do one of these tests to decide anything further?
So because we are discussing the topic, yeah, I would, and then I would decide on that because it has shown a benefit, and I think we're already using it in the Western countries.
Okay, so we are as good as any Western country in some aspects. So if a patient comes who is able to do it, who says, okay, if you tell me I will stay in India, otherwise I can go to New York. We do get some occasional patients like that. So then would you advise the test or not?
Yeah, I would advise the test, and if it comes positive, there is good data that we can suggest for adjuvant chemotherapy.
Okay, fair. Dr. Neeraj? You tell them to go to New York. Easiest thing to do.
Theoretically, ctDNA is done. And if it is positive, then systemic therapy.
Okay. Okay. So, Dr. Parekh, is there any data to really say that if you have ctDNA, then treat in a T3N0? Is there some data exist? Shashank?
I don't think.
You don't think so. Shashank, any?
No, sir.
Okay. Can I have a show of the few? Yeah, I can see 4 or 5 people at least here. So, how many would do, say, a ctDNA and then treat based on the report? Any hands? 1, 2. Okay, excellent. So, we have quite a few people over here who want to use it. Agreed. Very good. So I think the data has come from basically the dynamic study, which is the circulating tumor DNA analysis. This is in stage 2 colon cancer, specifically stage 2. Now, interestingly, this included 86% in T3, 14% of T4. Clinical high risk group was actually 41% only. 59% are clinically low risk group. Now, what did was clinical risk group? This is what it is, what I just told you. T4 with extension, poor differentiation, lymph node yield less than 12, lymphovascular emboli, tumor perforation, bowel obstruction. If you fitted any of these, you would be clinical high risk. If you did not fit into any of this, you were low risk. Right? This is the definition used, and our patient goes into actually a clinical low risk group. 59% were there in this. Look at the data, what the results showed. What they looked at is how many people actually needed chemotherapy. And in the ctDNA guided group, around
only 15% got chemotherapy, whereas in the standard management, 28% got chemo, which means 72% did not get chemo based on clinical features. 59% were low risk, 41 were high risk, but only 28% got adjuvant chemotherapy. So again, it's interesting that a lot of people are not being given chemo any which ways. Of them, single agent 5FU was given for people, that is capsaicin alone. Capox only in 4 patients. So whereas if the ctDNA was positive, more patients got capox. I think it's a very biased study in that way, that a lot of physicians have now this inbuilt feeling that, okay, if it is positive, it's a bad disease, we are understanding. So you try to give more chemotherapy to prevent it. And this is the curves in which if you do ctDNA guided management versus standard, no difference. So you can do a CT guided management and reduce the amount of chemotherapy given. In patients who have negative ctDNA, they do much better, that is well known. And then you have in the patient, I'm not shown that curve, but in the positive ctDNA, those who got adjuvant chemotherapy did better than those who did not. That's the data what was presented here. So my take home from this is, in a stage 2, if there's any reason you want to avoid chemotherapy and the ctDNA is negative, you are well within your rights to avoid chemotherapy. So that would be my take on this, and that's where we are using it. So in this patient, he got operated 15 days back, so we have asked for a ctDNA after 10 days. And I told him that, look, if negative, I'm very happy to avoid chemotherapy. In a CKD patient with all these, we can avoid. Clinical low risk, can you not do ctDNA? That's a good option enough, because as I showed you, even in the standard management group, many people did not get chemo. So that still remains an option, but if it is T4, it's a good option for doing. This was the bespoke study wherein they actually looked at personalized ctDNA for stage 2 or 3. Again, when you look at this, a lot of these people have used mixed results. And what this study showed, MRD negative did very poorly, MRD negative did very well, positive did better. And that's what I think the previous speaker also showed. So that's this one. And this was the patient. So case 2. This is again all real cases, by the way, all patients whom we have treated in the last 6 to 8 months.
Just one question.
Yeah.
Yeah. So my only thing is, assume that you have now a tumor-informed versus agnostic.
Yeah.
So I think, which would you prefer? Because now we don't have the option. So in this case, or the first case,
you have the option because you have the.
So which would you prefer?
Okay. So the Signatera, we had that problem initially that you needed to use fresh tissue, but now they are doing it on blocks.
So you would rather prefer both tumor informed.
I am okay to both. To be very honest, based on the data, whatever is available from Signatera and from the Guardant, both seem to be equally effective.
But it makes sense to go for the tumor informed because because agnostics, you have the set pair of mutations which they look at, and if there's something very specific to the patient, you would not pick it up.
So that is the whole point why epigenomics has come into the picture. Epigenomics picks up that extra 10%. It picks up the genetic, result of the genetic change, which can be picked up in methylation or hypermethylation. So that's the logic of it.
So is it that tumor informed is superior to the tumor?
It's not superior. There is no head-to-head comparison. But when you look at the results across trials, they are similar. So that's how I take it.
So I think what's brought up is the classical dilemma we face in practice, because both are available to us and that whole debate starts off. I would say we have more data with tumor informed in terms of trials, a little more leaning towards. The problem with the tumor uninformed was the COBRA trial came negative, and that was but a premature version. Pegasus is okay. So in general, if we have tissue, we are doing more tumor informed, but if we don't have tissue, we are doing the other way. So
given the option, tumor informed.
I would say there's leaning towards it more. I would put it that way.
Specific.
So, okay, now second case, an 82-year-old gentleman, diabetes, hypertension, he's a diabetes, CAD on meds, but cardiac function is okay, COPD control with meds. He was found a fecal mass, non-metastatic, right hemicolectomy done, and this is the report. Now, 1 out of 23 lymph nodes positive, T3, no other risk features, grade 2, no other risk features, excepting that single node. So, this is T3N1. You can see the genetic testing done and the MSI stable. So Mansi, back to you. T3N1, 82-year-old chemotherapy. Again, the options I'm showing you, the same options. Give chemo or not give chemo, or do ctDNA and decide?
Yeah, again, go for ctDNA and then decide, because he's 82-year-old and again, there is enough data to...
So, okay, assuming in this from the panel, how many of you, if the patient did not have a ctDNA option available, how many would give chemo for an 82-year-old like this? Those who don't have chemotherapy, who don't do a ctDNA, at show of hands, how many would give chemotherapy? Show of hands.
Oral chemotherapy single agent.
So you would give oral. Anyone else?
So oral chemotherapy with single agent capecitabine.
Okay, everyone is giving chemotherapy.
Single agent oral.
Okay, great. So in this situation, would you do a ctDNA? Since Dr. Parikshit, you said that you want to give single agent. Would you do a ctDNA and if negative, avoid chemo?
Yes, sir.
You would avoid. Okay, Shashanka, you would avoid? Dr. Neeraj?
Yes, if the ctDNA is negative, then...
Okay, so perfect. So I think I have done my job. Yes, you were about to say something, Dr. Parikshit.
So if the patient is affordable and if we have the option of doing the testing, obviously we would get it done.
Fair enough.
That can then decide based on the
This patient was a businessman from Dubai and he obviously had the option of doing it. He did the ctDNA after 4 weeks. It came negative and we have kept the patient on observation. And the second ctDNA done after 4 months has also come negative. So he's continuing to be on observation. So this is one place I just wanted to bring this thing. This is the circulate arm of this Galaxy study in which they actually looked at 5,700 patients. And they found that in the patients who were post-op negative, so they included only stage 3 and high-risk stage 2. So this is the precise population I am telling you. Stage 2 high-risk and stage 3, no difference in those who were MRD negative. There was no difference if you added chemotherapy to them. Those who had ctDNA positive in high-risk stage 2, stage 3, some stage 4 also, not all of them benefited from adjuvant chemotherapy regardless of the stage. This is the Pegasus study, again looking at the same group. Post-surgical liquid biopsy directed therapy, wherein if you had a liquid biopsy positive, you would actually get CAPOX for 3 months. Repeat liquid biopsy, consolidate with either CAPE or with FOLFIRI. If negative, again repeat a biopsy and continue observation or go with some chemotherapy. This was the way it was done. And they found that 26% patients had ctDNA positive. Low risk detection was still 23%. As the risk state increased, your positivity increased. And what they found was the MRD rate is similar, and at a follow-up, those who have negative do very well. That's the idea. Seroconversion occurs in 40% of patients. So again, final question, how about rectal CA?
Once in the MRD negative, can you go back to first slide of this trial? The first one.
Which one?
No.
Yeah.
Next. Pegasus.
Yes, Pegasus. Okay.
Yeah, this one.
Yeah.
No, go back.
This is the one you're asking.
The initial slide of Pegasus. Yeah. So if it is ctDNA negative, also they give capecitabine.
Because it's the single agent they have given.
Yeah, so the point is that if you have a clinical factor which is there,
correct.
So we do not have a very clear-cut thing of not giving. And if you are looking at a stage 2 where you would not give, you would give if the ctDNA is positive. Is this not how we look at?
So the circulate trial has told you can avoid it. The Pegasus did not look at
circulate is a much smaller.
No, it's a larger trial, 5,700.
But look at
Pegasus was less number of patients. Pegasus had, I think, 140 patients. But I take your point that Pegasus is one which is looking at a more de-escalation, escalation type of study. Yes, Amit.
I think stage 2 we are absolutely confident because dynamic is there. Stage 3
still some hesitancy.
For de-escalation there is a hesitancy. Escalation we are confident.
I'm okay.
Okay. De-escalation we are scared. Vamsi, to question to you for stage 2, if you look at dynamic and you say you yourself said it, mentally we think they are positive, so we'll treat them, over-treat them, or you'll give a CAPOX. So I look at it, if I tell you the other way, it's easy giving capecitabine. Why do the test and just give capecitabine to everyone in stage 2 if you want to get away without it?
I don't think capecitabine is so simple, number one. Number two, 6 months of capecitabine. There is no data for 3 months of capecitabine. The idea looked at CAPOX and FOLFOX. It never looked at CAPE. 6 months of CAPE, HFS and all are a toxicity. They are a concern. If I can do a test, even that 2% risk of any cardiac event or encephalopathy, you get one of those cases and it will haunt you for at least 1 year. So that is the way I look at it. And it's a more scientific way of telling a patient that look, we are doing a test and we are looking. Again, all this is a theoretical discussion if only patient can afford it. That's again a point to be taken.
I only think we are over-treating with oxaliplatin a little more.
Possible. Okay, we are out of time, so I won't do much. I won't discuss these other dynamic rectal and all these studies. The third case, I'll not ask anybody because we are out of time. This was a patient who is a 54-year-old gentleman found to have a CS sigmoid with 4 lesions in the liver. Bilobar, largest 1.5 centimeter, MSI stable, all RAS wild type, FOLFIRINOX 4, significant resolution, and the liver mets became non-FDG. He underwent a surgery, hemicolectomy, liver met resection. Now this patient had YPT3N0, all the liver mets were removed. He was planned for 8 more cycles of FOLFIRINOX. Is there a role for doing ctDNA here? And again, here I am a little hesitant to do it. I don't think there's a real strong data. For whatever reason, he was advised, and 4 weeks post surgery, he did it and he got negative. We continued, he was planned for FOLFIRINOX, we could not give it because on table he had blue liver. So we then removed oxali and gave only FOLFIRI. So that is what we did. And this patient has finished and he is now coming for a PET scan after 1 week, and then he will do a ctDNA after 3 months, and he will do a PET scan again after 3 more months. There's a weird kind of concoction that we have decided because we don't know what else to do. Because patient is ready to do both and more if I ask him to do. So that is where we are stuck. Right, last case, I'm calling this a client. I mean, if anyone in the real corporate hospital realize, patients are people who are fit and who walk in to improve their life and to increase their life expectancy are called clients by their so-called wellness people and metabolic people. So, we had a metabolics and anti-aging expert who constantly referred to people as clients. So I decided to copy that. So there's a client number 4 who is a 51-year-old gentleman, CTO of a company. So obviously very tech educated, no family history of cancer, non-smoker, no complaints, nice BMI. He wanted routine screening for malignancies, apprehensive for colonoscopy. Though he will go back if the doctor insists under sedation, he can do it. Would anyone recommend a ctDNA screening for this patient? Amit is laughing. So, okay, since you are laughing, I'll ask the panel. Would anyone agree for a ctDNA based testing, or you will say, okay, we don't know, do whatever you want? Well, ultimately, I think at some point we have to say that. It becomes easier for us. Anyone for ctDNA testing for this?
Sir, recently Guardant has came out with a test Eclipse of screening for colon cancer. And
Guardant Shield it's called.
Yes.
So you would agree with that or not?
Sir,
right. So this is the Eclipse study, and very interesting study. When you read at the headline in this study or the conclusion, it says it has a 83% sensitivity and 89% specificity, which as screening tests go is very good. But this is what they found. Out of 7,861 patients, 65 had colorectal cancer, 1,116 had advanced precancerous lesions, which they defined as 1 centimeter sessile lesion or some other 1 or 2 criteria. 4,514 had a negative test in colon. This is on colonoscopy. Now, in this, they could detect 11 out of 17 stage 1 cancers, 14 out of 14 stage 2 cancers, and 17 out of 17 stage 3 cancers. Okay, and very interestingly, Doctor, I'll just finish this and then we'll take your question. Very interestingly, when you look at advanced precancerous lesions, patients, the positive ctDNA report was seen only in 13% of patients. So advanced precancerous, where you can actually detect before a cancer has developed, was seen only in 13% of patients. So the conclusion says all this, but remember 13% for advanced precancerous, you're only detecting cancer early, which a colonoscopy would anyways do. Right, Dr. Sahu.
You go back.
Yeah.
1 slide back.
Yeah.
Just take out. No, take that out. Yes, that's it. No, put that out.
Yeah.
Yeah. So I think I'm not convinced this does not serve the purpose and should not be scientifically not justified to do this test.
I agree with you.
Amol has come in at the right time.
Yes.
The stage 1 sensitivity of 65% is not just good enough. I don't want to catch stage 3 cancers. If you're doing a screening test, it has to be precancerous or a stage 1 at the least. And that's not happening. And more so, 17% are missing cancers. And what do I do about the false positives? So there are a lot of issues. It has been approved. People will do it, but I don't know how they are going to manage it.
I completely agree with you. Again, I think the issue comes of pretest possibility. So if you have anyone who has slightly higher chances or risks, do not do a liquid DNA alone. Do a colonoscopy, convince them to undergo a colonoscopy. You know, you can send them, my hospital does 150, 200 colonoscopies a day, we can manage one more. But the point is you have to do colonoscopies for those who are at high risk or who are at any kind of elderly risk. That's my take on it. So how do I treat? You can treat as per FDA, you can treat as per guidelines. Sometimes you can use a little bit of common sense. I think that's what all oncologists should learn. What I will do in a T1, T2, N0, answer is no. At this point, no role of ctDNA for me. T1, T2, N1 or T3, T4 with a N0, I would probably do a test. It helps. It does prognosticate and you can avoid chemotherapy for people. That's how I took it. T3, T4, N1 or N2 or T4. I am not convinced we can completely avoid chemo. I would probably not do it. I would just give chemotherapy. These are high risk patients. I would give chemotherapy. A metastatic at this point, no. Oligometastatic at this point, probably no. So this is the way I would treat, and again, I think that's...
one more question of common sense.
Yeah.
So if it is the T2 N0, comes to your hospital on 6 weeks or ctDNA positive?
I have to treat. But I will not do the test. Let me put it that way. See, at 6 weeks, if anyone is ctDNA positive, it's the one patient who will never do well. I would probably go back and look at the pathology or the surgery.
But then, how long will you treat?
Which will it be? Standard adjuvant. So again, okay, I'll put it this way. I'll go out on a limb here. What I will do is I will start chemotherapy and look for clearance of the ctDNA. I will repeat the test.
So why not wait, because it is done at the end of 6 weeks, why not wait another 4 to 6 weeks and see whether there is a spontaneous clearance of the ctDNA?
So again, in a T1...
For a T1, T2, N0.
So I'm coming to that. So T1, T2, to have a positive ctDNA is a bad thing. So my suggestion to anybody who wants to do it at 4 weeks. Don't wait till 6 weeks or 8 weeks to do it. And then point well taken, especially if the lab is an Indian lab which is not fully accurate, I will not rely on it.
That is my next question.
I will not rely on it.
According to you, currently, for everybody sitting and practicing here, which lab is the most reliable lab?
I rely on Signatera and Guardant. I don't rely on any other lab.
So Signatera and Guardant only?
Only.
You are missing in the first one.
I'm doing only those. So I am not doing on any Indian lab. I do not believe the CTC. We had a patient who came with this report midway through his treatment. He came with this report saying 1 CTC positive. I said, I don't look at CTC, we look at ctDNA.
So only Signatera Guardant, that's it, nothing else?
As of now, yes. I don't rely on the Indian because they have not presented any positivity. Right? So this is all. I'm not doing anything more. It's 7 o'clock. It's time to close the thing. So I think too many slides here which I'm not touching upon. Okay, so thank you everyone. And that's it. I'm just looking at my last slide.
Only your conflict of interest.
Conflict of interest I have not put. Sorry, Dr. Amol. I know you ask me that every time, but I have not put it. I don't put it. Acha, why Signatera? Okay. Okay, why Signatera and okay. Okay, this was what I want to show. We are having an annual summit next week. So if anyone is still interested or wants to send their students, please feel free to do that. That's my conflict of interest. Okay, I'm using it to plug my summit. Okay, thank you. Thank you, everyone.
Thank you so much, everyone. And there's an announcement to make. The gala dinner is at 7:30 p.m. on the ground floor in the garden. And tomorrow we have 2 more sessions of ovarian cancer and precision oncology. And it starts at around 10 o'clock. So see you all tomorrow. Thank you so much.